How was the break, ladies and gentlemen? I hope you all now are getting more excited for our first main agenda, Keynote Lecture 1, Biomedical Research and Primary Care, Transformation in Pandemic Era. The session will be moderated by Dr. Danasari Vidyawati, Master of Science, Clinical Med, Family Med, Primary Care Family Doctor Specialist. Dr. Danasari finished her study as a medical doctor in 1990 at the Faculty of Medicine, Universitas Indonesia. She then finished her doctoral program in medical science, Universitas Indonesia in 2014, and also finished her magister program in clinical med, Family Med, University of Philippines. Now she is currently active as a lecturer at Community Medicine Department, Faculty of Medicine, Universitas Indonesia. Without further ado, please welcome Dr. Danasari Vidyawati.
Thank you very much, Alisa. Thank you very much, Master of Ceremony. Good morning. Have bless you in this bright morning. We together in this Eyes of IMERI conference. And before we start with the plenary, I would like to tell you about what is our plenary speaker this morning, because in this primary care transformation, comprehensive aspect need to be tackled in healthcare services. This COVID-19 pandemic proved that not only clinical aspect, but also the education aspect, family and social economic aspect, peer and community aspects needed in primary care services. Okay, taken as a whole, health-related behavior influence health outcome in individual as well as community level. So those features should be supported by competent healthcare workers working together in an effective system. So together with sport medicine specialists, family medicine specialists conduct the seminars and workshops in this 6th International Conference of IMERI of Learning from COVID-19 Pandemic on the importance of physical activity, how is the transformations in primary care services. And this bright sunshine morning, together with us, Dr. Gede Wirabrata, S.Si, apotheker, Magister of Kesehatan, Magister of Management, Magister of Health, as Director Pelayanan Kesehatan Tradisional Kementerian Republik Indonesia, will tell us about what is Ministry of Health view about primary care transformations in pandemic era. Thank you very much for your attention and time for us, Dr. Gede Wirabrata. We would like to hear you as the plenary speaker this morning. May time and also appreciate for you to start your speech. Thank you.
Thank you, moderator. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Good morning, salam, om swastiastu, namo buddhaya, salam kebajikan. Honorable Dean of Faculty of Medicine of University Indonesia, the Chairman of Indonesia Medical Education and Research Institute, IMERI, Professor, the speakers, ladies and gentlemen. First, apologize from the Director General. He has urgent task. I will ask to present. A very good morning to all of you. I would like to say that it's been a great pleasure to meet all of you, the 6th Annual International Conference and Exhibition on the Indonesian Medical Education and Research Institute. It is a wonderful opportunity to me to share what we done on the primary care transformation during the COVID-19 pandemic era, especially on the telemedicine in primary healthcare services. Please slide. Thank you. This slide, we have a present health challenge. Our health outcome still lags versus other. Life expectancy, death birth in 2018, and maternal mortality, infant mortality rate. We look the graph. This is the situation from Indian. I got tuberculosis, the second burden in the world, and 6.63% the death are contributed by NCB disease, higher than C over, more than 60%, 30% of population age 15 years are smoking. Please slide. This led to the movement of Indonesia reform health sector. There has never been a more opportune time for health transformation. The COVID-19 has made healthcare the number one priority. And look at the step, the pandemic need a strong healthcare resiliency. Indonesia health system is ready from the transformation. This is look the situation, the right momentum. Our BPJS continue to grow and expected covering more than 98% of population by 2024. Digital health technology are more commonplace and the population is already on the embrace and change. Please slide. This is a slide about the health system transformation. 5 national midterm developed goals, RPJMN, and 6 pillars of health transformation. The vision we are looking at this slide. Key programs of category of primary healthcare transformation are population education, promotion and champion and education program, primary prevention, such as vaccination, immunization, province of health, meal in school, secondary prevention, health screening, iron booster tablet to reduce anemia, chronic disease management, increase capacity and capability of primary healthcare, such proximity on primary and community-based care facility, quality of services, gateway to secondary gate. Slide. Yes, this is the comprehensive health promotion and education. We have immunization counseling, nutrition counseling, sport counseling, anti-smoking education, environmental sanitation and hygiene education. This is the prevention. Early detection, disease screening education. For the treatment, there is a counseling. This is the target of every German. The teenager, 10 until 18 years old. This is the teenager smoking. You can see the number decreased until 2024. Population more than 18 years of obesity. Right now, 21.8%. I think it is this constant number until 2024. The current under the routine immunization, this slide, from 12 to 14 types of vaccine through Indonesia. Cervical cancer is type of cancer with the second higher number of sufferers in women in Indonesia and ranked third from cancer death. The only cancer that can be presented by immunization in human papillomavirus, SPV, pneumonia, and diarrhea are two of the 5 highest causes of under 5 mortality in Indonesia that can be prevented by immunization. PCV, pneumococcal conjugate vaccine, rotavirus, it can be used from the program. This table look at the Indonesia, India, Japan, Cuba, UK, and USA. The comparison, the situation of the kind of vaccine. Slide. Ladies and gentlemen, this is an expansion of the screen in primary care. The left side column, age of target, death causes, screen type. Right now, 2025 regulation and preparation and socialization, this transparency regulation, and 2022, we have target 30% and more 100% target in 20 and 24. The expansion of screening in primary healthcare, FGMI health priority screening, we have a problem, stunting and wasting, maternal death. This is the antenatal care program, increased from 4 to 6 services. At the last 2 done by the doctor using the ultrasound USG before 24 weeks of pregnancy. We have target until 2024 is 95%. Slide. This is the situation of Indonesia. We have mapped 161 sub-district have no puskesmas, but we have built the puskesmas in the Pemda, they call it Pemda. In 3 years, puskesmas will be built. 67 puskesmas of 2022 until 2024, 44 puskesmas, all of Indonesia, Sumut, Kepri, Sumsel, Kaltara, Sulteng, Papua Barat, and Papua also. Slide. The conclusion. First, COVID-19 pandemic is the right momentum to reform health sector. Primary healthcare plays an important role in the transformation of the health sector. Primary healthcare transformation aims to increase access and quality of health services. Primary healthcare is the best way to deliver prevention, can be created significant impact on healthcare outcomes. Primary healthcare transformation are focused on population education, primary health prevention, secondary prevention, and increased capacity and capability primary healthcare. Thank you for this session. I believe that the conference and exhibition of Indonesia Medical Education and Research Institute will bring a lot of motivate, innovation, and productive view in the health sector, especially in transformation of primary healthcare services. I wish you all success and thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you.
Dr. Dansari.
Thank you very much, Pak Wira. Okay, so we can see on the presentations how the Ministry of Health increased the target of screening and of all aspects in primary care. Because you are on behalf of the Vice Ministry of Health, may I ask you that you received the question from the audience, sir? We understand that you have a very tight schedule, Bapak Wira, and thank you very much that you still have time, small time for us, and then we will continue our program this morning. Thank you very much, Bapak Wira, and keep healthy.
You're welcome. Thank you very much.
Okay. So this is the end of the first plenary for this morning.
How was the break, ladies and gentlemen? I hope now we have recharged our batteries to prepare for our next session. Panel discussion 1, the future of telemedicine after COVID-19 perceptions of primary care. Now for this session, we have Dr. Arya Kekali, MD, MTI, PhD as the moderator. Dr. Arya Kekali finished his study as a medical doctor in Universitas Indonesia at the year 2004. He then finished his magister program in information technology in Universitas Indonesia and doctoral program in nutrition science Universitas Indonesia. Now he is active as a lecturer at Community Medicine Department, Faculty of Medicine, Universitas Indonesia. For Dr. Arya Kekali, the floor is yours.
Thank you, Alicia. Can you hear my voice? Okay. So thank you for the committee to plan the implementation of this plenary session. So I think this is a very interesting topic. Yeah. Today we will have a panel discussion about the future of telemedicine after COVID-19, the perception of primary care. Alicia has introduced me as a doctor and also a practitioner, yeah, because I have a bridge of the IT and the medical practice. Nowadays, we have a momentum of implementation of the telemedicine, especially in this pandemic. Yeah, because we have some regulations regarding to COVID that must have a consultation using the telemedicine. So this will be a very interesting panel discussion. We have three distinguished experts, yeah, resource persons. First, we have Dr. Kalsum Komariani. She is the head of the Health Coverage and Financing Center in the Ministry of Health, Indonesia. I want to send a greeting. Hello, Dr. Kalsum, are you here?
Yes, good morning, everyone.
Yeah, good morning, Dr. Yani. So I can call you Dr. Yani, Doc. Thank you for being present here. It's a very honor to have you here in this session. And also we have Dr. Budi, Professor Dr. Budi Wiwiko. Prof, are you here? Hello, Professor Prof. Iko. Okay, maybe he's preparing. And we also have Prof. Purnawan Junadi. Prof. Purnawan, are you here?
Yeah.
Oh, thank you, Prof.
Nggak pakai video ya, because
thank you, Prof.
banyak orang di sini.
Yeah, it's okay, Prof. So for the first chance, I will give the time to Dr. Kalsum Komariani. So as a background, he is a medical doctor from Universitas Indonesia, and she is also have education as the School of Planning and Policy Development in the University of Southern California. The current position now, she is the acting official director for primary healthcare services, and she will present about the telemedicine regulation in Indonesia. The time is allocated for 5 minutes, Dr. Yani, so I will remind you if you exceeded the time allocation. Please, Dr. Yani.
Yes, thank you. Good morning, everyone. Good morning, distinguished speakers and distinguished participants. Allow me to present the telemedicine regulation in Indonesia. Maybe I should introduce myself. Actually, I was the director of health financing and health insurance. But since October 14, I moved to director of quality of health services. And also, I am now the acting director of primary health services. Next slide, please. So currently in Ministry of Health, due to the pandemic, we are starting to revise our strategic plan because we believe that the pandemic was tested our health system. So that's why we try to transform in 4 themes. The first one is how to strengthen the primary care. And the second one, how to providing quality and efficient care, especially for referral care. And the third is the resilience of pharmacy, or the readiness to prepare the health emergency. And the fourth is the enablers, how to strengthen the financing, the health financing, the health human resource, and also the health technology as well. And I think telemedicine is related to provide in primary care and referral care. Next slide, please. So there are 2 types of telemedicine concepts. The first one is telemedicine hospital-based. This is inter-healthcare facilities telemedicine. And Ministry of Health is providing an application. We call it Feminine. And the second one is telemedicine community-based. This is telemedicine between the community and health facilities. And we also have the application is we call Healthpedia. Next slide, please. So there is some there are some important things when we do telemedicine, because telemedicine means an expansion of health services. So every doctors who will conduct telemedicine should have registration and licensing, and also should comply the standard operational procedures. It means the telemedicine also related to the competence and authority of the doctors, and which facilities that provide the telemedicine. Next slide, please. About the regulation, now under the Ministry of Health, we launched the ministerial regulation number 20 by the year 2019. This is the telemedicine between among the facilities, because we are facing the problem for the health delivery of health services in the remote area. So that's why we need to develop the telemedicine from facilities in the remote area. They can provide consultation to the regional hospital, provincial hospitals, and national hospitals. But unfortunately, until now, this regulation is not implementing optimally because after that we are facing the pandemic. And then I think during the pandemic, we are also thinking about we need to provide the telemedicine, because under telemedicine, we can monitor the patient that self-isolation at their home, and also to give the medicine. So that's why there is a ministerial decree number 4829 by the year 2021. This is replacing the circular letter from Minister of Health number 303 in 2020. This decree is regulate how to giving monitoring from the doctor to the patient, and also the giving medicine, the pharmacy to the COVID patient. Next slide, please. So the benefit of telemedicine, I think, as you may also know, for the health workers is to solve the communication that limited in some time in some area, and for the referral system, reduce referral rate, and for the financing, I think it is obviously will increase efficiency, and for the education is how medical education can placing, and for the diagnostic, this is to overcome the delay of diagnostic result, and the last one is for the monitoring under the telemedicine, we can facilitate patient monitoring. Next slide, please. So I think,
yeah.
Yes. I think,
Actually, the 5 minutes is
have,
over, but you can accelerate your presentation, please.
Okay, thank you. So I just want to show the audience about the Temenin application. This is the telemedicine inter healthcare facilities. We have tele-echocardiograph, teleradiology, tele-ultrasound, and clinical consultation. So I think in the future, we still need the telemedicine inter healthcare facilities. And second one, to the next slide. Next slide, please. Oh, this is how the hospital facilitators to giving telemedicine under Temenin. And my last slide is my conclusion. Telemedicine is not limited for remote area, but also I think we can use it under the pandemic, and we believe in the future also under the JKN program we can provide telemedicine, but now I think we're still waiting for the regulation. That's all my presentation. Thank you. I offer to you, Pak Moderator.
Thank you, Dr. Yani. That's a very interesting yet a very brief explanation about the update for the regulation and implementation of the telemedicine under government management. So the next resource person is Prof. Budi Weweko. Yeah, he will give the overview presentation regarding the user's perspective and telemedicine innovations. Because our topic here in the perception of primary care, despite Prof. Budi Weweko is a OBGYN specialist, but I see that in your presentation you already prepare the overview, not only in the specialist perspective, but also in the GP, and also in the patient. So, Prof. Iko, are you there?
Yes. Yeah. Thank you very much.
Yes, Prof. Iko. So I will introduce you. I think Prof. Iko is already well known, but I will try to introduce his background again. He's a doctoral program from UI and Magister of Public Health, and also from since 2018 as a professor in OBGYN. But he is also the chairman of the National Health Technology Assessment, vice director of the IMERI, and also the past president of the Aspire, Asia Pacific Initiative of Reproduction. So we allocated 5 minute time for presentation. Prof. Iko, please proceed.
Yes, thank you very much, Mr. Chairman. So I'd like to continue our discussion this morning regarding the use of telemedicine and my perspective from the user perspective. So I think it is mandatory if we look, this is the data from United States, that at least almost 75% that the company corporate over telemedicine to the workers in 2016. And we know this is one of the platform or virtual or telemedicine services which was established by National Health Services in UK. I think it's already been used over 1 million populations. And we can see here the affiliate patients actually must wait 13 days to see their NHS GP in person. However, with the use of virtual GP, it will help them a lot. And then what's happened in our country? This is, I think, one of the biggest platform of telemedicine in Indonesia. Over 5 million people already downloaded the platform of Halodocs. And this is also, I experienced also to use the Halodoc platform in communicating with my patients. And also we use the Zoom platform in RSCM, especially in my clinic, in fertility clinic, Yasmin Clinics. And this is very important things for me as a user of telemedicine or teleconsultations. That very important things that the patient engagement. So that's why we should prepare. It's very good to make the patient engage with us. So the communications, we can build the trust, and also we can build the empathy during make the teleconsultation. I think this is very important. And this is also the very interesting experience from American College of Obstetrics and Gynecology. There is the special important notes, now the law, and then security. It means also that the obstetrician and gynecologists in US, they should have healthcare insurance regarding the use of telemedicine, and also license, reimbursements, malpractice insurance. This is very interesting. That's very important notes regarding the use of telemedicine, as also mentioned by Ibu Yani before, and might be Professor Purnawan also will explain regarding this kind of issue. And also it is very interesting how the American College of Obstetrics and Gynecology make a coding for telehealth and other remote services. You can see here, telehealth visit. They all have a coding for reimbursement by National Health Insurance, remote patient monitoring, virtual check-ins, and I think it is very interesting. That's why this is my analysis regarding the use of telemedicine. That was very important. That we should actually empowering the patients. The data also is very interesting. The use of data, and then the use of electronic health record, regulations, and also training and education. Not only for the healthcare provider, but also for the patient itself. And this is one of the examples, the use of telemedicine in empowering the patients to check the follicle growth in doing test tube baby programs. So the patients was teach to use the ultrasounds, and then they can measure the follicles diameter and then report to the gynecologist. And then I think that the future might be the use of artificial intelligence must be mandatory. It is quite important to address our limitation in physical examinations. I think Huawei is one of the corporate or private company that very ready, they have a very good platform of telemedicine that enhanced by the use of artificial intelligence that we can see in these figures. And then also, if you talk about the new technology, the blockchain, hospital information exchange is very important. The use of electronic health record, and then data storage, and then we can make a hospital information exchange if we use the telemedicine, and also with the good electronic health record as well. And I think the last, it is very important, a nice quote from CEO of American Telemedicine Associations, that actually right now, the healthcare should be just as convenient, accessible, and safe as online banking. So that's why no wonder that we should use the telemedicine anywhere in Indonesia to improve, to increase access and quality, and also should be regulated by ethics, legal, and professionalism. And the use of AI, it will help us a lot in the future. And then this is the platform that ensure the safety, confidentiality, access, and affordability. Okay, Dr. Arya, thank you so much.
Thank you, Prof. Iko. So it's a very interesting presentation, and regarding your, there is a statement that telemedicine must be as secure and as accessible as online banking, Prof. Yeah, so
Right.
it's a very interesting statements, and we want to explore about that implementation of this is from the practitioner of the telemedicine. We have the information direct from the chairman, the director of the Indonesian Telemedicine Alliance, TANSI. So Prof. Purnawan Junadi, he's a medical doctor from University of Indonesia. He finished the master degree from the Michigan Public Health University, and he also have a PhD from the University of Michigan. But here we will have a very important perspective from him about the way that the role of Indonesian Telemedicine Alliance, TANSI, in the implementation of telemedicine in Indonesia. So please, Prof. Purnawan, are you ready?
Ya, terima kasih ya. Slide-nya dari Anda ya. Jadi saya lihat kan nggak ada orang Barat nih, adanya orang Sumatera Barat, Jawa Barat, ya kan, Nusa Tenggara Barat mungkin ya. Oke, tadi my slide is in English. Ya, jadi video maaf anak saya pakai juga untuk belajar sekolah nih Sabtu ya, jadi nggak bisa kita bagi bandwidth ya. Jadi saya nggak ini, nanti kalau tanya mungkin lebih ini. Oke, jadi saya ganti istilahnya menjadi telemedicine development karena kita masih di area pengembangan telemedicine ya. Ini apa yang seperti permintaan moderator, jadi kita cerita tentang role of atensi ya. Terima kasih. Next slide please. Jadi saya memang chairman of atensi, kebetulan juga chairman dari BKK di CBD di ID, sekretaris dari Anderson Medical College, and ada alasannya juga kenapa saya di Indonesia Anti-Aging Association. Next slide. Jadi sebenarnya kalau menurut saya pionir telemedicine itu Pak Jokowi ya, Presiden, karena dia yang dengan jelas menyebut ya pada bulan April itu ya sebelum pandemi bahwa Indonesia has hospital without wall. Jadi telemedicine ya. Jadi dianjurkan orang untuk tidak ke rumah sakit langsung, tapi bisa menggunakan telemedicine. Itu dampaknya jelas sekali ya, dalam 3 bulan itu aplikasi atau user itu naik hampir 600% ya, dari 4 juta ke 15 juta gitu ya. Terus next slide ya. Jadi saya ingin menyatakan bahwa telemedicine bukan kompetitor nih, orang masih suka melihatnya sebagai kompetitor, sebenarnya kan enabling. Ya, ada khususnya di bidang pandemi itu dan enriching ya. Jadi karena kita juga meng-cater tidak hanya patient tapi juga healthy patient. Jadi orang sehat, orang yang berpikir dia sehat dan orang sakit ya menggunakan kita, dan kita bisa refer bekerja sama dengan primary care atau juga referral care ya. Nah, memang tentang penyakit-penyakit tertentu, penyakit-penyakit akut, penyakit kronik yang berulang kan gitu, yang sebenarnya tidak perlu ke dokter gitu. Next slide. Oke. Nah, atensi ini sebenarnya punya tujuan, jadi kita memang ada anggota individual ya, ada juga institusi ya, orang bilangnya startup, kita bilangnya PLT, jadi pengembang layanan telemedicine ya, sampai sekarang itu naik jumlahnya terus ya. Dan ini tidak hanya dokter, it's not a doctor. Jadi ada dokter, ada ahli IT, ada ahli hukum tentang telemedicine ya. All we oversees all of them ya. Sehingga di bawah kita ini ada yang melakukan complete, ada yang melakukan home services, ada special services gitu ya. Tujuannya sebenarnya adalah kalau keluar tentu kita ingin membantu ya menjadi alternatif atau complementary atau tadi enriching, enabling ya, sehingga Indonesia, status kesehatan Indonesia bisa menjadi lebih baik. Tapi secara internal kita ingin agar orang-orang yang bekerja di bawah kita, organisasi itu juga mempunyai standard of care ya. Jadi supaya semua PLT yang di bawah kita itu punya standar bagaimana melayani pasien, bagaimana melayani macam-macam ya. Termasuk di dalamnya itu adalah confidentiality dan juga kerahasiaan pasien dan juga keselamatan pasien. Next slide. Nah sebenarnya memang pandemik ini blessing in disguise untuk telemedicine dan juga untuk atensi. Saya kasih lihat gambar selanjutnya, next slide. Jadi kan 13 bulan April itu Pak Presiden menyatakan kita pandemi. Ya. Tapi sebelumnya, next slide. Ya, jadi kita sudah menduga itu ya, karena memang kan sebenarnya sudah ada gejala dari Wuhan itu ya. Sehingga pada bulan Maret kita bekerja sama dengan M.Kes untuk membuat MOU, ya kan. Jadi itu persis 1 bulan sebelum dinyatakan pandemi. Dan kemudian memang BP POM sendiri juga sudah menyiapkan diri menghadapi pandemi sehingga keluar aturan BP POM ya tentang bisa menggunakan resep tidak hanya obat bebas tapi obat keras ya, kecuali narkotik dan yang psikotropik ya. Jadi sebenarnya itu bisa dilakukan menggunakan telemedicine. Kemudian kami setelah berunding itu keluarlah surat edaran tadi ya tentang telemedicine tanggal 29, jadi 2 minggu setelah dinyatakan tadi pandemi, dan dalam itu juga keluar aturan dari Perkonsil ya. Kita sendiri meskipun sudah bekerja sama tapi resmi sebagai institusi itu baru bulan Mei ya. Dan kemudian pada bulan itu keluar ya aturan dari MKK tentang bagaimana telemedicine itu bisa dilakukan dengan prinsip seperti di rumah sakit. Misalnya harus mempunyai komite medik, harus segala macam persis seperti rumah sakit ya. Next slide, terus. Nah kita tahu di gelombang kedua kan, jadi itu terjadi di kira-kira di bulan Juni itu. Tapi kita juga sudah melakukan, kita sudah berdiskusi juga persis sebelum mau gelombang itu kedua ya. Dan kita menghadap kembali ke M.Kes bahwa kita perlu mempersiapkan ini ya. Jadi tanggal 5 Juli itu kita dapat MOU dengan M.Kes soal mengenai isoman, jadi isolasi mandiri. Nah persis 1 hari kemudian ya kan Pak M.Kes mintanya seminggu, tapi ini karena sudah dipersiapkan 1 hari kemudian. Memang seminggu sebelumnya kita menghadap ke Pak M.Kes ya, sehingga minta supaya keluar aturan dalam 1 minggu ya. Jadi kita bisa lihat bahwa pandemi ini juga merupakan blessing untuk disguise dan juga blessing untuk telemedicine karena semua menjadi dipercepat. Kami sekarang ini juga akan melakukan MOU kembali ya, karena kita bersiap diri terhadap gelombang 3 ya. Mudah-mudahan tidak terjadi ya. Tapi kita sudah mempersiapkan MOU dengan self isolation ya dengan M.Kes ya. Jadi itu peran kita dalam pandemi ini. Silakan, next slide. Nah, kita sudah melakukan ini ya, jadi teleinformasi di itu terus, next slide. Digital training, next slide. Home services ya, next slide. Rapid test ya. Drive thru, next slide. Drive-thru vaccination juga ya. Jadi ini hal yang kita lakukan ya dalam rangka telemedicine. Dan pada bulan April itu kita sudah melakukan, kalau dilihat itu secara bulan itu artikel kita dibaca oleh 5 juta orang. Kita juga menangani 5 juta orang dalam bulan ya. Kemudian juga ada berbagai resep dan sebagainya. Next slide. Ini tadi statistik dari M.Kes ya. Akhir tahun yang lalu kita menyelenggarakan survei ya oleh UNDP dibantu kepada 30 PLT dan ini hasilnya ya. Jadi kita bisa lihat bahwa sekitar 20.000 dokter terlibat ya di dalam 30 PLT itu ya, dan sekitar 7.000 spesialis, jadi dan 2/3-nya itu dokter umum ya. Memang kita masih menjangkau kota-kota besar ya, kami melihat kebanyakan memang adalah wanita 63% itu ya. Lebih banyak ibu-ibu yang mengakses memang ya dengan telemedicine ini ya. Next slide. Jadi mungkin yang terakhir itu ya di bulan Juli itu mungkin yang perlu dicatat pengembangan telemedicine itu adalah kerjasama 4 sistem informasi. Ini yang luar biasa. Jadi ketika suspek itu dikirim ke sekitar 700 lab ya, memberikan hasil PCR negatif atau positif. Kalau negatif, kalau positif itu dikirim ke kita ya, startup, dan kita menyiapkan kalau perlu telekonsultasi, teleedukasi, dan resep ya. Resepnya ini sesuai juga dengan apa yang kita sepakati. Resep itu dikirim ke sistem informasi kimia farma untuk dipersiapkan obatnya, dan dari situ dikirim ke si cepat untuk drug delivery ke rumah pasien. Jadi Anda bisa lihat ya, pasien tidak perlu keluar rumah ya, dari mulai dia PCR, mendapat obat, mendapat telekonsultasi, teleedukasi, dan obat diantar ke rumah. Saya kira ini luar biasa terjadi ya, dampak daripada pandemi menyatukan sistem informasi yang besar gitu. Next slide.
Izin Prof, waktunya sudah lewat.
Ya, oke, baik. Jadi ini kita tolong, ini adalah market growth-nya 60%. Next slide. Dan juga reduce consultation cost by 40%. Next slide. Ini saya kira hampir habis juga. Next slide. Oke, ini terakhir ya. Jadi masa depan kita sudah mulai ada nih spesialis medical virtualis. Ya, ini sudah terjadi di beberapa negara gitu. Terima kasih.
Baik, terima kasih Prof. Purnawan. Sangat menarik sekali ya dari Prof. Purnawan sebagai direktur dari praktisinya langsung ya. Dan tadi ada suatu data dari UNDP yang menyatakan keterlibatan. I need to speak it in English. I'm sorry.
Yes.
So Prof. Purnawan already present about the involvement, yeah, not only in the increase of involvement of users, but also the doctors who involve, yeah, and the PLT. The PLT is the telemedicine implementer, yeah. So I think this is a very good momentum for us. But we have the questions from the audience, and the red line of the question is talking about the security issues. Yeah, the security issues. So I think this is very interesting because we do not have we do not want any breach in the security, because this is very, very vital informations. And for that, I want to have the perspective from the three expert here, three spoken person here. So maybe first I want to have the perspective from the physician. Maybe Prof. Iko can share something about the security in the perspective of the physician who give the consultation, Prof. And then we will have the perspective from Prof. Purnawan from the atensi, and also from the last is from Dr. Yani from the regulator from the ministry. Please, Prof. Iko. Yeah, if Prof. Iko still having a problem, technical problem, maybe we can.
Saya aja dulu boleh.
Yes, Prof. Purnawan, please.
Pak Budi ya, jadi now we trust the online banking system. Ya, Anda bisa transfer uang 200 juta tanpa lihat uangnya, tanpa menggunakan cek, ya kan? Anda trust itu tidak akan disalahgunakan. Nah, kita kalau dalam PLT itu ada dua yang aturan yang kita harus sepakati. Aturan dari M.Kes, ya, tadi STR, ya, SIP, kemudian juga aturan-aturan seperti di rumah sakit, dan juga aturan dari Kominfo, ya, tentang tadi online, ya. Dan itu harus disepakati ya. Jadi itu kalau nggak bisa berdiri itu PLT. Jadi kerahasiaan itu pasti itu ya di dalam pengembangan layanan telemedicine. Cuma it takes time for people to trust ya. Tapi seperti online banking lah akan terjadi juga ya. Saya kira begitu aja. Everything takes time.
Yes, Prof.
Yeah.
So I think so the way that we have a learning curve to to accept the way that online banking work, I think it will have the similar process also that we eventually, finally, we will accept about the telemedicine, because we have the same platform, the same security platform, just like Prof. Iko mentioned before. We need to, just like the online banking, So, Prof. Iko, do you have any comments, perspective about the security issues?
Yes, thank you very much, Dr. Arya. Of course, the security is becoming the most important things in telemedicine, and also not only in telemedicine, I think, but also in all field. If we talk about the health data, the security, so that's why. If we want to have to enhance the telemedicine services in our country, of course, number one, that we should ensure that the data is very secure. The data means that the clinical data that was stored in the telemedicine providers. The some issue very important is who will be responsible for this data, and then to whom the data belongs to, and then who can access this data, and then also how the corporate, the healthcare, the telemedicine provider regulate the sharing, the data sharing and data access. I think this is a very important thing that should be regulated by the government.
Thank you, Prof. So yes, I agree with that. The complexity, the system who already involved in this telemedicine system is or need to maintain the security, but not those component who related in this telemedicine, not only the provider, but also the patient, and the most important, the doctor themselves.
Yes.
They need to understand the security protocol.
Correct.
Okay.
Because the data is, we know that big data is new oil in medicine and health. Yes.
Okay. Before I want to confirm to Dr. Yani, I want to, because we have the question also from the audience, Prof. Purnawan, I need to back to you again. Regarding the security, do Atensi implement the standard not only for the provider, but also to the doctors? You know that we have thousands of doctors already involved here. Do they need to have like a tutorial practice or standardization to use the protocol, the platform before they involve in the telemedicine, Prof?
Jadi kita kan baru berdiri, dan itu yang kita inginkan. Jadi internal, we would like to have the same standard, no, not the same standard, minimal standard for PIT for startups, how to they conduct the services, Di samping memang ada ketentuan dari Kominfo bahwa misalnya server harus di dalam negeri, harus di-encrypt dengan yang terkini kan gitu. Sehingga breaching itu highly impossible lah, meskipun namanya hacker ya bisa aja tetap kan. Pentagon aja bisa di-hack bagaimana kita kan gitu kalau mau ya. Lalu kita mesti mengikuti juga aturan MKK, because MKK sudah mengeluarkan aturan, jadi setiap PLT harus punya komite medik. Dan kalau ada persoalan harus didiskusikan seperti inilah audit seperti di rumah sakit dilakukan setiap minggu kan gitu. Nah itu tujuan kita Atensi supaya semua punya memastikan ya semua punya itu. Cuma memang kan ada PLT yang sudah grown up seperti Halodoc, tapi ada yang baru just 2 doctors, 3 doctors Pak. Jadi just this year gitu ya baru berdiri tahun ini. Jadi kita bilang begitu ya. You have to have the standard, the minimal standard ya gitu.
Yes, so
saya kira begitu.
So to translate that, so Prof. Purnawan just say that as Atensi, as the Association of Telemedicine Providers, they has the standard, to that must be complied, must be fulfilled by the telemedicine provider. But some of the provider is already mature, but some is just grow. So we need the process, but the standard is there, and I think Atensi is a very good institution, or maybe collaboration here, the institutional body to control the telemedicine provider in the next. But I think we need to have a closing remarks about from the Dr. Yani as the regulator from the Ministry of Health regarding the security, regarding of the growth of the telemedicine. Dr. Yani, do you have any perspective or recommendation about how should we maintain this momentum, Dr. Yani, please?
Thank you. I think we cannot define the growth of the telemedicine because there is a demand from the people who seek the health services and under the pandemic era, and also maybe under the technology era. I think in the future this telemedicine is not only is used for the pandemic, but also is used for better or maybe to accelerate the access from people to the health facilities. And I do strongly agree with the security and the safety of implementation of telemedicine. I mean, the security is like all the information system. We should to protect the security of health information of our telemedicine system information, and also the safety. We have to ensure that the health providers is a registered doctor, and also they have licensing. And the last one is also we have to conduct the medical report as similar to the patient that they get services from health facilities as well. Thank you.
Thank you, Dr. Yani. So I think that's wrap up of our session here. I think it's a very good discussion, and I think it is a very good momentum for us to maintain this the hype, the hype of not only the doctors, not only the patient, but also for the telemedicine provider. We are well supported by the Ministry of Health and also the Ministry of Information. So I think we can maintain this. Don't worry to use the telemedicine. We can maintain, and we can maintain the standard. And like Prof. Iko and Prof. Purnawan said before, we will accept this as the way that we accept the online banking. Thank you, everyone.
Dr. Arya, I think one word.
Yes, Prof.
One sentence. I think telemedicine is must for Indonesia. So
indeed,
improving
Prof. I agree.
access and quality of health services. And then please don't be hesitate to adopt and adapt the technology.
Yes, we are a growing market. We have a very spread geography. I don't think if we don't do this, for the foreigner will come to interference. So I think we have to be the master of the telemedicine on our own country, Prof.
Yes.
Okay, so thank you, everyone.
Welcome back, ladies and gentlemen. As mentioned before, in Hall A, we have Concurrent session with topic Genomic Diversity, Evolution, and Therapeutic of the Pandemic COVID-19 Disease in Indonesia. The session will be moderated by Mrs. Linda Erlina, Bachelor of Pharmacy, Magister of Pharmacy. Mrs. Linda Erlina finished her bachelor's degree in pharmacy, Universitas Pancasila, in 2013. Then in 2016, she finished her magister program in pharmacy, Universitas Indonesia. Currently, Mrs. Linda Erlina is active as the junior researcher of Bioinformatics Core Facilities Cluster, Indonesian Medical Education and Research Institute, Faculty of Medicine, Universitas Indonesia lecturer. Please welcome Mrs. Linda Erlina.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Good morning for Honorable Director of IMERI, Board of IMERI, Head of Core Facilities, Head of Research and Medical Education Cluster of IMERI, Dean, Vice Dean, and Managers for Faculty of Medicine, Universitas Indonesia, Honorable invited speakers, Ziliang Chen, PhD, Dr. Destiani, and Dr. Irandi Putra Pratomo, PhD, professors, doctors, and all distinguished participants. Let me introduce myself. I'm Linda Edina, and I have a great honor to be moderator for concurrent session of Bioinformatics in the 6 Eyes on IMERI today. First of all, I would to welcome you all, ladies and gentlemen, and to our concurrent session with the topic Genomic Diversity, Evolution, and Therapeutics of the Pandemic COVID-19 Disease in Indonesia. Today, we have 3 awesome speakers. And then in the session, we have invite 3 awesome speakers to deliver their talk with the topics. First, Illumina Informatics Solution. Second, persistent symptoms sequelae in post-COVID-19 discharge and genomic variant related to PASC. And the third, phylogenome sequencing for defining reinfection with COVID-19. Each speaker will be deliver their talk in 20 minutes, and after that, we will continue to the panel Q&A session with the duration about 15 minutes. If the participants have any question to the speakers, please kindly write your questions in the chat box or YouTube comments. Okay, before we start the first presentation from Ziliang Chen, PhD, I will read her short curriculum vitae. Ziliang Chen, PhD, graduated as Bachelor in Science Bioinformatics at Shanghai Jiao Tong University in 2007. She got her PhD degree at University of New South Wales in 2012. Now she has position as a Senior Bioinformatics Sales Specialist in Illumina. Okay, then we will continue to listen Ziliang Chen's PhD pre-recorded presentation with the title Illumina's Informatics Solution for COVID Surveillance Applications.
Good morning, everyone. My name is Ziliang Chen. I'm an Executive Bioinformatics Sales Specialist from Illumina. I'm based in Australia. Today, I will be talking about Illumina's informatics solution for COVID surveillance applications. I'll be starting with an introduction to Illumina, followed by looking at the important role next-generation sequencing is playing in identifying
for the committee, maybe the voice
then finally,
is not here yet.
I will talk about Illumina's effort in creating bioinformatics tools and resources in this pandemic. So let me start with an overview to Illumina. In case you don't know who Illumina is, we are a genomics company, meaning that we create tools for researchers and clinicians to look at genomes. So what can we do by knowing your genome? Genomes can give you insight into predisposition and symptoms. Understanding the genome can help inform proactive health management and lifestyle choices. It can suggest conditions for which your children may be at risk. It can guide you on drug choices, and it can provide personalized choice and care. So we serve many areas from oncology to genetic disease to non-invasive prenatal testing, population genomics, and also
Mbak Kresna or Mbak Rita, can you repeat it again because I didn't hear any voice for Ziliang Chen PhD presentation.
In April 1998, that's where we founded as an array company, and this is actually in line with the project of the Human Genome Starts, which starts in 2003. In 2006, we acquired Solexa. This is the foundation of our sequencing technology, and we have taken off since. And a few key milestones. In January 2014, we have announced the HiCX, which has bring down the cost of sequencing human genome from millions of dollars to a bit more than $1,000. And in January 2017, we introduced the NovaSeq 6000, and this is the platform that brings us to the path to the $100 genome. And in January 2020, we have introduced the latest technology, which is NextSeq 2000. And this has brought us the new sequencing by synthesis technology and super resolution optics to further bring down the footprint of the instrument and the cost of sequencing. So what Illumina has done in providing a unique advantage to fighting a pandemic like COVID-19, the Illumina technology has enabled novel pathogen identification and characterization. We have helped in diagnostic testing, and sequencing technology has helped in pathogen monitoring and global surveillance. And by sequencing the host genome, we can also look at the host genetics and immune responses. And also, we have helped many companies in drug and vaccine development by doing sequencing. So during the pandemic, we have launched Illumina COVID-Seq platform, which is enabled on NovaSeq 6000, NextSeq 2000, and the NextSeq 500, 550, and the DX series. So we have provided a flexible and scalable COVID-19 pandemic diagnostic assay for using clinical testing laboratories. So what we have done in the front line of the COVID-19 pandemic, so since the start of January 2020, Illumina technology was used to identify the new virus that causing the COVID-19 in China. And by October 2020, this virus has increased the risk of co-infections, and Illumina technology has been used to look at the serious impact on mortality rates and to see whether it will add to the burden of the hospitals and are already facing. And in December 2020, again, Illumina technology has helped to identify the highly infectious variant of SARS-CoV-2 strain, the B.1.1.7, identified in the UK. And today, the risk of new mutations creating new variants and their impact is alerting the scientists to look at diagnostic tests and the vaccine efficiency. So let's take a detailed look of why we want to use sequencing in identifying new variants in this pandemic. So the next generation sequencing technology is actually transforming outbreak detection and epidemiology. M.Kes has provided a genome-wide strain typing in the molecular typing method. And also by sequencing different variants and strands, we'll be able to identify outbreak clusters and transmission routes. And also by having all the sequencing data available, we'll be able to easily transform data into insights. For example, we can identify the pathogens and the genotypes, not only the SARS-CoV-2 that we are looking at the moment. We can look at co-infections and other bacterial and viral strands that happened that may cause another pandemic. And also, we've been helping the clinical laboratory to look at antimicrobial and antiviral resistance. And by looking at the bacterial and viral genome, we'll be able to understand the virulence of those genomes. So the genomics-based epidemiology empowers the strain-level tracing that it's definitely needed in any of the outbreak detections. So how does genomic surveillance data help the response to the COVID-19? By understanding the genome and the outbreak clusters, it helps support allocation of resources. It helps prepare local, state, and federal institutes to respond to the emergency. And also, by knowing the details of the genome, it accelerates the development of more therapeutics and diagnostic. More importantly, by doing the surveillance testing, it allows the government agencies to rapidly implement policy for prevention. I'm going to take the B117 and the B1351 strand as an example. These two strands are the novel virus lineages that we identify using the Illumina technology during the pandemic. And these two strands require broader and routine surveillance and make the scientists aware that we require broader and routine surveillance to manage COVID-19. And also by looking at these new emerging lineages, FDA was able to warn healthcare providers of risk of getting a false negative result with certain molecular tests. So the B117 strand originally was found in UK and it's known as the Alpha strand. And now late 2020 it was found in many countries, and then because of one of the deletion regions in the S gene, and it causes S gene dropout in the PCR test, so it was missed by many PCR tests at the very beginning. And also another example is the South African strand. It's the B351 strand, and also it has got another deletion which caused a false negative rate in the PCR test. So if we have missed those strands in the PCR test and then we didn't do a surveillance sequencing, those viral lineages will be able to develop with unusual high number of mutations, and the pandemic will be out of control. So this is really important, that apart from doing the traditional PCR test to understand whether the virus is present, and also we need to do routine surveillance testing and doing the whole genome sequencing to be able to understand the new mutations and whether they have spread out to the other part of the world. So what Illumina has done, apart from developing the assay that can detect the virus, we also developed a series of tools and resources on the bioinformatics part. As we all know, by just getting the raw results, you won't be able to interpret the result. So analysis is playing a really important role in understanding data. So looking at the ecosystem of the analysis tools, there are actually many available apart from the ones that we have developed to our platform. So there are tools that are publicly available on the website that many academic users and researchers will be able to use that. For example, the NCBI pathogen detection website. And then there are also other tools, for example, Rust, that you can use to understand and characterize the genomes of your interest. There are some tools that might need a bit more on the computer science side, that you need to be able to run some command line tools to further use the tools. For example, PROCA, this is a very famous one to interpret the genome. So in terms of doing analysis, what we usually do with microbiology, we can start with assembly if you don't know what you have sequenced. After that, you can do genomic characterization, for example, annotation, virulence, analysis, antimicrobial resistance analysis. And also you can do comparative genomics analysis and put that into phylogenetic. So there are many things that you can do, but we also understand many of the microbiologists, virologists, they would like to have access to a very simple platform that they don't need much of the command line skills or understand of the tools to be able to know what they picked. So what Illumina has done is we have developed a platform which is called Base-Based Sequence Hub, and we actually support upload directly from our instrument to a cloud-based platform, and you'll be able to run a lot of analysis on the platform. And also it allows sharing and collaborating, meaning that you will be able to share directly from this platform to your collaborators, and or even upload to GenBank and upload to GISAID to deposit your findings. And on our platform, we have a broad range of applications for secondary analysis. So here what I listed is just some examples of what you can do on base-based for microbiology analysis. We also have developed a platform called Dragon, which is a hardware-based accelerated secondary analysis. You can do a lot more than microbiology analysis, from germline to somatic to many other things. But what we did is actually we combined the powerful Dragon with our cloud-based base-based analysis platform, that we have developed a series of tools that can enable from shotgun metagenomics analysis to enrichment-based assay to the COVID-6-based assay, which is amplicon-based, that you can do different type of analysis on base using the Dragon hardware-based accelerated platform. Then you'll be able to analyze your sequencing results and get the answers, and to submit to GISAID, and then also submit to S.Si. So what we have developed, we called SARS-CoV-2 NGS Starter Toolkit. We have the COVID-6 apps, which is specifically for the COVID-6 assay that we have developed for our NovaSeq and the NextSeq platforms. And we also have the COVID lineage app, which supports variable of read lengths and some other library prep protocols and all the other smaller benchtop instruments. Enables analysis of data from any Illumina sequencer. And also we have the a combined COVID pipeline and COVID lineage tool to be for anyone that doesn't want to run on the cloud, that we also supply a Dragon local server. Then it works similarly to the COVID-6 app and the COVID lineage app that is compatible with the Illumina instrument and library prep. And all those tools are free of charge, and we hope to provide the ecosystem for any researchers that want to look at the SARS-CoV-2 sequences and to be able to analyze their results. So what our SARS-CoV-2, the COVID-6 app does is actually a complete analysis from analysis to reporting, and it takes many samples at the same time. For example, the 3,072 samples that we support on the NovaSeq, and from demultiplexing the raw data to mutation identification and give you a report on the viral detection. And also our tools gives you the FASTA file that can be used with other open source software tools. For example, Pangolin, which is the commonly used tools to assign lineages of SARS-CoV-2 from the FASTA file. And also Nextclade, which is built by Nextstrand for you to assign phylogeny of SARS-CoV-2 sequences from the FASTA file. So we have actually built these tools into the COVID lineage tool. But also, if you would like to just use our COVID-6 test app to get the FASTA file and use it on your own open source tools, it's definitely welcomed to use. So in this, we create our own ecosystem, and also we have created the flexibility for any researchers to be able to do their own tertiary analysis. So this is the end of my presentation, and I would like to use a quote from the World Health Organization to end my talk. Sequencing enabled the world to rapidly identify SARS-CoV-2 and develop diagnostic tests and other tools for outbreak management. Continued genome sequencing supports the monitoring of disease spread and evolution of the virus. Accelerated integration of genome sequencing into the practices of the global health community is required if we want to be better prepared for the future threats. Thank you.
Okay, thank you so much for Zhidiang Chen, PhD, for your great and very comprehensive presentation. We will move to the next presenter, Dr. Destiani, PhD, as a specialist of pulmonology. I will read her short curriculum vitae. Dr. Destiani, educational background is a medical doctor, and she completed her study in master program in occupational medicine at Universitas Indonesia in 2003. And in 2013, Dr. Destiani finished her pulmonology and respiratory medicine specialist education at Universitas Indonesia. Her current position now is Vice Dean of Academic and Student Affairs, Faculty of Medicine, Sultan Ageng Tirtayasa University. I would like to invite Dr. Destiani to present the second topic. Please, the floor is yours.
Thank you, Ms. Linda. May I share screen my slide? No?
Yeah, yes, please.
Yeah, can see my slide? Okay, thank you for this opportunity. I have a presentation topic from committee with the title Persistent Symptoms Sequelae in Post-COVID-19 Discharge and Genomic variant related to PASD or post-acute symptomatic or sequel COVID-19. Assalamualaikum warahmatullahi wabarakatuh. Good morning, all participants in this meeting. I hope all of you in this are in a good health and full happiness. Allow me to present this topic. This is my outlines. Maybe I have to slideshow first. Sorry. Yeah, we will discuss about introduction. And the second, we will discuss about persistent symptoms, sequelae in post-COVID-19. And the last is a human genome variant related to PASD. Yeah. From the introduction, as we know, the novel virus severe acute respiratory syndrome coronavirus 2 resulted in global pandemic of COVID-19 and still an ongoing global pandemic. Yeah, it quickly spread to around the world, and the World Health Organization declared a public health emergency of international concern on 30 January 2020 and the pandemic on 11 March 2020. Classic cases of acute COVID-19 characterized by respiratory symptoms such as fever, cough, shortness of breath, and also this is this most symptom finding in this patient gastrointestinal problems. And patient can present with a wide range of other symptoms, including neurological symptom, especially in central nervous system involvement. Okay, in this slide, we can see COVID-19 cases and present of long post-acute and post-acute sequelae of COVID-19. This case range is length and severity. So many patients are symptomatic, while and the others required hospitalization and also need ventilation devices. Average cases case of COVID-19 last between 1 or and 4 weeks, and across the globe, some patients who sustain an acute SARS-CoV-2 infection develop a wide range persistent symptom and do not resolve until 9 months. And several studies reveal that the COVID-19 patient follow up this persistent symptom up to 9 months. And the after illness found that approximately is about 30% reported persistent symptom. And this patient we call with long COVID. This is a familiar definition. And also we know about the post-acute COVID-19 syndrome. It's the same name to long COVID and post-acute sequelae of COVID-19, or PASG. This most common symptom remaining from one study. This is a cohort study with suspected and confirmed COVID-19 cases. We can see remaining symptom after month 7, with the prevalence is up to 30%. And the most symptom in this study is fatigue. This involves so many multiple organs, and several symptoms in this in all patients. In persistent symptom patient COVID-19 is such as fatigue, post-exertional malaise, brain fog, select sensory motor symptom, headache and related symptom, memory problems, insomnia, muscle ache, speech and language, shortness of breath, joint pain, tachycardia, tightness of chest, and other sleeping symptoms. This is my study, unpublished but already accepted in Health Science Report Journal. About 127 from 201 patients. It's about 63.18% patient reported having experienced sequelae. And from 127 patients, sequelae were reported by 61 patients aged between 18 to 39 years old. And 63 patients, 49.60%, age 40 until 64 years. Okay. Sorry. Yeah. Post-acute sequelae COVID-19 diagnosis in patient can develop severe acute COVID-19, but also in patients who experience only mild or asymptomatic cases, not just from mild or asymptomatic cases, but also from moderate and severe cases. Another study reported a range of long-term symptoms in cohort confirmed and presumed COVID-19 patient whose acute symptom would not manage without the need for hospitalization. Maybe this patient is treated in home and be self-isolation and treatment from primary healthcare. Study by Huang document persistent COVID-19 symptom in 1,400 subjects with confirmed SARS-CoV-2 infection. It's also about persistent COVID-19 symptom. This is post-acute sequel COVID-19. As we can see, the symptom include fatigue, muscle weakness, insomnia, palpitation, chronic rhinitis, dysphagia, chill, sore throat, and headache. About 20% from all subjects reported persistent symptom after 60 days. And the patient age about 50 years, comprising 72% cases. Woman is more likely to report persistent symptom than men, and 30% subject reported symptom at 61 days after infection. This is summary of the long COVID, or this is summary of the post-acute sequel of COVID-19. It involved so many organs such as cardiovascular, acute coronary disease, heart failure, palpitation, arrhythmia, and respiratory system such as cough, shortness of breath, low blood oxygen, and kidney, acute kidney injury, chronic kidney disease, musculoskeletal such as joint pain, muscle weakness, and also general side malaise, fatigue, and anemia. It involved too with mental health, such as anxiety, depression, sleep problems, nervous system such as stroke, headache, memory problems, health problems, and metabolic endocrine such as obesity, diabetes, high cholesterol, gastrointestinal such as constipation, diarrhea, acid reflux, and skin disorders such as hair loss and coagulation disorder, blood clots. Yeah, pulmonary sequelae such as decreased exercise capacity and hypoxia. This is commonly persistent symptom and signs. Reduced diffusion capacity, restrictive pulmonary physiology, and we can find ground glass opacities in radiological descriptive and fibrotic changes on imaging. This is note at follow-up COVID-19 survivors. Assessment of progression and recovery of pulmonary disease and function. This is including home pulse oximetry, maybe everyone or every family in all over the world and also in Indonesia. This is familiar device. Yeah. 6-minute walking test, pulmonary function test, high resolution compute tomography of chest, and compute tomography pulmonary angiogram. This is as clinical appropriate in this case. How management long COVID in primary care? As we can see, if a person or patient with symptom 3 or more weeks after COVID-19 onset, we have to make investigation about blood tests, about other investigation, such as chest X-ray, and then we managing comorbidity. Many patient comorbidity including diabetes, hypertension, kidney disease, and this is clinical assessment. We have to take full history and current symptom. We have to make and assess the patient, temperature, heart rate, blood pressure, respiratory examination, functional status, pulse oximetry, and clinical testing, and assess comorbidity, and also assess social financial circumstances, because prolonged COVID-19 may limit the ability to engage in work and family activities. And do not forget to assess mental health in this patient, medical management, and self-management in a patient with self-isolation in their home. And also we have to safety netting and referral if this patient worsening, so we have to refer to a hospital. The patient should seek a medical advice concern, for example, worsening breathlessness, oxygen saturation is less than 96%, and unexplained chest pain, new confusion, and focal weakness. I do not forget, and the last management is pulmonary rehabilitation. This is indicated if patient has persistent breathlessness following review. Okay, this is post-acute sequelae management and rehabilitation. Managing breathlessness, exercise after leaving hospital, managing problem with your voice, managing activities of daily living, managing eating, drinking, and swallowing, managing problem with attention, memory, and thinking clearly, managing stress, anxiety, or depression. SARS-CoV-2 evaluation. This is the second our discussion. Identifying candidate genomic site that may confer phenotypic changes. Virus acquired genetic changes and most acquired genetic changes do not substantially affect virulency or transmissibility. A variant of the virus between virus genome sample from different location cannot be assumed to cause observed epidemiology difference in COVID-19 between those locations. And despite this, it is possible that a genetic change may occur that causes a corresponding phenotypic change in SARS-CoV-2 of public health important. How about certain human genome variant may facilitate PAST development? The unique human gene harbored by a given PAST or post-acute sequelae COVID-19 patient may predispose to how environmental insult, including infection with SARS-CoV-2 itself, able to drive disease and potential chronic symptom. An important research consideration for PAST cases is identification of specific human genome individual variant whose activity may be particularly detrimental for environmental and base sequelae also implicated in development of PAST. Okay. And genetic variant in innate immune components such as manus binding lectin-2 and toll-like receptor plays central role in the immune system ability to recognize viruses such as SARS-CoV-2 and also initiate an early immune response to fully clear the pathogen. And if we find COVID-19 patient harbored is a detrimental manus binding lectin or toll-like receptor genetic variant, they may consequently be a higher risk for PAST symptom resulting from possible persistence of the virus in tissue. This is deep whole genome sequencing and genetic variations among the patient. In this study, 322 patients identified a total 22 million variants, including 70.9 million biallelic single nucleotide polymorphism, 1.75 million and 2.45 million, and the average transition ratio is about 2.12, and the proportion heterozygote versus homozygote variant among all the sample is about 1.29, consistent with statistical expectation and indicate good quality of variance calls. About 261 of of those variants were uniquely presented in COVID-19 patient and have not been previously reported in the 1,000 genome and genome AD studies. And average each patient possesses about 343 predicted loss of function variant in the genome. This is descriptive about deep whole genome sequences and genetic variation among the patient. We can see this is deep whole genome sequencing and genetic variation among the patient. The picture of A picture is sequencing distribution, and B you can see proportion and number of types, and proportion and number of functional consequences of genetic variant among the patient, pedigree gene discovery, and mutation burden associated tests of loss of the function between the severe and non-severe patient. And the last is allele frequency distribution for all missense and loss of function variant placement in S2 and CRMPSS2 genes. Okay, even found that gene CCL2, interleukin 1A, interleukin 1B, and matrix metalloproteinase 9 show fold changes after in human primary bronchial epithelial cell after exposure to the viral spike protein. CCL2 chemokine associated with pulmonary inflammation and extensive lung involvement in SARS patients. And CCL2 suppress the proliferation of myeloid progenitor cells, leading to lymphopenia in both SARS and MERS patients. And the last matrix metalloproteinase 9 works as an activator or active enhancer or signaling molecule like cytokine or chemokines, and it expressed at low level under psychological conditions, and this regulation lead to the development of pathological conditions. This is take-home message from this topic. The individual nature of PASD symptom also mean that different therapeutic approach may be required to best treat patient with a diagnosis. Identification individual human genome that may augment environment-driven contribution to PASD would bolster such an effort, because a wide range of biological factors may contribute to PASD development. Research on patients with PASD diagnosis must involve collaboration between teams with a wide range of skill set, including pathology, virology, immunometabolism, neuroscience, and physical therapy or rehabilitation. And overall, an individualized treatment approach to PASD could contribute to a growing era and personalized and predictive preventive global medicine. Yeah, thank you. Yeah, thank you for your attention. Miss Linda, yeah.
Okay, thank you, Dr. Destiani, for the excellent and nice presentation about persistent symptoms, sequelae in post-COVID-19 discharge. Okay, we will move to the last speaker, Dr. Irandi Putra Pranomo, PhD. I will read his curriculum vitae. Dr. Irandi has a background medical our last speaker, Dr. Irandi Putra Pranomo, PhD, specialist of pulmonology consultant, is a medical doctor at Universitas Indonesia. In 2017, he got PhD in biomedicine at Hiroshima University, Japan. And in 2018, Dr. Irandi finished his clinical pathology specialist program at Universitas Indonesia. In 2020, Dr. Irandi PhD got his consultant of pulmonologist, and now Dr. Irandi is a lecturer at Pulmonology and Respiratory Medicine Department, Faculty of Medicine, Universitas Indonesia. He became also chief of pulmonology medical staff at Universitas Indonesia Hospital and coordinator for COVID-19 high care unit at Universitas Indonesia Hospital. I would like to invite Dr. Irani Putra Pratomo, PhD, to present the third topic. Please, the floor is yours.
Thank you, Mbak Linda. Assalamualaikum warahmatullahi wabarakatuh. Is my voice is clearly heard?
Yes, very clear, Dr. Irani.
Okay, I will begin the presentation. Now, can you see the slide on my presentation, right?
Yes, I can see it clearly.
Okay. Let's begin. So, thank you for the floor. There is a change of title since actually the proposed title from the committee is from the other presentation that serves as the main question for our topic today. So the topic will be finding COVID-19 reinfection throughout SARS-CoV-2 genome sequencing. So in the previous lecture, we already heard the presentation by Dr. Desdiani, mainly from the side of the patient, from the human side. Now I will present from the virus side regarding its genome sequencing. So we will begin from the COVID-19 reinfection questions, and then we will move to the genomic profile of the safe virus and how genomic sequencing could help, and also we will end the presentation by take-home message. So the reinfection question itself, already questioned by the CDC of the United States, that it's already been reported, but remain rare, even in the global scale, and of course in Indonesia. Up until now, maybe we only, or maybe under report for the case of reinfection, but I would say that the question about COVID-19 reinfection, how likely the reinfection will occur and how often, and also how soon after first infection can reinfection take place, and how severe are the case of infection, and also how about the risk, and how about the immunity, and also how should the reinfection could be spread. These are the questions that yet to be answered, at least up until August 6, 2021. So this is the actual question that previously was destined to be the topic of our presentation, but I prefer that this to be remain the main question because the reinfection itself, the definition is not well established. As you can see in the slide, the symptom-free period is maybe required with a negative PCR result between two positive PCR results. But was it caused by persistent viral strain or maybe another different strain? But how to define the difference between these strains? Because we need to know the number of different nucleotides, and so we can rule out the mutation chains. That could be answered maybe by viral genome sequencing. And also we know that the fact that PCR may only detect system remnants or maybe fragments, and maybe would get confused because of delayed viral clearance. So right now, let us refresh the condition, the profile of the SARS-CoV-2 virus. The virus itself is belong to the beta coronaviridae family, and it is positive single strand RNA virus. The size itself is between 27 and 32 kilobase pairs, And I would like to highlight the non-structural proteins. You can see in the left side of the graphic, we have viral protease, the 3CL and PL, and also RNA-dependent RNA polymerase, the RDRP. And the next group is the structural proteins, the spike protein, the S, membrane protein, M, envelopes, small membrane protein, the E, and nucleocapsid, the N. And in one of the reference, we know that we already detect the many variant, the many SNP or single nucleotide polymorphism that could acid. We highlight this from the structural protein, from the envelope, spike, membrane, and the nucleocapsid. The spike itself in this table was divided into two sections, the NAB and RDB, the receptor binding site. How about the condition between the animal and also between human? So we can see here, this is the situation of all of the structural protein. You can see the profile here, how much the frequency of the mutation between the SARS-CoV original from the SARS in beginning of the century, and also the SARS-CoV-2, the one who responsible for COVID-19. And we saw here there are so many variants, but maybe the conclusion would be the most genomic variation part of SARS-CoV and SARS-CoV-2 is it binds to human ACE2 receptor, and also that means very crucial in the virus host selectivity and infectivity. Which means also the least mutation in RBD means a catastrophic effect on the human host, because the RBD itself is very important for the binding between the virus and the human side. But was it only the problem here? Maybe we need to recall also the protein S condition. You can see here. Maybe our concern during that time was the conversion of D614G, the change of aspartic acid into glycine in the position of 614 in the S1 domain of protein S. There is, in consequence, the structure of the protein S itself is allowing the RBD component, we can see here, into up position, which more increase the infectivity, because it is more possible to connect with the ACE2 binding, you can see here. So the mutation itself will allow the up position of RBD. In contrast, if there is no situation of SNP mutation, the protein S is more stable. But the other side condition maybe is more infectious compared to the non-mutation or the wild type. But in fact, this is the SNP that is collect between the, already the strains from alpha, beta, gamma, delta, lambda, and mu. You can see change into G or glycine. So maybe it's no longer significant, because almost all the variant of concern is already have the G614 right here. So we need to focus on other condition, which one who could actually responsible for the increased infectivity of SARS-CoV-2. We need to recall about the definition of variant of concern right here. We can see, you can read yourself in WHO website. We already familiar with Delta variants. We have many naming type here. Pangolins, Giset clade, Next-strain clade, ATC, but the change that is we need to understand is this one. The position in proteinase change of 417 into N. This begin from India in October 2020. And this is the variant of interest. The only thing that we need to know that maybe lambda and mu is very potential to be variant of concern, because the former VOI currently designed it into 5OC. You can see here is delta. So the chance is may happen. Maybe inevitable, but may happen. And in Indonesia itself, we can see here in the G-shape repository, there are increase of Delta variant beginning maybe around February or March 2021. Compared with the global situation, we almost the same. Or this is Asian and also global. In contrast, we see the Alpha variant, the original one, is decreasing. Maybe the peak is almost the same with the beginning of the Delta variant. And the situation from Indonesia itself, the Alpha variant increase was maybe zero additional casing, almost 90% in past 4 weeks as of August 2021. So we need to still be concerned about the Delta variant and also the other variant of interest that would maybe change into variant of concern. And we see here the change is getting stable. You can see that maybe in the previous slide that the D614G at first time maybe it may emerge into another mutation or maybe another more severe disease. But the fact is, the condition is getting stable. We can see here, for instance, the temporal geographical residue variation of the D614 spike. At the beginning, maybe the mutation rate is very low, but it's getting increased. Only took 6 months, and that means it's getting stable. And we will expect for another single nucleotide variation that will increase its mutation rate. In this case, maybe we should forgetting the D614G for our focus of topics. We need to look at another SNV through another locus. And how genome sequencing could help for this situation. So again, the CDC of the United States already create some kind of limitation or maybe definition on how the SARS-CoV-2 reinfection should be. So individuals with COVID-19-like symptoms with a positive RT-PCR with a CT value of less than 33 at least 40 days after the first positive RT-PCR. You can see here the CT value for the clinical relevance. I'm the one who is against the use of CT value in predicting the patient outcome. But this is a laboratory side of the use of CT value. I have my own experience that for the genome sequencing, maybe the relative CT value of less than 30 is usually not running good during the genome sequencing. So this is more a technicality, not for the clinical reason. Okay. And next, the paired samples from the same individual from the 2 episodes includes the evaluation of single nucleotide variation in class to distinguish viral persistent within host evolution or another reinfection. So we need to differentiate between old and persistent infection and also new infection by single nucleotide variation and clade. And here are the common investigation protocols. So right here, this includes diagnostic testing of available specimen from listing episode, already explained in the previous slide. The objective is to answer our question from the beginning of this presentation. How about the frequency? And how about to characterize the case and resulting laboratory evidence? And how about the time interval from initial illness to reinfection? Next question will be the frequency and the duration of RT-PCR positivity and shedding. And maybe in another opportunity, we'll discuss about the serologic response to reinfection. The answer may be using the genomic testing and also serial antibody determination and evidence of active viral replication in another discussion. So this is the prioritized person. There are two main category on how the person should be considered as reinfected or not. The first is prioritized person with detected RNA for more than equal to 90 days since first infection. With the, you can see the required requirement in the slide, and also the second one, the person who is considered with COVID-19 like symptom and detection between 45 and 89 days since first infection. So if we comply to this situation, I hope that we can actually define the reinfection of COVID-19 by proof through the genome sequencing, as will be, I will tell you about three references that I am about to deliver in this presentation. Okay. And this is the ideal genomic testing that is more than 100 per base position and Q-score consensus of more than 30 with 99% of the genome covered and 100 times average genome coverage for analysis of minor variation. And of course, removal of amplicant primary contamination from assembly. This is the standard. And this is a few recommendations. First, the use of high fidelity sequencing platform with Q-score pre-30 preferred for consensus generation. I think this is a very high requirement. But if we only have low fidelity sequencing platform of Q-score of less than 13, verification of SNP by alternate sequencing method is encouraged. So we need a high standard for the genome sequencing for SARS-CoV-2. And the CDC also categorized the evidence into 3 levels. The first is the best, the moderate, and also poor evidence. The different clades are defined in next strain or G-shape between first and second infection, coupled with other evidence of actual infection, for instance, high viral titers, or maybe serology, or maybe culture. So at least from this category, we also have the best evidence they need from the CDC is compare with the next strain or GSET as the repository. You can see the other category here, maybe from the website CDC itself. And next, we see at least 3 cases of how the infection can be studied by genome sequencing. This is from a patient. Her first infection is from April 19, and the second one is June 5th, 2020. And between those tests, there are 2 negative tests in May 2020. The genomic sequencing showed genetically significant difference between each variant, and this is the timeline. And we see here the maybe the method, test methodology, RT-PCR between specimen A in April and specimen B in June. He also, the author also checked for the immunology value here, not for the clinical reason, but for the technicality for laboratory. And the genomic sequencing here against the reference genome from MN 908943, I think it's from the GSAID one. You see the variant between the A and the B. And of course, we saw here the G614. And we also other location. And from this, the author concluded previous exposure does not necessarily translate to guaranteed total immunity, because they are hypothetically there is reinfection. And at this one, the patient showed increased symptom severity in the second infection. I will explain in the next case.
Dr. Irani,
very
I'm
high
sorry
dose of
for the
virus
time.
might have led to second instance of infection and induce more severe disease.
Okay, I'm sorry. I think Dr. Irandi has a technical problem with his internet. So maybe we can move to the Q&A session. I would like to check in my chat Zoom. There is one question from the participants for Ziliang Chen. What are the differences between amplicon and enrichment method for SARS-CoV-2 sequencing? Which one is better and feasible to apply if we have a large number of samples? Dr. Ziliang Chen, are you here?
Hello? Hello?
Hello, Dr. Irandi. Do you have any
Yes.
unstable connection for your internet?
It's connecting. I think it's connected. Should I return to my presentation or? Hello?
Maybe you can give a take-home message to us to close your presentation, please.
It's not already finished. Okay.
Okay.
I will miss. Okay. Can you see the presentation?
Okay, Dr. Irandi, maybe you have 1 minute to finish your presentation. Thank you.
Hello?
Yes, Dr. Irandi, we can hear your voice.
Okay, the situation. Okay. So the take-home message. Okay, I was asked to skip another case. We can discuss it in another situation. So genomic-wise and by human host factor, the reinfection could either caused by two distinct strains or from a prolonged viral infection. So that we need to consider the strain diversity by checking the mutation rate and also threshold of difference, which is not yet to be well defined. That's why we need to comply the available group and genomic benchmarking, for instance, maybe from the US CDC. So from the whole genome sequencing investigation, let's just focus maybe outside the structural protein gene, which condition, which the location of mutation could happen other than, especially in the S protein. Okay, thank you very much. I will return to Mbak Linda.
Okay, thank you so much, Dr. Irandi, for giving us the insightful topic about viral genome sequencing related to reinfection COVID-19 cases. Okay, we will continue to the Q&A session. First question is for Ziriam Chen, PhD. Do you still with us?
Yes, I'm here.
Okay, thank you so much. What are the differences between amplicon and enrichment method for SARS-CoV-2 sequencing? Which one is better and feasible to apply if we have a large number of samples?
So there are different ways to look at that when you say which one is better. In terms of workflow, amplicon is usually easier for anyone who is new to NGS because it actually requires less technique and also less lab equipment to do it. For the enrichment method, the advantage is sometimes if you have other species to, sorry, I'm in the car. So if you've got other species to look at, that would be beneficial to use the enrichment method because you can also look at species other than the only SARS-CoV-2 that you're looking at. But if you've got a large number to look at, I would definitely recommend the amplicon sequencing, especially if SARS-CoV-2 is the only thing that you're looking at. And also, I would like to mention that Illumina's COVID-6 assay that is actually designed to, for example, it supports more than 3,000 samples in one of the NovaSeq run, and then that is a feasible way to look at a large number of samples at the same time, and the turnaround time is about 30 hours. So that would be a good application to look at if a large number of samples and short turnaround time is something that any lab is looking at.
Okay, thank you so much, Williamson, for your answering. Okay, and then I have a question for Dr. Destiani. Based on your experience, what are common symptoms that occur in a PASC patient, and how do you apply the management and rehabilitation program for the patient? Thank you.
Yeah, thank you for the questions. Most symptom finding in the clinic, in polyclinic, and also in daily practice is fatigue and and also shortness of breath. It's depend of the patient condition. Maybe some patient talk to us to the doctor that he felt so many symptoms about 1 month until 2 months until 3 months. Maybe just they felt that the symptom is occur in several hours in a day, and maybe in morning, maybe in evening, maybe in afternoon. So many variant, so many symptoms, so many variant problem, and so many variant age from patient. Yeah. This is a unique symptom, I think, because I have a patient with the persistent symptom or sequel post-COVID-19 almost 1 year. And he, because this is a male patient, he still come to my clinic and always said that my shortness of breath is never improved. I refer to rehabilitation medical clinic specialist, and also in cardiologists, and also in internists, but didn't improve because I just know he has a problem with mental. So do not forget to assess mental health problem and traumatic in the patient, because this problem is most and more important than clinical or about the multiple organ failure, about the organ problems, because the mental health problems, the key point for patient with persistent symptom post COVID-19. That's all. Thank you.
Okay, thank you, Dr. Destiani, for your answer. And then we will move to the next question for Dr. Irandi. If Indonesia facing the third wave of COVID-19, is it represented by new variant of SARS-CoV-2, or how we will prevent it? Oh, I'm sorry. I think Dr. Irandi is lost his connection again. So I will continue to Dr. Destiani.
Yeah.
I have got COVID several months ago, and I think I have a parosmia until now. I got COVID in July 2020, and now I have parosmia, but not fully parosmia, just partial. It's like that.
That's a problems in all patients. So we have to make management and rehabilitation in whole sector, managing breathlessness, exercise, problem in mental health, just also in eating, in drinking, in social life, and lifestyle, because the symptom in persistent symptom post COVID-19 for treatment is just symptomatic, and also as I mentioned before, we have to pay attention with mental health problems, because almost patient COVID-19 traumatic, very traumatic with about their disease. Okay. Yeah.
Okay, thank you, Dr. Desiani. Dr. Irandi, are you with us and can hear my voice clearly? Dr. Irandi? Dr. Irandi, sorry. Dr. Irandi, can you hear me?
Yes, voice is very clear, but
Yep.
Do you have any question?
Okay, I have one question for you.
Can you hear my voice?
Oh yes, I can hear your voice. Okay, so this is a question
Yes,
for
I can hear you clearly. Can you hear my voice?
yes, Dr. Irandi. So there is question for you. If
Yeah, I just
Indonesia,
stop the video. Okay, let's try.
yes, yeah, I think it will improve your connection.
Yes.
It looks good, Dr. Irandi. Okay. If Indonesia facing the third wave of COVID-19, is it represented
Can you
by
deliver the question?
new variant of SARS-CoV-2 and how we will prevent it? Oh, okay. I think Dr. Irandi has lost his connection again.
Okay, sorry, I was disconnected.
Okay.
Can
You join
repeat
us.
the question? Yes.
Okay. If Indonesia facing the third wave of COVID-19, is it represented by new variant of SARS-CoV-2 and how we will prevent it?
Maybe this is more like a rhetorical question because we haven't got any decisive condition that may lead to mutation of the SARS-CoV-2. So basically, the only one that we could do to prevent the further mutation is to limit the spread of the virus, regardless the genomic or the mutational profile, is by doing the social distancing and also using the mask and also clean our hands. It's very basic. We don't need very complicated scientific proof to explain that at least those three simple gestures, but very essential for our survival during these hard times. And in the meantime, of course, scientifically speaking, we will still looking for the great better evidence on how which one of the SNP or maybe the variant that would be very easy to spread to something else. Because even the Delta variant in our country, somehow you can see it decreasing itself. Either the transmission rate or maybe the severity of the disease. So there are certain things that yet to be explained there, and then also we need to keep certain space for any other possibility. So the only thing that I can say right now that we have to stay social distancing, keep out from the crowds, and also wearing masks and also washing hands. Thank you very much.
Okay, thank you so much, Dr. Irandi, for your explanation. Because the time is up, I will summarize our first concurrent session today. Sequencing enabled the world to rapidly identify SARS-CoV-2 and develop diagnostic tests and other tools for outbreak management. Continued genome sequencing supports the monitoring of the disease spread and evolution of the virus. The individualized nature of PAC symptoms also means that different therapeutic approach may be required to best treat patients with the diagnosis. Identification of individual human genome variants that may augment environment-driven contribution to PAC will bolster such an effort. Genomic-wise and by human host factor, reinfection could either caused by two distinct strains from prolonged viral infection. Whole genome sequencing investigation such as nucleotide variant detection outside the structural protein gene further required to control the SARS-CoV-2 evolution. Okay, that's all from me. Thank you so much for all invited speakers, Ziang Chen, PhD, Dr. Destiani, and Dr. Irandi for giving us an insightful talk today. Thank you for all the 6 eyes-only IMERI committees. Thank you for all distinguished participants. I close this first concurrent session and give it back to the MC. Thank you and good morning all.
All right, now is the time for free communication 1. This first free communication will be moderated by Dr. Indah Suci Widya Hening, M.S. Master of Science, Med Family Med PhD. Dr. Indah Suci Widya Hening graduated from Universitas Indonesia in 1997. In 2000, she finished her postgraduate program in Occupational Health and Safety, Universitas Indonesia, and continued her study, graduated as Master of Science, College of Medicine, University of Philippines in 2002, and PhD Clinical Epidemiology, Utrecht University in 2016. Currently, she is active as a research coordinator of the Community Medicine Department of the Faculty of Medicine, Universitas Indonesia, National Board for the Enhancement of the Primary Care Physician Education, and National Experts Committee on the Control of Non-Communicable Disease. All right, without further ado, please welcome Dr. Indah Suci Widya Hening.
Okay. Thank you very much, Alisa. It's a nice introduction. And I would like to welcome all the participants, the presenters for this session. Yeah, that you and also I would like to congratulate all of you because you are selected, yeah, as the best 6 presenter to be presented in this session. So as a moderator, I would like to invite. There will be 6 presentation today, and I would like to invite the first presenters, Joshua Viventius, Dr. Joshua. Okay, and it will be presented in the form of video. So maybe I would like to ask the committee to play the video, and we can watch it together. And then after that, it will be continued with the question and answer session. So please, committee, please play the video for the first presenter.
Hello everybody, my name is Joshua Viventius. I am from Medical Culture Specialist Program, Faculty of Medicine, University of Indonesia. Thank you for the opportunity given to me so that I can be a part of this discussion. And now I will start my presentation entitled Occupation Physics Self-Care for Hyperemesis terlebih dahulu during the COVID-19 pandemic. As we know that most pregnant women, about 50 until 90%, generally experience nausea and vomiting during pregnancy, which subsides at 16 until 20 weeks of gestation. About 0.5 until 2% experience severe nausea and vomiting, called hyperemesis terlebih dahulu, which require hospitalization. Hyperemesis terlebih dahulu is characterized by persistent nausea and vomiting, psychosis, weight loss during pregnancy, also overweight. The impact of hyperemesis terlebih dahulu on pregnant women and infants includes psychosocial disorders, electrolyte imbalance, preeclampsia, and more perpetuates within time. Acupressure has been developed by the Ministry of Health of the Republic of Indonesia, among others by implementing Vascular training without the technology for my complaints. Acupressure is defined as stimulation of acupuncture points by utilizing pressure techniques and mechanical techniques. The purpose of acupressure is to obtain a functional response to the body that can be used to cure the disease. There are several methods to stimulate acupuncture points with the pressure, including using elbows, fingers, feet, knuckles, palms, thumbs, or special tools, such as swords, wooden balance surface, etc. According to the workshop session, pressure is very safe, and but still needs attention to the patient with blood clotting disorders, the use of anticoagulant drugs, stress factors, and factors in elderly patients. How did acupressure work? Acupressure works by activating the slowly myelinated nerve fibers in the muscle and transmit the stimulation to higher nerve levels, like spinal cord, brain, hypothalamus, and pituitary axis. Acupressure stimulation also activates hormonal complex involving the hypothalamic pituitary adrenocortical axis to produce cortisol, which causes the relaxation. Acupressure increases the endorphin and serotonin secretion to the brain and body organ. Acupressure also stimulates the release of nitric oxide, which increases local microcirculation. Generally, acupressure can play a role in reducing tissue adhesion, increasing body relaxation, increasing blood circulation, and improving the parasympathetic system. Next, I will explain about the patient of the acupressure point. The point used in this case is P6 network, which is anatomically located on the anterior part of the forearm between the palmaris longus and flexor cardialis tendons. You can see this is the P6 point, and the patient is 3 fingers proximal to the wrist. Stimulation of the P6 point can be done by pressing massaging about 20 until 30 pressures. The strength of the pressure consideration if 1/3 of the nerve become lighter. The strength of this pressure is adjusted when using a blunt tool. Acupressure at P6 point can lower the hyperemesis gravidarum by influencing the gastrointestinal function, inhibiting cerebral cortex function through nerve stimulation, which can cause and reduce the dementia activity. The Indonesian Ministry of Health has trained 2,000 doctors and healthcare providers. The doctors, as person in charge now, will screen the patient, and the research will be done by healthcare providers. This is the education material that can be used also. There are multimedia, visual, media, and tools. If the visual method, you can see in the book. The Indonesian government has established a national priority program to improve public health status and reduce maternal mortality and mortality rates. There is an increase in the tendency of traditional herbivores and center of business. The acupressure program is one of the components in healthcare community. Hyperemesis gravidarum can cause maternal mortality. Healthcare acupressure is one opportunity that can be done during the COVID-19 that can be done in yourself to be healthy through healthcare acupressure. So you can help each other to be healthy by keeping your difference. The acupressure healthcare program is one of the components in healthcare community health. The location of P6 point is easy to define, so that it is easy to be understood by everyone because to perform healthcare acupressure. The safety of acupressure healthcare at point P6 can be accounted for by for the conclusion, acupressure on P6 can be considered to reduce the hyperemesis gravidarum so that the maternal mortality rate and infant mortality can be also decreased. Acupressure is relatively safe and can be done by everyone, especially with the Okay.
Okay, yeah, it's a very interesting presentation, yeah, Joshua, Dr. Joshua. However, I would like to ask whether there's already a randomized control trial on the effectiveness and safety of the acupressure as a treatment to manage the problem.
Okay, thank you, Dr. Indah. Can you hear my voice?
Yeah.
Okay, yes, thank you. Yes, there was a systematical review that used the acupressure for treat the hyperemesis cervidalis, and also the acupressure technique is a safe technique that we can use in provide to reduce the symptoms of the hyperemesis cervidalis. And in that systematic review, the result was good. So we can try to use the acupressure as one of the method to improve the hyperemesis cervidalis symptoms, I think. We can search the literature in the Google Scholar, and it also indexed in Scopus, Doctor.
Yeah, but I mean, how is the quality of the research involved in the systematic review? Is it a randomized control trial, or is it another type of another design? And how many studies that is included in the systematic review? And so maybe you can help us to understand more.
Okay. Sorry. Okay, thank you. Usually the research that had been done in acupuncture was a randomized control trial, and we can search in the internet or the scholars that the acupressure is one of the type that we can use in hyperemesis cervidalis.
Okay, thank you, Dr. Joshua. As we don't have many times for question and answer, I believe we must continue to the second presentation. Thank you very much. Again, congratulations. And I wish you for your future success. After this.
Okay, thank you, Dr. Indah.
Thank you. So, committee, could you please play the second video?
Good morning. My name is Dr. Muhammad Ridwan from Faculty of Medicine, Brawijaya University. Thank you very much for opportunity given to me. My study is entitled The Effect of Clot Face Mask on Cardiopulmonary Metabolic Physiology and Subjective Sensation, a control trial. During the COVID-19 pandemic, there are many different types of masks available in the community. It's important to understand the effect of face masks as the most common type of face mask used and the most available mask for the public in the COVID-19 pandemic. Background my study, many people wear cloth face masks than wearing surgical masks or respirator mask. In general, people don't know the advantage and disadvantage of using cloth face mask on body physiology. Many people don't know the effect of wearing cloth face mask on physical activities with low and moderate intensity. We know that the use of masks aims to prevent the transmission of COVID-19. The use of cloth masks is often complained with people about the discomfort when wearing the cloth face mask. The IMERI study is one to evaluate the effect of wearing cloth face mask on cardiopulmonary and metabolic physiology. 2. To know the effect of using of cloth face mask on subjective sensation during low and moderate intensity exercise. The result of this study can later be used of consideration of lawmakers in terms of face mask regulation for the public. Subject must be healthy adult, aged between 17 to 35-year-olds without cardiopulmonary, neuromuscular, and musculoskeletal disorder. Dropout criteria and able to complete the research protocol to completion and termination treadmill test. The procedure comprised of warm-up, exercise, and rest. Each subject ran off treadmill at a 5.6 km per hour for 30 minutes. The subject underwent the procedure twice using no mask and then with a cloth face mask. Examination of cardiopulmonary, metabolic physiology parameters and subjective sensation was carried out at 3 minutes, 10 minutes, 15 minutes, 20 minutes, and 30 minutes. The subject were wearing handle pulse oximeter and cardiograph to monitor oxygen saturation, heart rate, and tidal carbon dioxide. The absolute indication for test termination were as follows: 1. Participant request to acute myocardial infarction. 3. Moderate severe angina pectoris. 4. ST segment elevation. 5. Systolic pressure drop. 6. Severe arrhythmias. 7. Technical problem, the equipment. Table 1, baseline characteristic. There are 10 participants were recruited in the study, comprises of 5 male and 5 female. Table 1 were recorded including gender, age, weight, height, and body mass index. There was no statistically significant difference in baseline characteristic. And table 2, measuring of physiological and metabolic parameters in the control group and the blood mass group, reported the median, minimum, and maximum value of respiratory rate, heart rate, oxygen saturation, and tidal carbon dioxide, body temperature, pulse scale, blood lactate, and control, and blood mass group. Comparison between the two groups resulted in no statistically significant difference in all aforementioned parameters except for talk test. Table 3 and subject sensation show that there are statistically significant differences in the result of measuring of humid, hot, breath resistant, and overall discomfort. And healthy subject, the use of cloth face mask didn't cause debilitating physiological and metabolic effect. Subject sensation of discomfort when wearing it's still a problem when doing low and moderate intensity exercise. Thank you very much for a great attention.
Thank you very much, Dr. Ridwan, for the presentation. It is very interesting research, yeah, because we know that it's very relevant with our current situation we have the evidence about the use of cloth mask. However, I would like to know more about what kind of cloth mask did you use, because there are so many different types, right?
Okay, thank you very much, Dr. Indah. This study was conducted based on the number of people who wore cloth face masks during the COVID-19 pandemic. The purpose of this study was to prove whether the use of cloth face masks affect cardiopulmonary and metabolic physiology. We know cloth face mask recommendation from WHO, three layers. In the study, subject wearing three layers. I think the cloth face mask protect droplet from washing, sneezing, and stop from other person. Okay, Dr.
Thank you, Dr. Ridwan. And how do you assign the subjects in those? Because from my understanding, there are from 10 subjects. Then you assign half of them to the wearing face mask, and then the other half is not wearing face mask. Is it correct?
Yes.
Okay. And how do you divide the group?
Yes, this first study, there is two groups, namely the control group not wearing and cloth mask, and a group wearing cloth mask. Variable the study, there are one independent variable and several dependent variable. Okay, thank you.
Okay, thank you very much, Dr. Ridwan. So again, congratulations for your study. Yeah, and I hope that we will have more evidence, about the effect of using face mask, to our activities. Okay, thank you. And I would like to call the third presenters for today, Dr. Riani Gunawan. Okay, please, committee, could you play the video?
Hi everyone, my name is Michelle, and today I'd like to present a study on ICAM-1 levels in COVID-19 patients with diabetic foot ulcers. This study was conducted at the Department of Surgery, Prof. Kando Hospital, Samratulangi University, Manado. I'll start by giving a brief background to give a better understanding on the importance of the study. We know that COVID-19 is what's causing the current pandemic, and according to the WHO, as of October 4th, 2021, there are over 200 million positive cases and nearly 5 million deaths from COVID worldwide. Diabetes is a risk factor for COVID-19, and bear in mind that those with diabetic foot ulcers are already exposed to prolonged low-grade inflammation and infection. Triggered by this inflammation, endothelial adhesion molecules such as ICAM-1 are produced in excessive amounts as a component of the immune response. We feel that COVID-19 therefore adds weight to the load of patients with diabetic foot ulcers as they experience an acute inflammatory response from COVID on top of their pre-existing chronic inflammation. The aim of our study is to investigate the levels of ICAM-1 before and after debridement in those tested positive for COVID with diabetic foot ulcers compared to those who are COVID negative. And we hypothesize that ICAM-1 levels will increase in those diagnosed with COVID-19. Now, the figure on the left here shows how patients were sorted according to the inclusion criteria. The population of our study included those diagnosed with diabetes and those who are diagnosed with diabetes foot ulcers. The inclusion criteria were type 2 diabetes, diabetic foot ulcer patients who are currently or previously receiving holistic therapy for diabetes, ankle brachial index of more than 0.9, and hemoglobin levels of more than 7.5. In contrast, individuals with a type 1 diabetes, traumatic ulcers, malignancy, coagulopathy, or any kind of peripheral vascular diseases were excluded from our study. Now, shifting our focus to the right, the figure here on the right, out of 20 patients, 12 of our patients were tested positive for COVID and 8 were negative. They were screened for COVID-19 with RT-PCR and chest x-rays. These patients were therefore divided into 2 groups, 12 in COVID positive group and 8 in the COVID negative group. After the screening process, patients received a series of blood work, which included a complete blood count, random blood glucose level test, and an ICAM-1 serum analysis. Patients then received a holistic therapy for diabetic foot ulcers, which included debridement. 1 hour after the first debridement, ICAM-1 serum levels were again observed. And finally, for data analysis and reporting, we used the rVersion 401 software, Microsoft Excel, and the strengthening the reporting of cohort studies and surgeries, or the STRUCS guidelines, to write our manuscript. Now, these are the results from our study. Table 1 here presents the patient characteristics and laboratory test results apart from ICAM-1 serum analysis. A brief interpretation of Table 1. The average age of participants was 52 years. In terms of gender, both male and female patients were somewhat equally spread between those diagnosed with COVID and those who were COVID negative. As for hemoglobin levels, on average, they were low in both groups. Leukocyte counts were slightly elevated in both groups. And last but not least, the average random blood glucose levels were just below the threshold for both groups. Overall, unfortunately, no significance were found in these findings. We then examined the ICAM-1 serum levels in those who are tested positive for COVID and those who were negative, and found a correlation between ICAM-1 levels and the presence of COVID in our patients. The results from the chart here are reflected in the table above. Now, we can see that before debridement in the COVID positive group, serum ICAM-1 levels are at 317.2. After debridement, it dropped down to 312.5. In those who were COVID negative, serum ICAM-1 levels was 149.2. After debridement, it dropped down to 130.3. We can see that there's not really a significant difference between pre-debridement and post-debridement. However, if we were to compare between the COVID positive and the COVID negative group, even before debridement, the serum ICAM-1 levels were already different. 317.2 versus 149. After debridement, 312.5 and 130.3. These significant results are presented with a p-value of less than 0.001 for both groups, for both pre-debridement and post-debridement. Now, to explain our findings, diabetes being one of many comorbidity risks for COVID, the pathological mechanism underlying it, including chronic inflammation and coagulopathy, encourages COVID-19 progression. These can be detected by evaluating inflammatory markers such as IL-6, C-reactive protein, serum ferritin, coagulation index, ICAM-1, and D-dimer. In fact, a couple of studies have reported increased level of these biomarkers in those with diabetes. ICAM1 in particular facilitates leukocyte endothelial binding and the migration of leukocytes across the endothelial barrier. As COVID-19 adds a burden to the ongoing infection in those with diabetic foot ulcers, a holistic multidisciplinary approach is required to eliminate risk factors that may delay the wound healing process in these patients. Several limitations in our study included a small size patient sample, the fact that our study was conducted only at one center, and that apart from the first debridement, patients receive personalized approach in terms of the medications given that might become a potential bias in our study. To conclude, our study showed that ICAM1 levels were higher in COVID-19 patients compared to those who were tested negative, and perhaps with more studies in the future, there could be a possibility for ICAM1 serum to be used as preliminary screening method or as a marker to express the severity of COVID-19. Thank you very much for your attention.
Okay, thank you very much, Dr. Aling, for your presentation. It is very relevant as well for the current situation. I would like to ask about the analysis of your result. How do you, because you only analyze the difference you only doing a statistical test between those with COVID-19 and then those without COVID-19 with regard to the parameters that is become your point of interest, the ICAM1. However, how do you ensure that there is no other factors influencing? Because I believe the design is not a randomized design. So how do you control other factors that might influence the result?
Hi, Dr. Indah. Thank you for having me today. My answer to that question would be that all subjects were treated the same. And you can see that even from the beginning, even before debridement, the ICAM1 serum levels were already different in both groups because one group had diabetes, and we assumed that because one group had diabetes, therefore their ICAM1 levels were higher than those who did not.
But there's also another factors might influence. Have you think about that factors? Yes, but are the other factors that might influence the level of ICAM, like for example, from the theory that you learned?
Right. We try to minimize the confounding factors by providing the same treatment between all the subjects. And since this is a study on humans, it's kind of hard to really control those factors even if they happen.
But you can control it through analysis, right?
Yes.
So why don't you use, like, for example, multivariate analysis to control the difference with control the other factors that could influence the result?
I'm guessing there could be a room for improvement on that, and thank you for your input on my study.
Okay. Thank you very much. Again, congratulations for being selected for as a presentation for this session. Thank you. And I think we can continue to the next presenters. It will be Dr. Ade Risti, Irka Diratna. So, please, committee, could you play the video?
Good afternoon. With all due respect to the judges and audience, I want to thank the 6 Eyes on IMERI for giving me the opportunity to share the result of our study. The association between computer duration use and break time with the incidence of computer vision syndrome among medical students at Muhammadiyah University, Surabaya. The new normal era has altered several aspects of life, with nearly everyone from very circles relying on digital devices for information and communication, including teaching and learning activities inside the education systems. The use of digital devices was found increased during the COVID-19 pandemic. In context of medical education, a shift to distance learning has increased the use of digital devices and gadgets in student learning activities. Without any specific guideline, it is now currently typical for medical students to spend their time 8 to 12 hours per day online in front of their digital devices. The objective of the study is to determine the association between computer duration use and break time with the incidence of CVS among medical students during COVID-19 pandemic era. The research method: first, a pilot study, we formulated a questionnaire with a medical expert panel, then revalidating the CVS diagnosis questionnaire by Sigru et al. And translated into Indonesian. And then revalidating the questionnaire performed on 150 participants. The final questionnaire was divided into 4 sections. The first one is demographic details. The second one is the questions regarding the characteristic of computer use. The third is question regarding the duration of computer use and break time. And the fourth is the symptom of CVS. The result of the characteristic respondent in the study mostly students use laptops instead computer because it is more flexible to use anytime, anywhere. According to research, laptop users are less likely to maintain a good and correct ergonomic position than computer users. This will cause various kinds of complaints related to CVS when using the device, especially with a long duration of use. The use of fluorescent light, which has the highest energy and the shortest wavelength while using the computer, can cause CVS. Students who did not use the anti-glare filter is still high, although the filter can also effectively decrease the amount of light reflected from the screen. These findings are similar to a study conducted in Bali, where the prevalence of CVS was 74% on users with eye distance from the monitor less than 50 centimeters, and the monitor position lower than the eye level. There are 4% who use contact lenses and 47% who use spectacles. The study found that CVS was significantly higher among those who are using contact lenses or spectacles. 26% of the students have a history of refractive errors. Uncorrected vision problem can contribute to developing visual symptoms related to CVS. Only 4% who took medication during the study. The result shows that most students reported experiencing headache followed by burning sensation in eyes, itchy eyes, and increased sensitivity to light, while the least often reported issue was double vision. The result of univariate analysis: among 61% students who used the computer continuously for more than 3 hours, 66% of them took a break less than 15 minutes. The CVS incidence was found to be 80%. Using the chi-square test revealed a significant association between the duration of computer use and break time with the occurrence of CVS. According to a study in Egypt, the CVS prevalence was found 86% in respondents who spent 3 hours a day in front of computer screen, and found to be more likely to have one or more CVS manifestation. A previous study in 2016 on engineering students in India stated that 79% of students experience CVS with a duration of computer use more than 3 hours a day. The closest result between the two studies is the prevalence of CVS found in both studies. The eye focusing mechanism will respond differently when reading printed text and viewing a computer screen in terms of viewing distance, gaze angle, blink rate, and text display. When computer use is prolonged, the ciliary muscles of the eyes are forced to work continuously to maintain clarity and focusing on objects of the computer screen, putting the eye muscle under repeated stress, and the eyes begin to experience muscle tension followed by eye fatigue. CVS is more likely to develop in users who rarely or never taking a break because the eyes cannot normally remain focused on object generated by the pixels on the computer screen for extended period of time. In our study, we discovered that taking a break of less than 15 minutes was significantly associated with CVS. A previous study found that individuals who took a break of less than 15 minutes after using a computer for over 4 hours were more likely to develop CVS. The conclusion: concerns have been raised concerning the health issues of the widespread use of digital devices during the COVID-19 pandemic. There is an urgent need to build institutional policy that involve all stakeholders to develop effective strategies for preventing adverse health impact. It is the end of my presentation, and thank you.
Okay. Thank you very much, Dr. Adaristi. Yeah, it is also very relevant study, I believe. Yeah, I would like to know more about the students. How do you recruit them? Whether it is because it's medical students. So, in what year are they currently?
Okay, thank you, Dr. Indah, for the question. I'm sorry, can you repeat the question again?
Yeah, so please tell us more about the respondent, especially about their year, the semester or the year, the level of medical education, and also how do you recruit them? How do you get that the number of students that become the subject of your study?
Okay, so the target population was all the medical students in their preclinical and their clinical. The preclinic was from 2017 from 2020, and the clinical student is from 2016, and there are 2,060 students that we recruit on the research, and we use social media to share the link of our research. I mean, for our questionnaire, and we use survey link like Google Form if they want to participate in our research or not. I guess that's my answer.
And how is the response rates of your students, or from the number of students that you have currently in the medical school, and how many responded to your questionnaire?
For all the students was 2,060 students, and the feedback that we get is only 194 feedback. That's the one that we use on the research.
Okay. And why do you only analyze the relationship by bivariate analysis? Yeah, you are not continuing it to multivariate.
Yes, because that's the limitation of my study. Because on other study, we see that the duration and the break time is the most it's the most I'm sorry, can I answer it in bahasa Indonesia?
Okay.
Okay, baik. Di penelitian sebelumnya itu ditemukan bahwa penggunaan durasi komputer yang sangat lama dan waktu istirahat itu yang paling berpengaruh dalam kejadian CVS ini dibanding dengan faktor-faktor lainnya. Maka dari itu juga terjadi itu termasuk limitasi dari penelitian saya ini, di mana kami tidak tidak mencari faktor-faktor lain yang juga berkontribusi dalam CVS.
Okay. Thank you very much, for the presentation. I hope that you will have keep the spirit, of doing more studies in the future. And we can continue to the next presenter, Dr. Najma Kudah. Okay, please, committee, could you play the video?
Assalamualaikum warahmatullahi wabarakatuh. My name is Najma Muhammad Kudah. I'm going to present this study under the title The Impact of COVID-19 Pandemic on a Rural Free Clinic Service in Indonesia. So, as we know that COVID-19 pandemic has changed the world. There are almost 200 million cases and 4.2 million deaths globally by August 2021. And this created a challenge for healthcare system both in developed and developing countries. As we know that before the pandemic, Indonesia had low resources to face the pandemic. We only had 0.38 physicians ratio per 1,000 populations, and we only had 2.7 ICU beds ratio per 100,000 populations. So, when we faced the COVID-19 pandemic, Indonesia healthcare system nearly collapsed, especially in the second wave. There are shortage of resources in healthcare professionals, hospital beds, oxygen, and PPE. All of the service was focused on COVID-19. In the primary care, there are closure of 76% of village center, and then suspension of over 41% of home visits and postpone of regular health visits for elderly. This reduced number of visits and utilizations of essential service in primary care results a change of health-seeking behavior in the patients. Of course, this results a challenge for primary care to maintain its service. One of the type of primary care is free clinic. Free clinic is non-profit medical facility which provide free medical care for marginalized population. There are still no official report on free clinic in Indonesia. However, there are one free clinic, namely Rumah Sehat Duafa, Ruhafa, located in Pamekasan, Madura Island. So, the objective of the study is to analyze the impact of COVID-19 pandemic on the free clinic service by comparing data 1 year period pre-pandemic and 1 year period during the pandemic. The study design is retrospective cohort study conducted in Ruhafa Free Clinic, Pamekasan. The data were collected from electronic and manual database, and we compare pre-pandemic period from April 2019 to March 2020, and during the pandemic, 2020 to March 2021. We compare three sets different of data. First, the number of patients visits. Second, the number of laboratory exam utilizations. And the third, correlation of number of visits with national. So this data shows the comparison of patient visits before and during COVID-19 pandemic. The blue line is the data before the pandemic. The red line is the data during the pandemic. Before the pandemic, there are a total of almost 3,500 visits a year. But during the pandemic, there are reductions of 52.6% to only 1,631 visits during the pandemic. And we can observe the biggest reductions in the first 2 months. We have a data loss during July 2020 because the clinic relocate to another locations, and we can also observe a slowly but steady recovery during the pandemic to the total of 85% capacity at the end of the study. And this is the highest visits during the pandemic. And before the pandemic, we can observe the highest visits in the month of January. At first, we thought because of the reduction of the visits, will result the reduction of laboratory exam during the pandemic. But this data shows the otherwise result. The blue line shows the data before the pandemic, and the red line shows the data during the pandemic. So before the pandemic, there are only a total of 98 laboratory exams, but during the pandemic, there increased to more than 100% to a total of 213 total lab examinations during the pandemic. Actually, there were 0 lab examinations in the first 2 months of the pandemic, but we can observe a significant increase during the pandemic as the time passed. And there are a change of type of laboratory exams during the pandemic and before the pandemic. Before the pandemic, the most lab order after the CBC was typhoid serology and urinalysis. But during the pandemic, the most lab order was CBC, and then followed by renal functions and liver functions. And there are more than twice increase of ECG, total cholesterol, triglyceride, HDL, LDL, and urinalysis. And this result in an increase of 94% of lab expense for the free clinic. And this study shows the correlation between the number of patients visits with the COVID-19 cases in Indonesia. The blue bar is the free clinic patients visits, and the right line is the number of national COVID case. There is a strong significant correlations. So the more national COVID case result, the more patients visits during the pandemic. So the conclusion of the study, COVID-19 pandemic on the free clinic service was observed in the quantity of its service, which decreased of total number of visits by 52.6%, and their increase of demand of laboratory exams, especially for non-communicable disease examination, and this result more expense for free clinic service, which might impact sustainability of free clinic in the long term. And the last, there is a strong correlation between national cases and number of visits. This shift of health-seeking behavior was probably affected by people concerned on contracting the disease from health professionals in public healthcare centers, service reductions in public health centers, as well as travel restrictions as a result by government policy. There are several limitations of the study. The study did not include the period during the second wave, and there is a missing data on the month of July 2020. And the comprehensive impact of the pandemic should be evaluated more by understanding both physicians and patients' perspective in the free clinic service. Okay, that's all of my presentations. Thank you for your attention.
Okay, thank you very much, Dr. Najma, for that your interesting study. And I think, we see there's a lot of different kind of studies still could be conducted, during this pandemic situation. So we see a lot of various kind of studies, and it's very interesting in this. Even those who work as a GP in a clinic could also make a study about their own practice. And I would like to also maybe have more information for you regarding because you compare the number of visits in your clinic with the national number. Is there any specific? Maybe can you also compare it with the number in your area where the clinics is currently positioned?
Okay, thank you very much for the questions. Unfortunately, I was not able to receive the data from the local government because the situation is the local government did not have the report was the report from the local government did not reflect the current situation of the city, of the town, because I think, and one of the reasons because this is a private clinic runs by NGO, so we don't have a special correlation with the government. So in order to have that data, it probably can receive if I work in the public health center.
Yeah, but maybe we can use data from the the public domain data, like from the website, national website on COVID-19, because like it's located in East Java province, right?
Yeah.
So you can use at least the data from your own province, which is, I believe, would be available from the website.
Oh, okay. Okay, thank you.
And is there any different? I mean, you just analyze it from the quantity, from the number of utilization, number of patient. I would like to know whether there is also maybe a change in the management of the clinic during the pandemic, and also maybe the service provided by during the pandemic. So that would maybe influence the difference of the number or the quantity of service utilization.
Yeah, from the slide, I was mentioning that usually before the pandemic, the highest number of visits is on January. But during the pandemic, we can see the opposite result. We have a decrease on the month of January, but slowly increase on the month in February and March. But the explanation is because during the January, there is we experienced the first wave period in Indonesia, and then the clinic decided, because we have a shortage, we have a shortage of PPE, so we decide to restrict the regulation of the clinic. So we screen the patients strictly before they enter the clinic. Actually, it was done before, but during that period, during that first period, we imply more strict regulation for the patients. That's the first. And then the second, we realized that the data was actually better if we compare the diagnosis, the shifting of diagnosis before the pandemic and during the pandemic. But and the management of the clinic, we learned that we haven't applied systematic written diagnosis by ICD-10. So because of this pandemic, we changed it by changing our medical record to more structured form, and then we probably increase it to use electronic-based medical record, so we can actually analyze not only the visitations but the diagnosis shifting of the patients before the pandemic and during the pandemic. Hello.
Okay. Yeah. Thank you very much, for your answer. So this might be just like some suggestion for me if you want to further publish the result, because it is very interesting and people would like to know more. You could also maybe add some more information regarding the change in the clinic itself, like because of the regulation, and then the procedure, and then the management of the clinic, and how so it could add more information regarding the effect of pandemic to the service in primary care.
Okay,
thank you very much again. And I hope that you will keep the spirit of doing research while practice. And I would like to call the last presenters for this session. I called her previously, but it's not the correct order. I'm very sorry. So I would like now call Dr. Riani Gunawan, to present her study. Please, committee.
Hi, I'm Riani Dwinasari, and on this occasion, I want to present my manuscript with the title E-Learning Readiness and Job Stressor of Elementary School Teachers in the COVID-19 Pandemic. The introduction, according to the Aris Munander, it was concluded that 30.27% of 80,000 teachers suffer from stress at the work. During this pandemic, it has tremendous effect on all aspects of life, including the education. In education, distance learning with electronic learning methods, or we call e-learning, is considered the best approach to continue the teaching and learning process during the pandemic. And by looking at the new teaching method, can be new workload for teachers, which can cause job stress factors for the teachers. The research objective was to explore job stressors that influence teachers the most and how they might be associated with e-learning readiness. Methodology, this study focuses on how the level of e-learning readiness of elementary school teachers with job stressor are the most dominant, and how the relationship between respondent characteristics consisting of individual and work factors on e-learning and job stressor, and the last, the relationship between e-readiness and job stressor. This study used cross-sectional method, assessed 186 teachers from public and private elementary schools in the urban city area in Jakarta. The data obtained from 2 questionnaires are Teacher Stress Inventory by Ball and E-Learning Readiness Aided at TASKI. TSE for assess teacher job stressors, and ELR for assess readiness of the teacher. And the result of this study are there were 85% of elementary school teachers who feel ready in e-learning. The most dominant job stressor were workload, continued by professional recognition, time and resources, student behavior, and interpersonal relationship. And for the first table, describes about respondent characteristic and e-learning readiness. In this table shows us that gender and teacher function affect for the e-learning readiness, with women and classroom teachers who feel more ready for the e-learning readiness. And the second table describes about job stressor on the teachers. The factors that dominant affect job stressor are total student and school status. And the third table is described about e-learning related to job stressors. For the whole e-learning, there is no relation between e-learning readiness and job stressor on the teachers. But if we divided ELR into each factor, we can see that self-development has effect to the professional recognition as job stressors on the teachers. The conclusion are in urban areas like Jakarta, 15% of teachers remain unprepared for e-learning teaching. The unpreparedness was related to female gender and non-classroom teachers who need a e-learning skills training to improve their readiness and control job stressor for better teaching performance in a prolonged pandemic situation. That's all for my presentation, and thank you.
Thank you very much. Yeah, it's also a nice study, conducted among teachers, which is, we can see, or we learn from various sources, that also there's probably, as we also experience, as a teacher in this medical school, that changing our methods of teaching is kind of stressful as well. Yeah, and I would like to know, when did this study conducted? Because it might have a difference, between if it is conducted at the early stage of the pandemic and probably now, where the in this current where the teacher probably already adjust themselves, after 1 year of the pandemic.
Okay, thank you, Dr. Indah, for the question. The study started from the webinar which titled Jurus Jitu Mengajar Online in July 2020, Doctor. So it starts off the new school year.
So it is still in the beginning, in the relatively early time, yeah, during the pandemic, yeah, when there is a change on the methods, yeah, because of the online learning. So it would be interesting, probably, if you repeat, yeah, the study now, yeah, or in this near future, because there might be a change. How do you think about it?
Yes, I think it's good if we can be a serial study, ya, Doctor.
Okay, and how do you recruit your participants? So it is the participants of a webinar, yeah?
Yes, Doctor. So when the participant of the teacher who registered to the webinar, we ask them to fill the questionnaire. So, but this is not only the webinar, not only for the elementary teachers, but also junior and junior high school, senior high school. But after the webinar finish, I choose only the elementary school teachers from all of Indonesia, Doctor. But only the majority respond for the questionnaire.
But we need to know more about whether, like, the characteristic of the participant. Yeah, maybe like you mentioned, there's between public and is there any difference, especially in the result, in the level of stress or in the type of stress, according to the participants' characteristic, like according to their, maybe from the public school or from the private school, or maybe the younger and older teacher, kind of something like that. Do you think about it?
For the first time, I thought the TSI, the questionnaire, the teacher stress inventory by Ball, it can describe the level stress, Doctor. But after a lot of reading, TSI by Ball, this is not to describe the level of stress, just to know what the job stress denominant.
I mean, for the type of stress, probably there might be a difference between teachers who work at the public and the private school, or maybe the older and younger teachers. Have you tried to explore more about the this result?
From the study, I don't give more effort to describe the level of stress, Doctor.
Okay then. Okay, thank you very much. Yeah, so we have our last presenters. All of the presentation today are very interesting. Yeah, very exciting studies. Yeah, and it is all very relevant with this current situation. Yeah, and so congratulations again for all the participants today. And we. I believe everybody who attended this session learned so much from the presentation. Yeah, and then thank you, yeah, for attending this session. And I would like to return the session to the committee.
Welcome back, ladies and gentlemen. As previously mentioned, the session is moderated by Professor Dr. Rini Sekartini, Consultant Pediatrician. Please welcome Professor Dr. Rini Sekartini. But before that, I will have a quick CV. So first, for Professor Dr. Rini Sekartini, she's graduated as a medical doctor at Universitas Indonesia in 1990 and finished her specialist as a pediatrician at Universitas Indonesia. She finished her doctoral program also at Universitas Indonesia in 2008. So please again welcome Professor Dr. Rini Sekartini.
Thank you very much, Alicia. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, dear colleagues and all participants. Thank you for joining the lunch symposia with Nutricia Salih Ustada as a partner. The topic on lunch symposia today is COVID-19 pandemic impact on the nutritional status and child development in Indonesia. I am Rinis Kartini as a moderator today and also a speaker in this session. It's almost 2 years we are in a pandemic period. Various problems and obstacles are faced by families and affect children's growth and development, since newborn until adolescent. In this session, there will be 2 speakers. First is Dr. Titis Pravitasari, pediatrician consultant, will deliver topic about risk of children nutritional status in the pandemic era of COVID-19. This is Dr. Titis, graduate from in 2021, graduate from doctoral program in medicine, University Indonesia, and also 2011, she graduated in nutrition and metabolic disorder consultant in University Indonesia, and also pediatrician specialist in University Indonesia. She is now staff of Department of Pediatric, Faculty of Medicine, University Indonesia, Dr. Cipto Mangunkusumo. I invite Dr. Titis to deliver your presentation. You have 20 minutes for presentation. Please, Dr. Titis.
Thank you, Madam Moderator, Prof. Widi, for nice introduction. Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to thank to the committee for the opportunity as well as the support from the sponsor, and also all the participants. I would like to deliver my topic about child nutrition during pandemic and outline what is the problem and how is the COVID data and what is the nutrition correlated issue, and how about the reality and how to overcome. I don't have anything to declare. This is our problem. There are 3 common nutrition problems in the global situation. About 38 million children suffer from overweight, and 45 million have wasting, category as wasting, and 149 million categorized as stunted. So in the pandemic, they predict that more and more children will suffer from the malnutrition. They predict in 2022, about 10 million children have wasted, so additional 10 million more, and additional 2 million more children have stunted. So we have to overcome and prevent it, those child not to have malnutrition. This organization do not calculate the overweight because they tend to focus on undernutrition. So how about the COVID condition nowadays? I would like to present the Indonesia and Asia Pacific condition. In terms of daily confirmed cases, Indonesia is one of the highest confirmed cases. But in terms of per million people, actually Indonesia is not as higher than Singapore. We have already overcome the second wave. Hopefully, cross our finger, we don't have the third one. So don't forget the social distancing and also the guidelines recommendation for preventing the COVID. We know that nutrition will influence the global policy, standard agreement and trading. And also the national policy will have correlated with the international standard and policy. During COVID, we have probably decreased production, have a lower market, and also have a certain restriction of the traveling. And probably because of decrease of production, then we have a higher price of the product. So it will make us to change our behavioral daily activity and food choices as well as diet. Yeah. And don't forget the media influence. Yeah. In community, if we see that our community support and engagement rise in terms of COVID, it is a positive point. But we know that some access and affordable and availability of the product may have some difficulty during pandemic. In terms of individual level, the knowledge, behavior, as well as the perception, activity, age, gender, and requirement will influence the food choices, diet, and lifestyle. So we come to the problem of whether we have undernutrition or we have overnutrition. The two of problem is also called malnutrition because it's not as good or normal nutrition. So we should think about the reason or etiology why it happened. Children as a person that influenced by environment and family will have their parent as the guardian and also the role model for the behavior and also the choices. So it can not be forget that the changes of the parents' behavior will influence the child status, nutrition status, and also physical activity status. We could improve the environment as well as the knowledge and behavior of the parent to increase the nutritional status of the children. In reality, an interesting survey in Italia, they make a questionnaire through people over 12 years. Yeah. They have revealed that those who are more active during lockdown and pandemic tend to twice more active, but those who are less active or sedentary is the same or more lazy than before. And it is interesting that the food choices, they tend to have a hot beverage and have more protein intake and have more snacking, sweet snacking. As the positive choices is more vegetable and fruit, because they think that they need the micronutrient, because they think about the vitamin C and D, zinc and selenium probably provided by the fruit and vegetable. How about Indonesia? I tried to find the data from Indonesian Pediatric Society, and they found that more children in our society have COVID-19 survivor because not suffer from malnutrition, because the comorbidity is about 20% have malnutrition, and the prevalence of the child population more on adolescent and preschool children, not preschool, school children, 1 to 6 years, preschool children, yeah, preschool and adolescent. So that's why the parent should be educated first if we want to increase the nutritional status in preschool children, and also we should educate the child itself if we want to educate or increase the nutritional status in adolescent. How about the complementary food choices before and during pandemic? About 10 years ago, I have a survey that made in East Jakarta. They said that about 54% made their complementary food home madely, and only about 30% homemade commercial and industrial commercial. And nowadays, during a pandemic, it's not much difference. Only increase about 10% of homemade, and commercial tend to decrease about 9%. Yeah, and the combination is increase about 2%. So the conclusion is not much different between the choices. In terms of the reality that mother have more time with their children, work from home, but work from home not equally have more time to cook for their child. Another study revealed that for preschool children, they have a more sedentary lifestyle. They tend twice more spent in screen time. Yeah, about 3 hours for the educational, and more 3 hours and more for the entertainment. So you can see that more and more hours they tend to have in a smartphone or television or computer. Another study in Jogja about qualitative, why they have changes the physical activity and sedentary lifestyle. They reveal that family and their friend as well as teacher have a role to influence the changes. And there is no facility at home and the surrounded area will affect their changing physical activity. About the sedentary lifestyle that they need the parental support, social support, and as well as the other support that make their comfortable and safe to have the physical activity environment. So how to overcome, as we are the frontliner, as a doctor in the frontliner, we can use our system and increasing the utility of external factor to modify the internal factor so that we can change the behavior and we have our goal. Yeah, in the community, we can use the parents to monitor their children, because the restrictive or isolation make they cannot go to the health center. Then they should be educated how to screen and monitor their children. Nowadays, a lot of application already provided by all the community, as well as the Indonesian Pediatric Society. They have Primaku. They can use as the primary tool to monitor the to monitor the growth and development. And then if there is a problem such as no weight gain or only slightly increment, so they can consult with the doctor via telemedicine. And then if there is some kind of severity, then we can go to the hospital to have a face-to-face examination. Yeah. Primary health center can be used as the first facility to overcome the unhealthy children, because not all the children have checked probably CBC or other, if there are some little or undernutrition, so they should explore more about the etiology. And don't forget to try to explore the red flag. What the red flag? The red flag is the clinical manifestation or condition then that make us to think whether we should check for more inadequate calorie or metabolic anomaly or dysmorphism or any other reason that will make the child not growing appropriately and optimally. So if the primary health care do not have some examination, then you should refer to the pediatrician. Yeah. As well as the secondary level referral. Usually, the most common red flag is anemia deficiency S.Si, or iron deficiency anemia, and urinary tract infection, tuberculosis, as well as the gastroesophageal reflux, and also the breastfeeding management that lacking of breastfeeding management that should giving the mother educate the how to breast feeding well, yeah. And then we check for further, then we can manage properly as etiology reveal. So the mass proper etiology should be reviewed first, and then the prompt treatment should be done after. Thank you, Professor Rini.
Thank you, Dr. Titis, for your excellent presentation. Maybe some item that I will present already mentioned by Dr. Titis, and I have more time for discussion. Okay, thank you for the organizing committee to invite me also to this symposium. I will share my slide presentation. Okay, I have a topic for this symposium about the risk of growth and developmental disorder in children during pandemic COVID-19. This is my outline presentation about pandemic COVID-19 and long-term effect on growth and development, changes attributed to COVID-19, and also some policy brief by WHO. And the impact of the COVID-19 pandemic around the world, and some recommendation for optimizing the quality of children's growth and development. It has almost 2 years that we have experienced in this pandemic, and pandemic COVID-19 produced potential risk to children's development due to the risk of illness, social isolation, socioeconomic status, and also the increasing stress level of parents and also for the caregiver. The situation becomes an adverse childhood experience and may generate toxic stress with some consequence like potential loss of brain development, individual and collective health, and also long-term impairment of cognitive, mental, emotional, and working capacity of the future adult. These are several factors. There are several factors that influence the physical and mental health of children and adolescents. The stress inherent in the pandemic, such isolation itself, school shutdown, reduce social life and physical activity, also changes to routine activity in the family. Some children got sleep difficulty and also got unhealthy diet, and also there is some family with disharmony at the home. Also, some children play activity limited with the home environment, and wearing masks can reduce limited facial expression and will influence with communicative learning. In this pandemic, there's also minimal physical touching, especially for the parent as also for the family, and can reflect limited expression of affection, and this can interfere with the emotional and learning for the children. Some children are also a limited relationship between the friends and also their another adult, then can increase also stress and anxiety in the children. Some children cannot go to the park or to the visiting gym for the adolescent. Then they become, the children reduce physical activity and more increased screen time. The authorities already mentioned about the study about the increasing on screen time in Indonesia. Then after 2 years, there's more effect in growth and development, and also the social, emotional well-being for the children. Some data or some study said is there's also 11 until 16 children who has the appropriate age is delayed going to kindergarten because their parents still worry if the children go to school. Until now, already said the PPKM, the children can go to the school maybe only 1 week, about 3 until 5 days. That's already done in many schools. And also children living in poverty may not have access to large screen device, because they need it for online learning. Like in this picture, in some place in Indonesia, the children must go to the high area to take to have the signal for the study. There are many study about many schools provide meals for their students. Example in Japan and India, and also the include physical activity in the class schedule. Then their meals and also the physical activity, this cannot be executed well via online learning. But some children, especially for the kindergarten children, they only can stay study by online only maybe 30 minutes, and after that they going to playing with their mother. There's some issue from WHO about the impact of COVID-19. First is falling into poverty and financial insecurity. This will the problem poverty can also have devastating effect on children because maybe the family cannot buy some food for the children. Okay. The second about learning, it's already mentioned. Now in pandemic area, most of the children got learning changed to online learning. Maybe in the big city or in the urban area, children can learning well, but not in the rural area. It's difficult to study by online. Sometimes in the family only have one device. Then they must share with another children, with the brother and the sister. How come they learning about like this? Then children living in informal settlements or camp with limited infrastructure can and no access to internet are particularly immediate. The third is about survival and health. The direct impact of COVID-19 infection on children is many cases. Also hospitalization rates for symptomatic children. The is already mentioned about there's increasing for severe acute malnutrition, and also the another problem about the obesity and also the overweight. And also the immunization, some children not complete immunization, especially for measles immunization, stated have been suspended at least 23 countries. Then also children and adolescents with chronic illness, including those living with HIV, are at risk of reduced access to medicine and care. Some children cannot go to the school because the school is remain closed and causes girls, especially girls, to drop out. Then we should also anticipate an increasing in teenage marriage and also teenage pregnancy, especially in rural area. Due to the COVID-19 measures, approximately 80 million children under the age of 1, at least in 68 countries, may miss out of the receiving life-saving vaccine. In the first COVID-19 in 2020, the coverage of immunization maybe below 50%. Now in 2021, the coverage is become increasing more than 17%, especially in the urban area. This is already mentioned for the statistics about the impact on the nutrition. Then also COVID-19 have effect on social emotional problem. And the social emotional problem is due to the several brain regions are often implicated in social information processing. This is one of the study about association between the COVID-19 pandemic in infant neurodevelopment, a comparison before and during COVID-19. This study got 546 subjects since 6 months until 1 year old. Then they screen for the neurodevelopment at 6 months and 1 year. They screen about all of the developmental of the children, cognitive, gross motor, fine motor, communication, and also personal social. And the conclusion of this study is there's an association between the experience of COVID-19 and a higher risk of neurodevelopmental delay in fine motor and also the communication domains in 1 year. Yeah, not all of the development in this study, only association between fine motor and communication. Maybe another study have another conclusion. Also, the impact of COVID-19. There's many children have sleep disturbance. Yeah, because they doing many time for screen time until midnight, and then they sleep after 12 o'clock or in 1 a.m. With loss of structure and routine, there's a high chance also for sleep problem to emerge. Yeah, increased time spent in bed, especially with the gadget, may lead to worsening sleep hygiene, and confinement inside the home may also leave children with fewer opportunity for physical activity, which is beneficial for sleep quality and mental health. After PPKM now, the sleep disturbance is more decreased. We hope if the pandemic is decreasing, there's no problem for the sleep. Also, we see the safety, yeah, the impact of the COVID-19. Many families with high risk of the stress level are not working. Yeah, there's also increasing of alcohol consumption, or there's domestic violence is a risk factor for the children, such incident of anxiety, depression, and also the children got abuse and neglect. This is must be aware for our health provider to also check is there any neglected or abuse in the family. This is one of our study in Indonesia about detection of internet addiction in the teenage. We got 332 teenage students of junior high school, and the prevalence of internet addiction about 29.8%. And the variable that have a connecting with the internet addiction is poor parental supervision and also screen time for entertainment activity more than 3 hours. In Italy, there's increasing consumption of red meat, potato chips, and also sugary drinks. Maybe same in Indonesia, yeah? And also decreased time spent on sport activity or physical activity and increased screen time. Same in the study in France, there's also increased sedentary lifestyle and also decreased consumption for fresh food and average weight gain about 1 kilogram for 35 of the respondents. This is the conclusion for the study in the France. Except nutrition, there are two kinds of the impact of the lockdown for body weight. Some children get weight loss for 23%, but weight gain more than the weight loss, yeah, about 35%. And also physical activity level is decreased and the sedentary time is increasing. Maybe same with the data already mentioned with Dr. Titis. This is data from Switzerland. During lockdown, 40% children eating more than usual. Screen time also increasing in children and also in adolescents. And children below 4 years exposed to electronic device, 41 anti 73%, yeah. And more than 50% children suffer sleep disturbance, stress and or anxiety. And after lockdown, there's also persistent habit, bad habit, yeah. 20% children still eat more than usual, and also 37 children still have excessive screen time. Then what is the recommendation for optimized growth and development? Yeah, this is some recommendation. Give the parental training in education, play, plan and stimulation. Yeah, encouraging balanced diet. Also promoting physical activity for not only for the children, also for the family. Yeah, appropriate screen time and content, and also the parent must give supervision for the children. Yeah, more family time is important for the children, and also early detection of traumatized children and immediately support if their children got and when the family know maybe the children got suffering for stress or anxiety. And also remember to complete the immunization by arranging immunization services in the hospital, and also some area in Indonesia there's a home visit from health worker to the children for giving the vaccination. There's already guidelines from Ministry of Health for health monitoring, also for growth and developmental screening, and also for made by Ministry of Health, and also guidance from give the immunization. This is our recommendation from Indonesian Pediatric Society regarding giving immunization in pandemic COVID. There's many many ID for give immunization, like manage the time for the immunization, and also drive through for the immunization. Not only McDonald's can do drive-through immunization and also can do the drive-through. This is the book, maternal and child health book. Dr. Riti already mentioned about this. This is for growth and developmental screening using we said buku KIA, the pink one. Yeah, we can also teach the parent for stimulation. This is stimulation, and for the screen for the children. Then one of the innovation also Primaku, yeah, made from Indonesian Pediatric Society, is an electronic application based on children itself. Yeah, the main feature for the Primaku about growth and development, growth and development monitoring with the curve, and also developmental screening. Yeah, and also immunization schedule and very many education about children health. This is maybe we can socialization for the mother with it is not difficult to use the Primaku for screen growth and development. Yeah, and also teleconsultation in many hospitals. They can done with this schedule. Then we must also give education to the parents to recognize and address fear, stress, and behavior change, and also help children stay socially connected. Schedule well child and immunization visit for children. Maybe one visit the children can get more than one vaccination. Yeah. Also see continuing in mental and occupational health care. Yeah. Help children to eat healthy and choose the healthy meal. Yeah. And also encourage children to play outdoor. Outdoor also wearing mask and also with the parents. Yeah. This is the recommendation for physical activity by WHO. This is the important thing. Physical activity at least 60 minutes. Yeah, moderate to vigorous for the children 3 until 4 years. Sedentary screen time no more than 60 minutes per day. And for the sleep, good quality sleep, the children have 10 until 13 hours for good sleep. Please educate to the parents. This is recommended by UNICEF, averting a lost COVID generation. That is a 6 point to respond, recover, and reimagine a post-pandemic world for every child. And this the conclusion is the impact of COVID-19 pandemic has been found on children's growth and development and also social emotional problem. And various efforts have been made to minimize the impact. And the important is education to family and community is an important, yeah. That might be done by health workers using various health services. And also we can use NCH handbook, yeah, to teach the parent and also to teach how to monitor growth and development and also give stimulation, yeah. This is my presentation. Before I close, maybe the committee can share my video about stimulation with the parent in the home. This is the stimulation in the rural area. Children can give the meal or this is milk to the goat. Yeah, I think. Yeah, this is the mother also accompany them. Yeah, there's interaction between children and and the parents. Yeah. Oh yeah. And the second video, please. Oh, okay. Okay, because we have only 5 minutes for discussion, I will ask about the question, the answer. Is there any question of answer? Oh, maybe I will read the question. First, how to deal with excessive screen during pandemic era because the children have to learn from home. Maybe this is for me. It is. Yeah, it is. Yes, it is difficult to manage screen time. But if the children must use the electronic device for study, it's okay. But no more for pleasure. Maybe only 1 hour per day. Then we can manage by schedule. After finish the school, the children can do 1 to 3. Don't forget for physical activity, especially in outdoor. Yeah. Okay. Maybe I will give the question for the Therapeutics about stunting. Stunting is closely related to hidden hunger. Which one the matter that we have to tackle first? Please, Therapeutics.
Okay. Thank you for the question. Stunting actually is the representative of chronic malnutrition, and hidden hunger usually used as micronutrient deficiency. So not all the micronutrient deficiency correlated with stunting, but the stunting actually the macro and micronutrient deficiency or under appropriate volume, yeah, or consumption. So don't forget to screen whether the child have such as condition or abnormality, anatomic, infection, as well as the other chronic disease such as hepatic disease or renal disease, as well as the malignancy. So try to screen the simple examination such as CBC, urinalysis, and probably in our country, Mantu test, and also try to find in our physical examination that leading us to think about the dysmorphism or syndromic disease, and also try to find the prominent disease in your area. Yeah, thank you, Prof. Rini.
Thank you, Dr. Titis. I also find in pandemic area there's many children increasing more body weight. Yeah, how to manage the children? I have a subject study. They from 2 years, the increasing body weight about 30 kilograms. It's amazing. She is an adolescent, 16 years old. Then he must go to the doctor or only give the education for the children.
Sorry, Prof. Rini, could you repeat the question?
I have children from since 2 years. The increasing body weight about 30. He is 17 years
30,
old.
30.
13. He is 17 years old, still school in senior high school. Is it important to send them to to the doctor?
Yes, definitely, because 30 increasing in weight is not normal in adolescent period. Although in the growth spurt in adolescent period, but 30 increasing weight is not normal. So please come to our clinic to explore more about the etiology, not only about the food choices, but also the healthy lifestyle, I think. And probably in terms of adolescent, probably, I don't know, because in our work, we facing much more psychological background. So we should giving therapy or at least a ventilation that will refill for another causes.
Okay. Okay. Thank you very much, Dr. Titis. I will send him to Dr. Titis.
Thank you, Prof.
It's time. Time is 13:52, and our lunch symposium is finished in 13:50. Then it's time for closing this lunch symposium. Thank you for all participants joining in this lunch symposium, and also thank you for Nutricia Sarisada as a partner in the lunch symposium. I close this meeting. Assalamualaikum warahmatullahi wabarakatuh.
Good afternoon and greetings to all of us. Allow me to discuss and also introduce to you doctors one of the products from Global Health, namely Sanotake, where all of these benefits will be discussed further in the topic the role of M. diffraction as immunomodulator in cancer therapy. If we talk about the cancer itself, based on the basic health research data by the Ministry of Health Indonesia, the incidence of cancer in Indonesia is number 8 in South Asia. And what about in Indonesia itself? Well, the prevalence of cancer in Indonesia also shows an increase from 1.4 in 2013 to 1.7 in 2018. So this is become a more serious concern for all of us in the treatment of cancer itself. However, in this case, not only medical treatment is an important factor in the prevention of cancer itself, but it turns out that the patient first experience in the treatment is also a factor that needs to be considered. It is discussed in their book entitled Clinical Psychiatry by Kaplan and Sidok that the patient initial experience in cancer treatment is also play important part and even very decisive factor for each individual's mental condition later in life. If an individual experience is less related to cancer treatment, it tends to increase anxiety when facing cancer therapy itself, and therapy may not run optimally. This is of course what we will avoid together, because in undergoing cancer therapy, it takes a prime condition for each individual both physically and mentally. Well, of course, fellow doctors also understand better that currently there are several alternatives that are used in the treatment of cancer in the medical world. And in this case, let me mention a little about immunotherapy, which is currently also the latest alternative treatment option in cancer therapy. In the following news that was reported in Detic Health in 2018, there were two immunologists from Japan and the US who won the Nobel Prize in Medicine for Cancer Therapy, namely Professor James Allison and Professor Tasuku Honjo, where these two scientists discovered that the immune system can actually be used to attack cancer cells themselves. So they later developed this concept into a new approach in cancer therapy called immunotherapy. Of course, this is a wonderful thing. And in this case, what does that have to do with our products? This is what we would like to introduce to our fellow doctors. It is Sanotake, whose main ingredient is maitake mushroom, which is also very well known in Japan for its MD fraction active substance and its various holistic benefit and a good level of safety without side effect. It was also approved by the US FDA as an immunomodulator and is not only famous in Japan but also has been actively researched in the US and European countries because it is proven to be effective in treating cancer in 60% of patients combined with chemotherapy. Then regarding of the composition of Sanotake itself, besides containing 20 mg of MD fraction, it also contains 500 mg of maitake powder and 20 mg of S.Si. In maitake powder itself, per 100 mg contains complete nutrients such as 18 kinds of vitamins and minerals, as well as 19 kinds of protein, carbohydrate, fiber, and other nutrients that are certainly needed by cancer patients to get good nutrition either before, after, or during chemotherapy. Of course, after this, we will discuss one by one in more details. As for earlier, I mentioned a little about MD fraction, which is the active substance of Sanotake itself. This is closely related to the beta-glucan in it. Let me explain a little about MD fraction and also beta-glucan. Even in history, Prof. Namba has succeeded in separating a substance that has been studied to have a strong potential in cancer therapy, namely the MD fraction, which is an active substance that has been purified from maitake mushroom, and his research has been carried out approximately 10 years, and as colleagues can see in the following picture, MD fraction as the active ingredient contained in Sanotake is the only one that has beta-glucan structure 1.6 as main chain and 1.3 as branch chains. This indicates that Sanotake has a stronger anti-tumor and anti-cancer effect than other mushroom. And related to the beta-glucan content in Sanotake itself, it is already well known for its ability to modulate the immune system, and discussed in his journal about the effect of beta-glucan on the immune system, and it was found that beta-glucan also show anti-carcinogenic activity. And why is the MD fraction one of the advantages of Sanotake? The following table is also an attachment from some study that I took. The results showed that the group with 20% consumption of maitake and MD fraction show significant result in inhibition of tumor growth compared to the control group. And also we can see in table 1 below how the diffraction content in Sanotake inhibiting tumor growth, and one example is in breast carcinoma. And this is what makes MD fraction of maitake in Sanotake is the best, in addition to the structure of beta-glucan, which is longer than maitake and other mushroom, but also based on clinical study also proved to have activity to inhibit carcinogenesis. And then what about the result of clinical study of if Sanotake is combined with the chemotherapy? Is it synergistic or even reduce the effectiveness of chemotherapy itself? Let's see. And it was discussed again in the research conducted by Prof. Namba in his journal Maitake Diffraction, Healing and Preventive Potential for Cancer, which has been shown with a single treatment with Sanotake had significant result compared with the control group in inhibition of tumor metastasis. Then we can see also in the table on the right how the use of diffraction Sanotake alone is said to be more effective than the group with the chemotherapy. And of course, if combined together with chemotherapy, it will give more optimal result, with result reaching 98% inhibiting tumor growth. And this show that it turns out that Sanotake has a good effect on tumor growth inhibition. It's also synergistic with the chemotherapy in terms of cancer therapy. And then when combined together with the chemotherapy, this will give a more maximal effect. Then we can also see in the journal published by Prof. Namba, which was tested on the several types of cancer, we can see that how the synergy between chemotherapy and Sanotake give a maximum result. An interesting fact that was also found that it was not only effective synergy but also very good in helping to reduce side effects caused by the chemotherapy. In this graph, especially the orange one, we can conclude that chemotherapy treatment and concurrent consumption of Sanotake can be much better in reducing the side effects that arise. Well, earlier we discussed a lot about clinical study, how Sanotake can inhibit the growth of cancer. How can this happen? Let me discuss a little about the mechanism of action in inhibiting the growth of cancer, which is one of them through the pathway of inducing apoptosis. This scheme wants to show how the molecular mechanism in the activation of apoptosis induced by the M diffraction Sanotake in breast cancer cell, which is by activating BK1 and KP7, which will allow apoptosis to occur and continue. And it turns out that this was also investigated by the urology department in New York Medical College in the US, where at the time it was tested on PC3 prostate cancer cell, which show more than 95% of prostate cancer cells die after giving M diffraction, and it caused by apoptosis too. Well, a number of study proven that maitake has a beneficial effect on immune function, and this is what a proof number also wants to tell in his journal, which is that apart from its synergistic effect with the chemotherapy, there are other things that also attract our attention, that by consuming Sanotake can also increase our body's immune system. Here's the presentation in the journal. This one of the journal that discuss how Sanotake fight cancer and tumor in addition to inducing apoptosis, which is by increasing the immune system. And this result conclude that M diffraction can improve the immune system, which can prevent the growth of cancer in according with the concept of immunotherapy. And it turns out that this is also followed by the Cancer Treatment Center of US, which began to use M diffraction as an immunomodulator in treating cancer patients. Well, of course, in its use as immunomodulator, if it is associated with the current pandemic situation right now, of course, in keeping our immune system in balance, Sanotake has a good potential too. Let me also explain some clinical studies of maitake mushroom in their use as immunomodulators and cancer therapy that have been carried out so far. The first one was discussed in the journal Cancer Immunomodulator by the Memorial Sloan Kettering Cancer Center regarding the phase 2 study of Sanotake in myelodysplastic syndrome. From this clinical study, it was found that Sanotake is well tolerated and has a potential beneficial immunomodulatory function in MDPS patients. And this was followed by a resubmission of a clinical study by the Memorial Sloan Kettering Cancer Center regarding the phase 1 and 2 trial of Sanotake in breast cancer patients. From the conclusion of the researcher, it is said that the oral administration of Sanotake has a measurable effect of both immunological stimulation and inhibition. So it's not only the consumption of Sanotake that continuously increase the body's immune system, but it seems that Sanotake can also regulate the proportion of our body immune system. It will be increased to the optimal amount according to the body's need, but will not be excessive. This is what makes Sanotake a good immunomodulator. While still on a discussion about the breast cancer, the following journal may also attract our attention because it is discussed about the triple negative breast cancer, and this journal was published by the OncoTarget in 2018, which discussed the anti-tumoral and anti-metastatic activity of maitake diffraction in the treatment of TNBC. From this, we can see that it turns out that Sanotake can also be useful in the treatment not only of breast cancer in general, but also of TNBC type breast cancer, which is fairly difficult to treat. As we discussed earlier in the clinical study, how the role of Sanotake as an immunomodulator and anti-cancer is also synergistic with the chemotherapy. Also, the next concern, is it okay if it is consumed by the healthy patient or in prime condition? So here I will describe the first journal that discussed the use of healthy people. The following journal discussed how the safetyness of Sanotake diffraction in healthy people, and it was tested on the 20 healthy people with age range of 35 to 73 years old for 1 month trial. And the results said that Sanotake is safe and can actually reduce the risk of cardiovascular disease and improve kidney and liver function. Then recorded the side effects are also said to be meaningless, and of course further study are needed regarding this matter. Here are also books that tells benefit of maitake mushroom, which are quite a lot. Then why is it also said that Sanotake is better than other mushroom in terms of cancer therapy? Well, in the report as in the graph below, it can be seen that Sanotake has a large percentage in inhibiting the growth of breast cancer, which is 86% when compared to other mushroom, and this is a significant percentage in terms of its benefit for cancer therapy, especially in the discussion of breast cancer. Well, after discussing a lot about clinical study of Sanotake, I also want to introduce to all doctors about how our Sanotake is produced. And the picture on this slide is the first company that produced maitake mushroom in large quantity, namely Yukigini Maitake, found in the 1983. They have 6 biocenter, and each biocenter is able to produce an average of 31 ton of fresh maitake per day. And of course, with the advanced technology they have in Japan, which make production of Sanotake very good and the quality is well maintained. And because it has passed several quality control stages such as hygiene inspection, heavy metal and pesticide inspection, it has also passed product testing and radioactive testing, which makes the quality of the maitake in Sanotake will keep strictly. Then for the therapeutic dose can be given 2 times every day, and each time you can eat 2 tablets. And for the maintenance needs can be given 2 times every day, and each time you can eat 1 tablet. And when can a maintenance dose can be given? In this case, it can be given if the patient condition is much better or within a crucial 5-year period after the chemotherapy. So the summary are, Sanotake can help induce external apoptosis through activation of BK1, may increase in natural killer cell, cytotoxic T cell, interleukin-1 and interleukin-2, and Sanotake has proven to ameliorate the side effect of chemotherapy effectively and has synergistic effect with the chemotherapy and inhibited the metastasis. And Sanotake has proven to work better than other mushroom to help complementing the cancer patient. And also Sanotake proved to be completely safe with no side effect and apply to any kind of cancer. And Sanotake had approved by the FDA New Drug Administration as immunomodulator, which may increase our immune system. And best quality of maitake extract can only be found in maitake. So the take-home message that I can share are, Sanotake can be used to help cancer patient and as complementary medicine to help doctors increase the quality of life over the patient. And psychological factors are as important as pathophysiological factors of the patient, and not all natural medicine are the same. If you have further questions regarding Sanotake, you can contact via the following contact. That's all I can share. Thank you for your attention.
If you are interested in Hall A, please stay because now has joined with us Dr. Adisti Dwi Jayanti, Magister of Biomedicine, as the moderator for Concurrent Session 3. Dr. Adisti Dwi Jayanti finished her medical doctor program in the Faculty of Medicine, Universitas Indonesia in 2007, and she then graduated as Master in Biomedicine, Faculty of Medicine, Universitas Indonesia in 2012, and Doctor in Biomedicine, Faculty of Medicine, Universitas Indonesia in 2021. All right, without further ado, please welcome Dr. Adisti Dwi Jayanti.
Thank you, the committee, for your nice introduction. Dear participants, thank you for joining us in this third concurrent session today. I, Adisti Dwi Jayanti, will lead the session, Theme Drug Development in Cancer Therapy and Vascular Aging. We will have two distinguished speakers, Dr. Penny Ahmadi and Professor Ippei Shimizu. Dr. Penny will present about her research in a novel field of cancer therapy using pro-apoptotic peptide, and then Professor Shimizu will talk about cancer therapy, and then Professor Shimizu will talk about therapy for cardiovascular disease targeting cellular senescence. Each speaker will have around 20 to 30 minutes to present, and then we will have 15 minutes discussion. Please feel free to ask by submitting your question in the comment box available on the conference web below the conference video. Without further ado, let's start with our first speaker, Dr. Penny Ahmadi. First, let me introduce her. Hello, Dr. Penny. Nice to meet you.
Hello, Dr. Adisti. Nice to meet you too. Thank you.
I hope you are in your very good condition today.
Yeah, I'm good. Thank you. And how are you?
Nice. I am also very good. Dr. Penny currently is a staff senior researcher in Research Center for Biotechnology, Badan Riset Inovasi Nasional, Indonesia, and also she's a member in Cluster for Pioneering Research in RIKEN, a research institute in Japan. She was graduated from Faculty of Science, Universitas Lampung, and then continue her master and PhD degree in University of the Ryukyu, Japan. Okay, Dr. Penny, we can start. I will give the time for you.
Okay, Dr. Disti, but actually I have a pre-recorded presentation, so maybe the committee can help me to share.
Yes,
Thank you.
please. The committee, you can play Dr. Penny video.
Hi, everyone. First of all, I would like to introduce myself. My name is Penny Ahmadi, and in this opportunity, I would like to talk a little bit about my research with the title Cancer Therapy by a Pro-Apoptotic Peptide. In this talk, I'm going to introduce in vivo therapeutic chemistry, which is developed in Professor Katsunori Tanaka's lab in Riken, Japan. But before that, I would like to talk a little bit about the cancer treatments. As we know that there are a lot of cancer treatment have been developed in the last decades, such as chemotherapy, radiotherapy, immunotherapy, hormone therapy, targeted therapy, and many more. However, from those reported cancer treatments show severe side effect. Even the side effect itself is more dangerous than the cancer cells. For example, the blood clotting. As you know, that blood clotting is very dangerous because it may cause a sudden death. With those side effects, we come up with a new strategy that we can eliminate the side effect. So we want to do a synthesis in the living cells. So the strategy is here. So basically, we need two important components that we want to use in this strategy. So first, is a catalyst, or we can combine it with a targeting agent, so we can call it metalloenzyme. And then the second thing is the substrate of the product itself. It means that the product is not active at all. At first, we inject intravenously the metalloenzyme to the human or patients or in mice. Then this metalloenzyme will be carried by blood and circulated into the whole body, and finally will accumulate it in a tumor. And after some time, we inject the second compound. It's a prodrug or substrate, and intravenously to the human. And then after that, it will be carried by blood, and also it will circulate in the whole body. And whenever the substrate of the prodrug meet the metalloenzyme in a tumor, this prodrug can be activated to be a drug and can kill the cancer cells. So therefore, this strategy is really promising because it may have several advantages, such as selective and specific, effective and efficient, and also the most important thing that it can reduce off-targeting problem. To do in vivo therapeutic chemistry, we need some reactions in vivo that we need to modify the drug from active to inactive, and then after that we want to activate again the prodrug. So here basically the structures of the drug contain amine. In this time we want to modify the amine moiety, and to modify this amine moiety and to make it inactive, we can attach the side chain with the alloc moiety or propargyl amine moiety, or with the propargyl ester moiety or another propargyl ester moiety. So this is one of the example of the reactions in the chemistry that we can use. And this reaction is so-called bioorthogonal chemistry because we want to do these reactions inside the living cell, and this reaction should not interfere native bioreactions in human or in a living things. And before we need to prove, is it possible to do reactions in vivo? So here we did cell-specific, organ-specific labeling by using our chemistry. So here we use gold as a catalyst, and we combine it with specific targeting. In this case, we use a glycan. And depending on the glycol cluster that we use, if we use metalloenzyme with the sialic acid as a targeting agent, this metalloenzyme can be specifically delivered to the liver. And when we use galactose, we can deliver this metalloenzyme specifically to the intestine. Then after this metalloenzyme accumulated in a specific organ, we try to inject intravenously fluorescent propargyl esters. And whenever this propargyl ester meet the gold in a specific organ, the triple bond will make a coordinate bond with the gold, and then nucleophilic attack on the surface of the organ will attack carbonyl and form amide bond. And then this specific organ can be labeled by our fluorescence. And here's the in vivo imaging that we got. As you can see here, here is the control that you can see no fluorescence were observed here. And then in the presence of the sialic acid as a targeting agent, you can see fluorescence intensity in the liver. And when we use galactose, we can see the fluorescence intensity in the intestine. So therefore, it is very possible to do in vivo reactions, and it's really promising for us. And then this result has been published in the Angewandte Chemical International Edition in 2017. For more detail, you can go and check for our paper. And then now we want to improve our chemistry, not only by changing or attaching side chain in the amine moiety, but in this case, we want to do another reaction, so-called ring closing metathesis reactions. So first, we have a natural product here. As you know that there are a lot of structures of natural product, and it's really active, and the structure itself is really unique and complicated. And in this case, we want to open the ring to inactivate the drug. So here is natural product with a cyclic ring as a standard, as a model, and then we inactivate the product by opening the ring, and then after that we want to cyclize again this product inside the living things by using our metalloenzyme. In this case, we want to use ruthenium as a catalyst. And finally, this reaction, so we want to apply it to the in vivo therapy. And here is the model. So we choose a lot of natural product with the ring cyclic in his structures, and we want to modify the structures. And by opening the ring, we want to get inactive form of the natural product. So here, we choose a very simple compound. It is umbelliprenin. It was isolated from plant images L, and it has activity as an anti-cancer too. And actually, we try many natural products, especially from marine organism, but actually from marine organism, the structure is really unique and complicated. So it is very difficult for us to use this as a first trial. So here we use umbelliprenin as the first model. As you can see here, the structure is really simple, and you have a ring and heat, and we can open the ring in a coumarin moieties. And after that, after we synthesize the product by opening the ring of the coumarin, and we check the cytotoxicity of these two compounds against HeLa-S3 cervical cancers, and also F549 lung cancers, and also SW620 colon cancers. And from this result, you can see that the different activity with prodrug and umbelliprenin is really significant, especially in a SW620 case. As you can see here, that prodrug almost no activity at all compared to the umbelliprenin. So they have a very significant difference between umbelliprenin and its prodrug. So therefore, we use this umbelliprenin as a really perfect starting material for this strategy. And here, the product did not show any activity. So therefore, we use prodrug of umbelliprenin as a starting material, and we want to apply it for further analysis. Before we did reactions in vitro or in vivo, we need to confirm that our metalloenzyme can really specifically target organs. So here we modified our metalloenzyme with several glycan. So depending on the glycan that we use, we can deliver this metalloenzyme to the specific organs such as liver, intestine, or even a tumor. And after modifying the metalloenzyme with the glycan, we are ready for next experiments. So the reaction is here. So we tried to do reactions in vitro at the first time, because it's really need to confirm, is it really active against cancer cell or not? So here we treat this SW620 cell line with a prodrug in the presence of the metalloenzyme, in this case, ruthenium. As you can see, here is the result. So this is untreated cells, and this is a prodrug. The product did not have any activity, and when we treat a prodrug in the presence of the ruthenium, the tumor growth can be, the cell viability can be suppressed here. And this deactivity as strong as the umbelliprenin itself. So it means that our reaction is occurred in vitro. So therefore, this strategy is really promising to be conducted in further purposes such as in vivo therapy. And actually, this result has been published in Nature Catalysis in 2019. For more detail, you can go and check for our paper for sure. And next, what we want to do is that we have specific organ labeling, and then we try to do reactions, then it is possible. And with those strategies in hand, we want to try our chemistry for more advanced purposes, such as organ-specific tagging to treat cancers. So the strategy is called selective cell tagging strategy, or SECT. So strategies here, this is the basic strategy that we want to apply for our chemistry. So here it's W620 colon cancers. As you know, that cancer is overexpressing integrin, and here we use RGD as a tumor targeting instead of the glycan. As you know that RGD have a strong interaction to the integrin. So therefore, we expect that our metalloenzyme can be specifically delivered to the tumor cells. And after the metalloenzyme accumulated in the tumor, we treat the tumor with the peptide propargyl esters. And as you know, as I mentioned before with our first strategy, that whenever there's triple bond with this metalloenzyme, they will make a coordinate bond with the gold, and then nucleophilic attack from amine moiety on the surface of the cancer cell will attack to the carbonyl and then form amide bond. And then this cell will be attacked by our peptide and can cause apoptosis, and it will cause the cell death. And here is the therapeutic in vivo synthetic chemistry by using SECT strategy. First, the important thing that you need to prepare is the catalyst itself. You need to have a very reactive catalyst. And in this case, we want to use a gold catalyst. And then you need the targeting unit here. This is very important too, to eliminate the off-targeting problem, because when you have a specific targeting, so you don't have to worry about the side effect about off-targeting problem. And then when you have a specific targeting unit, you need to make it as a complex, then you need to make it stable. And then whenever you inject this metalloenzyme here, and whenever you meet with your prodrug, and then they will react each other, and then this tumor cell will be tagged by the peptide, and then this peptide cause apoptosis inductions, and then the cell will adapt. And before we go for further analysis, we need to confirm first, is it really our metalloenzyme can be specifically delivered to the cancer? And we here prove by using in vivo imaging to prove the tumor-specific targeting by using S.Si as a template, human serum albumin. And we modified with the RGD here. And this is the peptide, cyclic peptide, and we label with a size 7.5. And then we inject intravenously this RGD labeled S.Si to intravenously to the nut mice, tumor-bearing mice here, and we observe, we took the image of the 6 hours and 8 hours. As you can see here in vivo imaging, so that's very clear accumulation in the tumor, while in other organs, almost no accumulations. Then after 24 hours post-injections, we sacrificed the mice and we took the major organs such as heart, lung, pancreas, femur, brain, muscle, and also tumor. And you can compare here that the highest accumulations is in tumor, and while in the other organ, almost no accumulation. So therefore, we can confirm that our metalloenzyme can be specifically accumulated in tumor. And we were very happy that our strategy might be possible to do in a specific area in a tumor. And here, when we have the specific organ targeting here with the metalloenzyme and we prepare the peptide 9, actually we prepare a lot of peptide at that time, but we choose the very appropriate peptide for this strategy. So here is the peptide 9. It's in active form when you attach the propargyl esters. And whenever they meet with the goal, then this peptide can be labeled on the surface of the cell and can induce cell apoptosis. And here's the cell viability analysis. As you can see here, peptide 9 in the presence of metalloenzyme, the cell viability is very low here. The cell growth can be inhibited. So this peptide 9 and metalloenzyme can be used as a starting material for therapeutic in vivo synthetic chemistry. And then we come to the in vivo therapy. So in this case, we want to treat our compounds. We want to use our compound to treat tumor-bearing mice. So first, we need to make tumor model mice here. We inject the NUT mice with the SW620 tumor with the subcutaneous injections. And then when the tumor grows at the perfect size, we intravenously inject the gold complex. And then after some time, we inject with the peptide 9. And whenever they meet, we expect that the reactions occur in a cancer cells. And during therapy, we observe the tumor growth, body weight, and also the survival rate. And here is a tumor growth during a therapy. As you know here, we did 10-time injections in consecutive days. And because we need more intense injections, as you can see here, that in gold only and peptide only, so a slightly cytotoxicity compared to the control group mice. And but when you use combinations between peptide 9 and gold metalloenzyme, the tumor growth can be totally suppressed. In this case, although they show, and for this group show slightly cytotoxicity, but it is really possible that to treat a cancer with our strategies, because it can totally inhibit tumor growth, and we are very happy that it might be promising for treating cancer cells. And we also check the body weight. As you can see here, the body weight is relatively stable, but however, in the peptide 9 and in the presence of the metalloenzyme, so slightly decrease at the end of the treatment. But however, after the treatment, the body weight go back to the normal. So we can assume that it might be because of 10 times injections. It's really too much for injections. And but after treatment, the body weight go back to the normal. So we may say that it's really the side effect. We can neglect a little bit with the side effect. And we are very happy that this is it's an excellent result here. And we also check the survival rate of the treated mice. So here is the 3 groups: cell line and a peptide only and a metalloenzyme only did not show any significant difference. But when you treat the mice with a peptide 9 in the presence of metalloenzyme here, you can prolong the survival rate up to 2 weeks. And it's really excellent result that our strategy in vivo therapeutic chemistry can treat a cancer cells. But however, it's the disadvantage of these reactions and this therapy is that you need 10 times injections. It's a little too much, and it's not really able to be applied in human or in patients. So therefore, we need to improve our chemistry to get a much better reaction that can be used and applicable for treating cancer cells. So here we come up with a new strategy with this new S.Si this strategy. So in here, instead of gold, we were using a ruthenium as a catalyst, and we use alloc benzyl fluoride as a side chain to protect the drug active. And after that, we after removal the alloc moiety, and this is a resonance of the proton, and then you cleave the fluoride, and then you form a quinone method immune formations. And this structure is really reactive. So nucleophilic attack from amino acid, especially from hydroxyl and thiol, is really reactive against these structures. So then the cancer cells can be labeled on the surface by our drug or a peptide. And then we also did the same thing as in gold therapy. So here we also make a tumor model mice. We use SW620, and we also inject the subcutaneous injections on the shoulder mat of the mice. And then after the size we have the perfect size, and then we treat the tumor-bearing mice with the ruthenium complex, and also after accumulated well in the tumor, we treat it with the peptide 9, and we also check the body weight, the tumor growth, and also the survival rate here. And during therapy, this special thing compared to the gold thing that we try only one injection, so we call it single injections on the first day only. So here we have the 5 group of treated mice. Here, cell line, peptide, catalyst, peptide and the catalyst, and also peptide and catalyst, but you doubled the dose. In the case of cell line peptide catalyst, you did not any significant difference, because you can, in this case, it means that there is no activity in this compound, I mean cell line peptide and catalyst. But when you treat a mice with a peptide in the presence of the metalloenzyme, you can inhibit the tumor growth significantly. But when you double the dose with peptide and catalyst, you can totally inhibit the tumor growth, even only one single injections. So therefore, we are very happy for this result. We can improve our chemistry from 10 injections to 1 injections. And this is a really excellent result, and even with a double dose. And then we'll also check the body weight. As you can see here, that the body weight is relatively stable, almost no different weight among the group, and we can confirm that almost no cytotoxicity were observed in this therapy. And then we also check the survival rate of the treated mice. As you can see here, cell line, peptide, ILOC, and ruthenium almost no significant difference. Even ruthenium shows some slightly activity, but not so much different. But in the presence of peptide, ILOC, and ruthenium, you can prolong the survival rate up to 2 weeks. And when you double the concentrations of the dose, you can get like around 3 weeks prolonged for the survival rate. And we are very happy that actually this is also the first time that ruthenium can be used as reactions in vivo, and this is the first report that we report. And also maybe this is an excellent result, because we can confirm that ruthenium can be used for this strategy, and even more stable compared to the gold metalloenzyme. And then here is the images that we took on day 1 and day 8. And you can compare here a vehicle, I mean, this is cell line only. You can see very significant difference, and you can see the peptide here also significant different, catalyst. But in the case of peptide, not so much different. And in the peptide catalyst, you can see in the double dose, there's no difference. So therefore, this strategy is really promising to be applied in cancer therapy. Yeah, I think that's all for my talk. Thank you very much for your kind attentions.
Thank you, Dr. Penny. Very interesting presentation. Very interesting result of your
Thank you very much.
Yeah, I believe the result is very promising. We will have another hope for anti-cancer therapy. Okay, before we move to the discussion session, we will listen to our second speaker, Professor Ife Shimizu. Hello, Professor Shimizu. Nice to meet you.
Hi.
Okay, Professor Shimizu currently as a professor in Juntendo University Graduate School of Medicine, Tokyo, Japan. He was graduated from Chiba University and then continue his postdoctoral fellow at the Chiba University and also Boston University School of Medicine. Okay, Professor Shimizu, you can start your presentation.
Ipe Shimizu from Juntendo University. Thank you very much for
recording in progress.
All right. So okay, so today I would like to talk a little bit about capillary network formation. This is a extra microscopic findings. For example, in the brown adipocyte, they are surrounded by capillaries. and also in the heart, the cardiomyocytes are surrounded by capillaries, and also in the skeletal muscle, the capillaries, as we know. So there will be a kind of a network between capillaries and the like a brown adipocytes or whatever the cells. So the maintenance of the capillary network formation has a critical role for the homeostasis for tissues, as we know. So there's an interesting published papers showing the link between capillary rarefaction and the aging. So this is the kidney from the aged rodents, and showing the reduction in the capillary network formation with the aging. And also this is a study from the brain in the hippocampus. With the aging, the capillary rarefaction develops and possibly have a role for the decline in the cognitive function. Also recently, there was a published paper from Science showing that the decoy for vascular end cell growth factor, so the VEGF receptor 1 in the soluble form, they become like a decoy for VEGF. So that leads to, again, with the aging, leads to the capillary rarefaction. And also in the disease model and the disease in humans, like heart failure with preserved ejection fraction, like HFF patients, they have a capillary rarefaction as published elsewhere in 2015. And also this is our study showing the pressure overload model, like TAT model, showing a kind of systemic systolic dysfunction together with ventricular dilatation. Again, when we count the capillaries, the pressure overload heart has a capillary rarefaction. So the point is that with the aging and with age-related disorders like heart failure, they have a diminished capillaries, as I demonstrated here. And the point will be whether we can enhance the capillary network formation with the aging and age-related disorders. What will be the strategy, and what will be the approach, and what will be the biological effect for the aging? So that's an open question to be explored. So I would like to a little bit talk about cell senescence. As you know, the cells have a limited capacity to proliferate so the somatic cells, not a cell line, so they become like a senescent stage. So the proliferative capacity is diminished with proliferative cell proliferation. So this was characterized in 1961 with Hayflick and described cellular senescence. So as we know, there are two types of cell senescence. One will be like a replicative senescence, another will be described as a premature senescence. And the telomere shortening develops with the proliferation of cells. And then after reaching the critical threshold, the P53, P21, and P16 pathway promotes cell senescence. Also, when the cells are exposed to like cytokines or reactive oxygen species, again, the cells upregulate P53 or P16 pathway, and then the cell gets senescence. Senescent cells are characterized with growth arrest, also the autogene expression. So P53 is, of course, it's a guardian of the genome. It's critically important to suppress tumorigenesis, but we take the position that the excessive P53 or P16 pathway promotes cell senescence, and then they become like pathogenic player for tissue remodeling, for example. Okay, so I brought this from the figure from New England Journal in 1993. When the cardiac tissue is exposed to pressure overload, the cardiac hypertrophy develops, and then they make a transition to heart failure. But the mechanism was not known for a long time. So when the mice are subjected to TAC operation, the pressure overload leads to an increase in the cardiomyocyte size, and that leads to myocardial ischemia. But in the adaptive phase of the heart failure, the cardiac angiogenesis develops, so that the transition to heart failure will be suppressed. But what we found that in the maladaptive phase, as I showed, that the P53, the key player for cell senescence, will increase, and then VEGF level will be suppressed. That suppress the angiogenesis. and then the cardiac tissue become like a hypoxic condition, and then they make a transition to heart failure. So again, the capillary network formation is critically important to suppress the transition to heart failure. And several years ago, we make a deep dive into what kind of cells have a high expression profile for P53. So the TAC-operated mice, the red signal is the capillaries. So they have a high expression profile for P53 in capillaries. And this was confirmed with the flow cytometry. And in this paper, we found that during pressure overload, the excessive sympathetic nerve signaling will increase P53 signal in the end cell that are positively regulates ICAM1. And also in the bone marrow cells, the inflammatory cell also has an increase for P53 that would increase the integrin. And then ICAM1 integrin axis promotes infiltration of the inflammatory cells in the cardiac tissue, and then cardiac inflammation and also the tissue remodeling promotes heart failure. And this is a paper published in 2015 from other groups. So they were interested in characterization of the capillary network. And then, so they generated the endothelial cell P53 knockout model in the TAC operation. And then, in a sense, they confirmed our findings. So in the P53 depletion, a mice model has a better cardiac function. And they were interested in the characterization of CD31 positive cells. Then they show that the depletion of P53 in endothelial cells promotes an increase of CD31 positive cells. So in a sense, endothelial cell P53 may be important for promoting the inflammation in the cardiac tissue, and also it would be important for the capillary rarefaction. It means the diminished capillary density. So P53 in endothelial cell may be interesting. Continues to be an interesting target to be, suppressed. And also with aging, so this is a human-derived endothelial cell. The evidence for the increase in the P53 sedentary and older individuals, and also P21 will be increased, and P16 will increase. But interestingly, even in the similar age, when these age the individuals are doing the exercise, the marker for this cell senescence marker will be suppressed. So we can even reverse or temporarily stop the aging process. So with the senescent cells, they are characterized with an enlargement. So they have a flat and enlarged morphology, and also they have a secretory phenotype like CCL2 interleukin 6. And as I already described, P53, 21, and 16 expression are high. And also they have a high DNA damage response, like gamma 6. And also they have a signal for SA beta gamma. And also they have a telomere attrition. And also telomere associated 4C like TAF was recently characterized to be the senescent aging marker in the cardiac tissue that do not proliferate that much. Okay, so I'll a little bit talk about the senolytics. So we can target and deplete these senescent cells specifically using some drugs or genetic models. Okay, so this is a history of aging research. So we have somewhere here. The most hot topics related with aging would be the specific depletion of senescent cells. Okay, so these are published from other groups. So this is a genetic model for P16 depletion. So these are progeria model in nature, but these mice are wild-type mice. I mean wild-type progeria mice. So this is a P16 depleted progeria mice. So in the morphological clearly indicates that they have a healthy morphology compared to the two lean model. So the level of scoliosis will be reduced with a P16 depletion, and also the cataracts the eye disease will be suppressed with a P16 depletion in the progeria mice. Also, this group used another genetic model, and then also the genetic model for P16 depletion. So this time they analyzed the atherosclerosis model, And the pink signal, red signal is a kind of a lipid. It reflects the atherosclerotic region. This will be reduced with a P16 depletion. Okay, so I talked about the genetic model, but there are drugs or chemical compounds or clinical use or not useful. So several years ago, we just published a review article, but at that moment, there are 14 senolytics. I mean, the compound or drug that specifically deplete the senescent cells. So among them, the dasatinib and quercetin are extensive study. Dasatinib is a tyrosine kinase inhibitor and used in the setting for the cancer treatment. Quercetin is a more physiological one. They will be categorized as a polyphenol. And then the combination of dasatinib and quercetin, D and Q, contributes for the specific depletion of the senescent cells. But so these are tested in humans. For example, like chronic kidney disease, idiopathic pulmonary fibrosis. But the dasatinib is a tyrosine kinase inhibitor, and quercetin is a flavonoid group of polyphenol. So we feel free to use quercetin, but the dasatinib should be like a kind of a toxic reagents. Also, ABT263 is another well studied drug, but the BCL2 family inhibitor. So this is also like a cancer drug. So we don't feel free to use it in a daily setting. Okay, so this is the evidence for ABT263. It's a senolytic agent and anti-cancer drug targeting BCL2. So with a high concentration in the young cells, they do not die, but in the age cells, with a high concentration of ABT263, the age cells start to die. So this clearly somehow the drug discriminate between the young against the age cells, and then only in the age cells can be depleted. So that's why the reason why they're classified as senolytics. And recently, the accumulating evidence indicate that the ABT263 also has a protective role for myocardial infarction. So when the mice are subject to myocardial infarction, and also for the ABT263, even the ejection fraction will be improved with the ABT263 administration. Also, this is a recently published paper from the Concurrent group on testing the D and Q in humans. So in the subcutaneous fat, the P16 and also P21 positive cells are reduced. And also the SA beta gal signal seems to be diminished with the DNQ treatment in subcutaneous fat of humans. So within 10 years, this approach will become a kind of a global standard therapy for age-related disorders, including heart failure, atherosclerosis, obesity, diabetes, CKD, or whatever. Okay, so we recently found that the cell surface marker like GPNMB, so we can target the GPNMB positive senescent cells. It became impressed maybe yesterday or today. So we analyzed the transcript for Hubic subject to the replicative senescence. And I found that the glycoprotein non-metastatic melanoma protein B, GPNMB, will be expressed highly in the senescent cells. So this is a transcript evidence, but we found that the senescent cells, they become high for GPNMB in protein. So P53, P21, and P16 will be enhanced. Under this setting, we found a robust increase in GPNMB, as you can see here. In the aorta for the aged mice, we found that the GPNMB expression would increase, also together with other senescence markers like P53 or P21. Also in the upper atherosclerotic model, as you know, they have a high expression profile for GPNMB and also for the P53, P21. And also in the atherosclerotic disease patients, like a coronary artery disease or peripheral artery disease, the patients, they have a high expression for the GPNMB in the end cell cells, as you can see here by the same. We generated a genetic model for GPNMB depletion model. with a DTR look mice. So in the high-fat diet, they have a high expression for GPNB, so they have a high luciferase signal, as you can see here. After diphtheria toxin, also the GPNB high cells can be depleted, so the signal will be diminished like here, like as you can see here. So this is a study for the S.Si beta staining. So the S.Si beta staining signal is diminished in the visceral adipose tissue. Also on like an aging marker like P16 and P21, they will be reduced, as you can see here. And importantly, the systemic glucose intolerance and insulin resistance with GTT and ITT would improve if we use a genetic model for GPNB depletion. And also we generated apo-inoculum mice, background GPNB transgenic mice. And then again, the DTR treatment reduced GPNB depleted GPNB positive cells. And this led to a reduction in the atherosclerotic lesion, as you can see here. Okay, so there will be some, the capillary network, and also for the marker for endothelial cells are important, especially for the senescent marker that I told you. But in the realistic drug or compounds, whether we have it will be a kind of open question to be tested. Okay, so this is the guideline for American Diabetes Association, ADA in 2020. For the diabetic patients, there are two types of drugs like SGLT2 inhibitors and GLP-1 agonists. So these are the weight loss. So both of them are interesting because these drugs lead to the weight loss. So the patient prescribed for these drugs will lose 4 kilograms per year in the first year. And I would like to talk a little bit as a reminder for the SGLT2 inhibitors. So SGLT2 in the urinary tract will uptake the glucose. So the SGLT2 inhibitor contributes for the suppression of the uptake of the glucose. So the glucose will be secreted out of the urine. So it's a kind of a calorie restriction situation. So that's the reason why the patients are losing body weight. And as you know, this calorie restriction, extended lifespan is the general consensus already tested in the apes. As you know, this is a very interesting panel. The report showing that one of the SGLT2 inhibitors significantly suppressed the hospitalization for heart failure. And also nowadays, this is confirmed with other studies that in testing heart failure with reduced ejection fraction, showing that these types of drugs universally has a role, cardioprotective role in a HFrEF condition. And recently, HFpEF, heart failure with preserved ejection fraction patients, the incidence for heart failure were significantly suppressed with SGLT2 inhibitors, as described already here. Okay, so these studies motivated us to test the role, the underlying mechanism for SGLT2 inhibitors. So we use one of the SGLT2 inhibitors, empagliflozin, and generated TAC operation in mice, left ventricular pressure level. And in the control group, the fractional shortening will be reduced together with left ventricular dilatation. But if we co-administer like empagliflozin, the SGLT2 inhibitor, these will be ameliorated, as you can see here. What was interesting is that when we take a look at the left ventricle, as our at least two papers have already shown, the capillary rarefaction develops in the left ventricle with TAC operation, but the EMPA administration, SGLT administration, ameliorated the capillary rarefaction, as you can see, and also the quantified error is here. So we're interested in the testing the underlying mechanism. So we use a flow cytometry and so analyze the level of several markers in CD45 negative, CD31 positive cells. So first we analyze the reactive oxygen species that were clearly increased with TAC, reduced with SGLT2 inhibitor. So AKT signal, we also analyze in the endothelial cells that show a reduction with TAC and improve with SGLT2 inhibitors. And also we do some staining Phosphorenols were reduced with TAC, increased with SGLT2 inhibitors. Also, the level of nitric oxide would reduce with TAC and increase with SGLT2 inhibitors. Also, when we characterize tunnel-positive apoptotic cells, they will increase with TAC and then diminish with SGLT2 inhibitors. So our studies, this is a scheme of our studies on this as well. So we found that this 3-hydroxybutyrate would reduce reactive oxygen species. This would increase with TAC, so the MPA administration reduce reactive oxygen species with a ketone body. And then in general, on the TAC operation, ROS is promoting apoptosis in cell cells that leads to capillary network, capillary rarefaction, that leads to left ventricular systolic dysfunction. The MPA and the butyrate suppress this ROS-mediated cell death in capillary. So SGLT2 inhibitors in the end promote the capillary rarefaction, the capillary network formation in the heart. Okay, so in the final several slides, I would like to talk a little bit about brown adipose tissue because the capillary network is also important here. So the brown adipose tissue and brown adipocytes was initially characterized as the organ of cells that contribute for generation of heat. But nowadays, studies indicate brown adipose tissue, but in short, as an active metabolic organ. So this is a study from the mice. They have like 5% of the body weight. But if they get highly activated, the clearance, the contribution for the clearance for triglyceride and also for the glucose disposal is enormous, as you can see, like 50 to 75%. When I was a postdoc in Boston University, I encountered the brown adipose tissue study, and then when we import high fat, high sucrose to the mice, the interscapular brown adipose tissue has a capillary rarefaction, as you can see here. So they're losing capillary in the brown adipose tissue, and then they also become like a hypoxic condition in the brown adipose tissue. So the hypoxic condition in brown adipose tissue promoted mitochondrial dysfunction, and then the autophagy, ping pong parking signaling became excessive, and then contributed for the clearance of the mitochondria that led to the brown adipose dysfunction system insulin resistance. And we are also now testing the role of the polyphenol in the brown adipose tissue. When the mice are fed high-fat diet, and they have a whitened phenotype, as you can see here, but we administer the polyphenol, and then the whitened phenotype will be IMERI, as you can see here. Uncoupling protein 1, UCP1, is a critical player for the maintenance of brown adipose tissue function. They will reduce with a high-fat diet, and then that will improve with polyphenol administration. And also the thermogenic response will diminish with the obesity, but they will improve with polyphenol administration. And also the systemic glucose intolerance, and also the insulin level will be ameliorated with polyphenol administration. And also, okay, so we are also interested in the capillary network formation under this condition because they have a critical role for the homeostasis for brown adipose tissue. The capillary will be reduced, and dietary obesity, and then polyphenol administration would improve the capillary network formation, as you can see here. So I think it's the safe compound that contribute for the health. And also, we previously showed that in the large arteries, the high-fat diet would increase the reactive oxygen species. But together with the polyphenol administration, this will be diminished, as you can see here. And also, the P53 level will increase with the dietary obesity that will reduce with the polyphenol administration. So polyphenol approach will be interesting, and one of the realistic way to enhance longevity, even also the capillary network formation. And also in the aorta, the nitric oxide would reduce with obesity that would improve with the polyphenol. And also the enos, the dimer is critically important for the player, so they will reduce with obesity but increase with the polyphenol administration. Also the function of the iliac artery will be diminished in the obesity but improve with the polyphenol administration. So it's important for capillary network as well as the maintenance of homeostasis in large vessels. Okay, so taken together, so our studies and other studies indicate the capillary network has a crucial role for maintenance of tissue homeostasis, and cells in essence promotes pathology in cardiovascular metabolic disorders, and senolysis reverse aging phenotype. So we are extensively studying as part of our several projects. Suppression of the aging signal become therapy for cardiovascular metabolic disorders. Thank you very much for your kind attention.
Thank you very much, Professor Shimizu. Also very complex and interesting presentation, very complex study. Okay, I invite Dr. Penny and Professor Shimizu to our discussion session. From the committee, there are no questions yet. I think this is because the topic is very complicated, I believe.
I talked too fast, I guess.
I don't think so, Professor Shimizu. You are very clear in presenting your study. But both of you have a very interesting study, and I think both of this has a very promising in the future. Yeah, we will have another anti-cancer strategy, and we will have another anti-aging strategy also. Okay, I will ask first to Dr. Penny. Actually, I have a question from the WhatsApp group, from our research group. Yeah.
Sure.
Okay, Dr. Penny, this is the question for your
metalloenzyme.
And metalloenzyme. Yeah, you are using Aurum. Yeah, Aurum.
Oh, that's not Aurum. That's Gold. AU.
Gold. Yeah.
Yes.
The gold is quite expensive. Yeah. Maybe you can explain the reason why you use gold, and maybe is there any alternative, another metal to make this enzyme? Thank you.
Okay, thank you. It's really good questions, I guess, because you're asking about this gold. Maybe people will think it's about really gold, but actually we use gold. It's not that. Au chloride, so gold chloride. It's not gold metal, only metal, but we use it as a chemical gold chloride. So it's not really that expensive. Actually, everyone can purchase this and commercially available. And actually, we use gold because it's also promising for treating the cancers and very active to activate our product. And also not only gold, but in this case, we also use ruthenium as a catalyst. And from our result, it shows that ruthenium works better compared to the gold. Thank you.
Okay, so it's the different gold, yeah.
Yes.
Okay, thank you very much for your explanation. It's very interesting. Now I would like to ask Nader for your explanation about your works. We need very sufficient chemical structure knowledge. Yeah. Do you have any key points in determine your model, your peptide? Do you have any key points, the important thing that we should consider?
Yes, it's really good questions. So actually, before we start our strategy, we need a lot of studies about the structures. We need to observe the structures, and we need to point out which reactions that we need to do, kind of like cleavage reactions, or like a metastasis reactions, ring closings, metastasis reactions, or something else. And then we choose the compound itself, the prodrug. Actually, a prodrug itself is not active, but we need to design prodrug that which is not active, or it's not have a cytotoxicity at all. And then we kind of try several compound, and we need to modify this compound, and then we make a library. So at first we need to do a peptide, so we need to make a various peptide first, like many peptide. We make many libraries, and then we choose the most a promising one, and then we choose the most promising peptide, and we use it as a starting material for our therapy. And I think we did a lot of work, and then finally we found very promising peptide. Thank you.
Okay, so you have already searched for the most
Yes, actually, we make a lot of reactions and make a lot of library just to get a best candidate for this strategy.
Thousands or millions of reactions.
Actually, because we work in teams, so we can share our works, and it's But with the result that we got, we were very happy.
Yes, I also saw that your result is very good. Yeah, I believe we can continue your research until clinical trial also.
I hope. We hope to.
Yeah, and we will have another anti-cancer therapy for our patients. Okay, now I will move to Professor Shimizu. I'm very interested in your SGLT2 inhibitor research. Yeah, so is it mean that the diabetic patient who consume SGLT2 inhibitor will also have a beneficial effect as anti-aging?
Oh yes, so that's true. So this type of drug was developed for anti-diabetic drug, but FDA made a kind of a duty, so they need to check the cardiovascular event, and then the heart failure event was amazingly suppressed, like 20% reduction. And also, the recent study showed that in the non-diabetic patients with heart failure, the incidence for heart failure, including hospitalization for heart failure, was reduced. So for recently, we can even prescribe the SGLT2 inhibitors in the non-diabetic patients, like primary diabetic cardiomyopathy patients, or whatever, whatever HF patients, we feel free to prescribe. And it's so so it's kind of a routine work for us to prescribe these drugs in the HF patients without diabetes or with diabetes. So I'm not sure in Indonesia, do you have this type of drugs? SGLT2 inhibitors.
Yes, we have
you have
SGLT2 inhibitor, but I think now it's only limited for diabetic patients.
Oh, really? Okay.
So in your place, you already prescribe SGLT2 for cardiovascular disease, right?
Yeah, that's right. And also, the recent study published in New England Journal of Medicine showed that they have a promising effect also for the HF patients, preserved ejection fraction patients. But so we want to prescribe this type of drug for the HF patients, but we don't feel free to use it because we cannot do it. If the patient has a chronic kidney disease, we can prescribe this type of drugs for the CKD. So once a patient in the outpatient clinic or inpatient clinic with a HF, we try to find whether these patients have a comorbidity for the CKD. And then if they have a CKD, we feel free to prescribe dapagliflozin for those patients, predicting that in addition to CKD, the heart failure, the diastolic dysfunction may be ameliorated with the SGLT2 inhibitors. So that's our strategy.
Yes, very interesting. Yeah. So at the first, it was developed as anti-diabetic agent, and then with your research and your colleague, and then we can also found another mechanism for SGLT2 inhibitor. Yeah. Very interesting.
We lose the body weight, so I want to take it even, not just running. Just take the drug and we will lose 4 kilograms. But I don't take it. But
if you lose 4 kilograms, I cannot see you.
It's similar to the calorie restriction. Even though the patient or individual taking calories, they're losing, from the urine. So it's almost like a mimetics for calorie restriction. So I think they may even enhance longevity. For example, people taking SGLT2 inhibitor may live longer. Nobody knows at this moment, but it's one of the possibilities, like calorie restriction.
Yes, maybe we will wait for another years, to see this SGLT2 inhibitor. Longevity.
So many interesting stuff pop up.
Yes, but the basic molecular mechanism already revealed. Yeah, you already studied it. It's very interesting.
Yeah, we really struggled. We wanted to find a single bullet. S.Si inhibitor. We did series of metabolomic studies, and then we focus on, for example, steroid level would increase, one of the amino acid would increase in circulation, and also the ketone body would increase. But we are not interested in ketone bodies because it was already extensively studied. So we focus on steroid because we saw that steroid may fuel TCS cycle and made its cardioprotective effect. So we generate TAC operation and infuse the steroid, but there was no effect. So we were really disappointing. And also other amino acid we focus, like I already forgot the name, something other amino acid, but they also show no phenotype. So I think it's not kind of a one single bullet. It's kind of a combination for several mechanisms attached with SGLT inhibitors. So it's a little bit painful project for us.
Yes.
And we finally went back to the butchery. So it's a kind of cynical project to us.
Yes. I have one other question now. About P53. The P53, also well known as the tumor suppressor gene. Yep. Yes. So how do the P53, this P53 expression interfere with your result in anti-aging?
Yeah, so we cannot completely, that's a very interesting question. And then of course, we need P53, but it should be maintained on some kind of a physiological level. When we keep the mice, systemic depletion P53 knockout mice, they show a kind of an anti-obese phenotype for several months. But after 6 months, they start to die because they promote tumorigenesis. So they die for cancer. So initially, we took the strategy to suppress cell senescence. But the protect way of cell senescence is a kind of anti-cancer system. So nowadays, like others, we made a shift to specifically deplete or kill the senescent cells. And then I don't know if you know the word bystander effect. When the cells, the young cells have, the aged cells, they have a bystander effect. The young cells become aged. So, if we can specifically deplete the aged cells, the tissue will rejuvenate, and the mice even become young. So it's a kind of a reverse of aging. So that's the strategy, our strategy. So we are interested in finding senolytics. So I don't know if you or other members joining. Curcumin also promotes browning, so brownie post-tissue enhancer. So it's also interesting to me. Yeah. I don't know how often you guys take it, but it's one of the spice for the cardio for us. So I like it anyway.
Yeah. Yes, usually in Indian food, yeah.
Yeah.
Okay. Yeah, very, very interested. Yeah, our two topics today, this afternoon is very interesting. I hope all of us and also the participants maybe still amazed with your study result. Yeah. So they have no question yet. But then our time is up. Yeah, I will wrap this session. So we have listened about the new strategy for anti-cancer therapy using pro-apoptotic peptide. Very interesting, very good work, Dr. Penny. Yeah, we hope that this study will continue to the clinical trial phase and then our patient. And also from Professor Shimizu, we learned about a lot of anti-aging strategy that we really need now because our elderly population is growing up and we need to maintain their health also. Thank you very much for the committee for this very good session. Thank you very much once again for our speakers, Dr. Penny and Professor Shimizu. Thank you very much. I close this session and I give this room back to the Master of.
Welcome back, ladies and gentlemen. As previously mentioned, for our last agenda for today, we have two sessions happening in Hall A and also Hall B. In Hall A, we have Concurrent Session 5 with the topic Learning from COVID-19 Pandemic on the Importance of Physical Activity. How is the transformation in primary care services? And in Hall B, we have Concurrent Session 6 with the topic Challenges in the Diagnosis and Management of Dengue Cases during COVID-19 pandemic. So here in Hall A, we have the beautiful moderator, Dr. Nani Cahyani Sudarsono, Sports Medicine Specialist. Dr. Nani Cahyani Sudarsono graduated as a medical doctor in 1987 at Universitas Indonesia, and in 1999, she's graduated as the Sports Medicine Specialist, Universitas Indonesia, and then she finished her doctoral program in Medical Science, Universitas Indonesia in 2018. All right, without further ado, please welcome Dr. Nani Cahyani Sudarsono.
Thank you, Master of Ceremony. Good afternoon for everybody in Jakarta time zone, and a very good evening to our speaker from Melbourne, Professor Lena Sanchi. It is an honor to be the host or the moderator of this concurrent session. Our concurrent session titled Learning from COVID-19 Pandemic on the Importance of Physical Activity, How is the Transformation in Primary Care Services? So we have here Professor Lena Sanchi from the University of Melbourne, who is a very distinguished researcher, usually prominently in the youth studies, but we can see here that she's also going into the research of the potential of technology to improve the mental health and clinical service system for youth. So without further ado, I welcome Professor Lena Sanchi to have the talk of transformation of health services with the use of information and communication technology. The time is yours, 20 minutes.
Okay, thank you, Dr. Cahyani. I'll just share the screen. Just a moment. Can you see the presenter mode? Is that correct?
We can see everything, Professor Lena. So we can see your note.
Oh, you can see the notes. Okay, no, that's not what I want to do. Just a moment. I'm so sorry.
Okay.
I'll just stop there for a moment. Okay. How's that? Can you see the notes still, or the?
Yes, this is perfect.
This is good. Okay. Thank you very much for the opportunity to speak with you today. I thought I was actually invited to speak about digital transformation of health services in general. So that's what I've prepared today, a little bit beyond the youth scope and a little bit before COVID and after COVID. So I hope that will still be of interest, but there will be some of our youth health examples in here and other examples from researchers in my department. So thank you for the opportunity. I'll cover a bit of background and just to give a summary of the state of digital health in Indonesia. I'm not sure if you're all completely up to date, but I think that we have a lot to learn from you, and I would hope that we can also have you present at some of our conferences on this topic. I'll speak a bit about the challenges of integrating data to achieve a learning health system that will improve quality for all patients, and also the place of co-design, human-computer interaction and simulation, and follow with some examples from our department. So we'll look at chronic disease prevention and management tools, the prediction tools for mental health management, risk and protective factor assessment in young people and management, and patient symptom monitoring, and a little touch on some of the issues around telehealth for teenagers and artificial intelligence. I am presenting in Melbourne, which is in the state of Victoria. We have 5 million people, and I'm on the traditional owners of the lands, the Wurundjeri people, and I pay my respects to their elders past, present and emerging. And if I was to fly to you this evening, I have saved 10 hours and 40 minutes doing that. But lovely to join you there in Jakarta. So, this is the University of Melbourne from an aerial view. It's 150 years old, our university, and this is a member of the department, our department, who I'll be talking with. And I'd like to highlight Professor Douglas Boyle, who is our Professor of Health Informatics, and Professor Patty Chondros, who is our biostatistician. And both of them underpin the digital technology that the rest of us in the research programs create for our patients. So we're just really starting on this journey in a big way in probably the last 5 years. I'd also like to acknowledge the 600 and more general practices, which are primary care practices that we work with in the community. A lot of them are in Melbourne, but many spread all across our state, and they participate with us in teaching medical students and in the research of many of these technological innovations. And this is a typical example of primary care or a general practice in Australia, where we have nurse reception and the doctor consulting with telehealth or electronic medical records if the patient is in the room. So now just to give a quick thumbnail sketch in preparation for this about the state of digital health in Indonesia over the last 5 to 10 years. And this is what I say that you will be leaders in this area. So digital health ecosystem is the fastest growing in Southeast Asia. And you have some challenges with a very large population of 263 million people spread around 17,000 or more islands. And the advantages you have, though, is that a third of your population is young. Even though they're aging, they're a much younger population than what we have. And with that brings some nimbleness and advantages in the take-up of digital technologies, especially in healthcare, with 100% mobile penetration and over 2/3 of internet penetration. And it's staggering that your annual growth rate for digital health revenue is over 60%. And they're predicting that from $85 million in revenue in 2017, there's an estimated $973 million to be expected in 2022. So there's a lot of scope. We yet haven't peaked in digital health revenue and technology in health. And this is similar to the international picture as well. So what are some of the areas that Indonesia wants to address? And this is from the book around the Australia-Indonesia Institute. These are very similar aims to what we have in Australia. So where you're challenged by lots of communities in different islands, we have lots of rural and remote communities that can't get to care. They may be several hours or a plane ride away from the nearest health service. So access to care is extremely important. Quality of healthcare is where our digital technologies also need to help. Achieving cost efficiencies, and this seems to take a big investment upfront before we reap return. Better efficiency of the healthcare system so that communication between sites is important and people aren't wasting time and funds having the same investigations and going through the same history all of the time. And by and large, the digital health technologies need to incorporate the patient's experience, as that will improve quality. So particularly cultural sensitivities, belief systems, look and feel appropriate to age group, all of those things are very important in the design of the new technologies. The World Health Organization focuses digital health really on 4 main areas: the interventions for the clients, and we know about the wearables and smart devices in measuring outcomes for patients and feeding it back to them, but also in the area of genomics and other sorts of precision tools that will be able to be fed into medical records to improve treatments. The interventions for providers are important to help them apply evidence-based guidelines and also other technical interventions and assessments at the point of care. And it's also very important for health system and resource managers to understand at a high level what is going on by reading the data from the systems and understanding where more resources are required. And this is true also if we try and wrap up data at a national level to understand the health of the nation and what sorts of other data collection and management we need to use. So there's sort of some general scene setting of where is digital health going and how might it transform care. Of course, COVID has absolutely accelerated this change. So where we thought we had 10 to 20 years, we've probably taken at least 5 to 10 years off that. So storage of data in the cloud has expanded. This is available now for artificial intelligence to allow direct-to-consumer feedback and modelling from lots of data in the cloud and design of interventions at the point of care. So with all this influx of data from everywhere, at least a third of it is generated by the healthcare industry. And what we're facing and facing globally is how do we harness all of this data and make plans to integrate it into the practical day-to-day clinical workflow of the clinician dealing with the patient. I'd like to present a few slides now illustrating some of the issues from Professor Wendy Chapman, who leads our Centre for Digital Transformation of Health. And Wendy's specialty is in natural language processing, which is really important as the electronic medical records are now captured, and trying to look for keywords and phrases to understand what's going on. That's one of her key specialties. So we take the typical problem that would happen in youth health or in any healthcare. We have, say, Fiona, who's 12. She's got a history of episodic asthma, and during the thunderstorm with lots of pollen, she becomes breathless, and her parents take her to the emergency department. Here she's stabilised and she's discharged with her asthma management plan written on paper. However, she's not really taking things properly. A few more high pollen counts happen and maybe another admission to hospital, and she's not really getting that much better. So her parents take her to see the local doctor, who doesn't have any record on her file at all of any emergency visits because nothing's being communicated. Fiona's lost her asthma plan. Her mother has an idea of when the asthma attacks occur, but nothing is written down. So they have to start from scratch and develop a new one. And we know from data that under 40% of GPs are familiar with guideline care, so the doctor will have to look this up. Families find care fragmented when they're discharged from hospital back into the community, and they don't tend to go to their doctors in the community proactively to look after their asthma. So we have quite a few barriers here. So how can virtual care and these sorts of innovations assist in this situation where we have Fiona here, who's capable of monitoring some symptoms, going to emergency room, and then what happens in the GP? It's all extremely separated and barrier forming. So how can virtual care help? And this is something that our teams are starting to work with. And I'm not sure if you have achieved anything in this area, but we certainly are still trying to solve some of the issues. So how could we do virtual care in this situation when we're delivering care to a distance? We have patient and carers in community. Hospitals have their own electronic medical record systems that are different from what's used in community. So there's a few players. So something could help if patients could have handheld devices that might record some of their symptoms and feed into a dashboard that enables their self-management. This would then be visible to the hospital specialists and inform their visit. Upon discharge, information could be uploaded onto the dashboard and sent directly to the primary care provider and prompt a visit. And if the primary care provider is in regular contact with the patient, the dashboards can be monitored and any decline in physical function could be alerted. And certainly this sort of information would make telehealth a much more appropriate and safe form of intervention. All of this is technically potentially possible, although there are barriers because of the different systems. But also we have to work through other issues such as privacy, personal privacy of data, the ethics of sharing data, and some of the technical aspects of not having appropriate access to broadband, and especially in some of these rural and remote areas. So technically possible, but we haven't managed to achieve it just yet. And a lot of the time because the record systems are different and don't talk to each other. The learning health system is certainly something we're investing in and trying to build up, where data is actually from all of these systems, and trying to link hospital data with primary care data to understand the patient journey is really important, and will highlight where there are gaps in care and problems in order to change practice and then monitor whether it's having an effect. And this is sort of something that's trying to be set up with our local hospitals to see how much of the hospital admissions we can prevent in primary care. So until we know where the basic problems are, it's hard to actually do that. But this is what we would aspire to. And this fits into the Wagner's model of caring for chronic care, where we're empowering patients to monitor their own care and self-care. We're ensuring regular follow-up and communication between care providers, and we need to provide decision support for the GP and others at the point of care, and harness a list of registry of patients with certain issues that can be monitored. So it's possible, but not yet functional. So where does co-design, human-computer interaction, simulation and prototype fit in? And this is something that in young people's health, we really have learnt that very early, often earlier than other groups, because unless they're involved in the design, they won't use the things that are made. And we use this now for every patient group that we deal with when we're forming technology. So we have an innovation hub in primary care where there is a place that people can gather, the co-production place, where the end users, be patients, clinicians, maybe hospital clinicians and others, might come together to understand what they need in a piece of technology. This is then built by our technical team led by Professor Boyle and tested in a laboratory environment, and other areas of expertise are watching on to see what might need to be organised around some of these interventions, particularly legally or technically with engineering or the ethics. We can feed in data and watch what happens, and then come out with a prototype that then can be put to testing. So that's the idea of laboratories. And we actually had a mock consulting room with a computer that ran some of the interventions, particularly for young people and for other groups, and is able to track eye movements and these sorts of things with the human-computer interaction techniques to see that the prototypes were working in the way that they're intended. So you actually watch what happens and tweak before piloting in the real world. And in diagrammatic form, we can also see we could feed in patient data and organise this space flexibly depending on what type of innovation we were having, but a big space for people to get together and decide what they need in an intervention. So I'll just move on to some examples from our department overall in this space. And these sorts of things are very helpful in also in times of telehealth and those sorts of issues. So firstly, with the data-driven quality improvement team led by Joanne Mansky and Nankervis. This team is trying to use data that's coming from the practice, matching it against benchmarks for care and feeding it back to the clinician to understand how they might have to alter their practice to better the care of their patients. And this prime program they're pioneering is called Future Health Today. So it's a system that enables preventative care and care of chronic illness according to evidence-based guidelines. It's deployed on the web, but it interacts with the electronic medical record seamlessly. So to the clinician sitting in their consulting room, it just is open in the background while they've got their patient file open, or when the files are closed, it's scanning their electronic medical records within the practice to pick up patients who might be at risk. The prototype is with chronic kidney disease, but they have modules for mental health, for other chronic illness, for cancer, and also for sexually transmitted infections. We're working on one of these modules to detect risk for STIs and pelvic inflammatory disease. So in the area of chronic kidney disease, the clinicians and the patients came together. The hospital clinicians were able, with the primary care clinicians, were able to deduce what investigations or presentations or physical examination might form the algorithm that would enable us to understand risk for chronic kidney disease in a certain patient, or whether they were not on appropriate management. So these were factored into an algorithm, and also particular devices and interfaces that the clinicians and the patients engaged with. And we tested in our laboratory. And what we come up with is that the clinician can be presented with a dashboard of patients who may be at risk of chronic kidney disease, because the Future Health Today technology can scan these out and bring them up into a list. And then the clinicians can call them in for a review. And at the point of care, there's an integration of resources such as guidelines for management that's delivered while the patient's in the room to the clinician to follow guideline care. They also get a readout of how their care has matched with best practice care, so there can be continual quality improvement going on. And this is a typical dashboard out of best practice. In this square, the system has highlighted 24 patients where a kidney health check is recommended, 8 with a likely diagnosis but hasn't been diagnosed yet, and 1 where they have had a diagnosis but it hasn't been coded. So each of these can be clicked on to give a patient list. The individual patient statistics are presented, and then the guidelines that are associated with management of those conditions are presented, along with the pathway for that particular patient. So the clinician knows exactly what they might do. And they can also turn off this guidance if they want to, if they know those things quite well. The second example is from the mental health team, the mental health research program led by Jane Gunn and Jane Perkis. Now, this is a tool that patients can fill in
I think we lost Professor Lena Sanji. Is that right? Organizing committee.
I beg your pardon. Oh, here I am. Okay. Sorry about that. I don't know what happened then.
You can pick up the rest of the presentation.
Thank you. Yeah, I don't know what I must have clicked on my mute button by accident. I apologise. So this piece of technology has algorithms in it that are based on 15 years of observation of patients in general practice that have come in at time A with the mental health symptoms, and they've been followed up over 15 years. So we know the trajectories, whether they've got worse, got better, got worse and better, or stayed the same. So these are built into this. The risk prediction is built into this tool, and upon completion, patients can be triaged into either requiring low-intensity services or high-intensity services. And when it has been put to a cluster randomised trial, it's actually shown quite efficient care. So there's cost savings in streamlining patients like this, and there has been a better mental health measures using the Kessler 10 measure. So this is very promising in the field of prognostic tools. But in the days of AI, that would cut out our 15 years of observation that we would need. So that will come. Professor Vicky Palmer, with some respiratory physicians and a company, has looked at COVID positive symptom monitoring at home. So in Australia, positive patients who are mild can get to take this app home, which prompts them to record their heart rate, their respiratory rate, their temperature, oxygen oximeter if they have one, they don't need that, and their mental health. And it actually gives them feedback on whether they should call their doctor or present to a hospital, or whether to do the prompt again. So this has been very helpful to use in conjunction with telehealth for the less serious cases in primary care. So in the Children and Young People's Research Program, my PhD student here has actually designed co-designed with young people and clinicians a way to talk to young people about their risk using a digital tool and their protective factors, and to come up with some management options and guidance for primary care clinicians. So this is administered via an iPad in the waiting room. It was co-designed with lots of young people coming together to decide what they needed and wanted to see in it. And they also designed the interface. So this is distributing the heads approach. It's asking them about how things are at home, with school or employment, their eating, sleeping and exercise patterns, their activities and friends, whether they're using drugs, cigarettes or alcohol, questions about sexual health and mental health, and their safety from abuse and road traffic safety and these sorts of elements. So they fill out this. It takes about 8 minutes in the waiting room. And then at the other end, the doctor gets the feedback in the form of traffic lights, where the certain areas that are concerning are lighted up in red. And if you press on these, you get what is going on, what you might be able to say to the young person, and where you might refer them, or some other resources you could provide for them to guide your practice at the point of care.
Excuse me, Professor Alina,
Yes.
we lose your presentation.
Oh, again. Okay.
You have to share it again.
Oh, I see. Sorry. Okay. Just a minute. Okay. Where are we? I'm a bit lost now. I have to hold on a second. There we go. Okay. Now we'll see if I can get that to... Can you see that properly now?
Yes, thank you.
Great. Okay, so that's we tried it in a general practice, and we measured patient-centered care, perceptions of patient-centered care. So here the lower ratings are better ratings. That means better scores. So the group of young people who used our iPads and our tool felt much better about communication, personal relationship with the doctor. They got better health promotion, and they were interested in their health much more than the treatment as usual. And what they said was they were very happy to interact with the device to talk about a lot of these sensitive things that they usually feel silly to raise with the doctor face to face. So that improved rapport and gave good discussion points. Lastly, on telehealth, there's been a lot of telehealth going on with teenagers and very little guidance on how to best do this. And we did a scoping review and really found most of the guidance is around video conferencing. And yet in Australia, I don't know about Indonesia, but in Australia, over 95% of the telehealth was actually by telephone in primary care, not with video. So we're not really sure of the impact of that. We know that from video conferencing, it is quite effective, and for some issues, adolescents and parents are quite accepting. Technical issues can be a barrier, and there is a lack of good evidence on some of the complexities we face in caring for adolescents, like ensuring they've got a private and confidential space and that they're safe, so we can't see them or look after them if we're asking them sensitive questions, and that can be a bit of a challenge. But there are some advantages in delivery from other sites other than in session. I led a special issue on innovative technologies with adolescent and young people's health, and it's quite a good paper. And a lot of the issues are around what's coming is the artificial intelligence world, which will probably come in the next 10 years and will shorten the amount of time to which we have to have data to get prognostic tools and prediction tools and those sorts of things. So any child born today will be getting born into the algorithm economy with lots of these unique terabytes of data. But what we have to be keeping in mind about this is the digital divide, because there are populations within our country and between countries who don't have access to digital technologies, so they're disadvantaged, and they're doubly disadvantaged in artificial intelligence. If their data is not being fed into the big data around the world, then interventions will not be adequately catering for them. So that's the equity and inclusion is a big issue for us with that. So on that note, I would like to say terima kasih, I think, which is thank you very much for listening, and I hope that was of some benefit. Thank you.
Thank you so much, Professor Lena. Do you still have time for discussion after the three speakers?
Yes, certainly. Yeah, I can hang on. Thank you.
Okay. Well, thank you. We are moving to the second speaker, who is Dr. Andi Kurniawan. He is a sports medicine specialist, and since we can see here that he is a practicing sports medicine physician, and he wants to share with us the implementation of active lifestyle using technology support. So hopefully this will give some insight to us regarding how we can use this technology to maintain our health. Dr. Andi Kurniawan, the time is yours.
Thank you, Dr. Nani. Good afternoon, everybody. Thank you for having me. And today I have very interesting topic that I will share my, sorry, wait, I will. Okay, my topic is implementing an active lifestyle with technology support. Okay, if we talk about the association between technology and physical activity, I think technology is a double-edged sword. Yeah. On the one hand, technology is contribute to increasing sedentary lifestyle, physical inactivity across the different age group in socio-economic level, especially in the COVID pandemic. If my kid's in the front of the computer, I don't know my kid is doing study or playing games, yeah. But in other hand, there is a good news from the using technology or smartphone application or wearable technology as an innovation solution to increase and promote the healthy lifestyle. Before we talk about the importance of technology, I think I will remind the dangers of physical inactivity, because we know that physical inactivity is a fast-growing public health concern, that the physical activity is contribute to number 4th global death attribute, the leading mortality. This is from World Health Organization 2004. But in 2012, the Lancet journal state that very interesting word, the sitting is new smoking, because inactivity is a global concern. It's more dangerous compared with the smoking. So we can conclude that the most dangerous place in your house is sofa in front of your television. Okay. The research also said that the average adult spend more than half of their day sitting, yeah, especially in the big city, from 7 a.m. driving, sitting, and then in the office always also sitting, and in the lunchtime they're not going, but just use the smart application to order the food, and then still sitting, and then after going back driving also, and after arriving at home sitting and watching television. Yeah, but in the COVID pandemic, I think whole of the day we are sitting. Okay.
Excuse me, Dr. Andi, could you please open your video?
Oh, I open my video. Sorry.
Okay, we cannot see you, but it's okay. You can proceed.
Okay.
Yeah, that's great. Sorry.
Okay. Yeah. The dangers of the physical inactivity, I think we can see from the very interesting research. Yeah, since 1953, the association between driver and conductor, the comparison between driver and conductor, the research from 31,000 London transport worker with the cohort study 30 years. After 30 years, the driver have increase in heart attack and also have incidence early mortality compared with the conductor. From the research, we can see that the difference between driver and conductor is about the physical activity. The driver just sitting, but the conductor doing walking from the front to the back, and then going up to collect the ticket and collect the money. sorry, next. Yes, the other research also said that I also very disappointed with this journal because sitting time is related to the cardiovascular even in the active people. If you 7 hours per week, you regular exercise 7 days per week, but if you sitting more than 7 hours per day, the hazard ratio of the mortality or cardiovascular disease is also still increasing. So we have 2 goals now, not only become active and also sit less also is very important. In COVID pandemic, I think in 2 years COVID pandemic uncertainty, we have know that everybody decrease in physical activity, increasing in unhealthy lifestyle habits, and also mental health issue, and also related with long COVID consequence. I think there is more negative effect of the COVID pandemic. But there is a positive effect in the COVID pandemic. We know that in the early 2000 or in the mid 2020, there is a bicycle boom. People in all around the world go to buy bicycle and go cycling. Yeah, go cycling. Okay, if we talk about the physical activity barrier, why we use the technology, from the American Journal of Sports Medicine say that there is a lot of physical activity barriers. The first one is I don't have time, the gym is too far away, more expensive, and I'm tired to work out. The weather is bad, exercise is boring, and I don't want to have a sore muscle. There is maybe some physical activity barrier that we find why people do not engage the exercise. Three-way technology can improve physical activity level. I think the first one is using by the activity tracker. The second one is using smartphone application or fitness apps or websites. And the third, I think the same with the last speaker, it's about the artificial intelligence for the next future. Yeah. This is the very interesting data also, high technology tools for exercise motivation, use and role of the technology such as the internet, mobile application, social media, and video. We can promote the knowledge and skill about from the website, from the application about the physical activity. We can also encourage the social support because with the application, we can connect it each other. And then we can also promote engagement with the technology. If we make some challenge or some competition, maybe the motivation is improving. And then we can promote the goal setting. We can encourage people to self-monitoring about the sleep pattern, about the active, about the target, about the steps, about the physical activity. And from the journal also reported that people who use the activity tracker had increased 47% physical inactivity. I have experienced last September. Last September to December, from July to September, we have activity. We have in the Petrosi, in the mining company, we create some activity. We create some program, Petrosi Active Challenge Space. We know that we make some step challenge, and we can see that the rookie leaderboard, the goal is only 10,000, but the number one is achieve 424,000 steps. So it's mean average 60,000 steps per day. So after 3 months, the number one, they receive 2,660,000 steps. So for the average is 30 steps per day. This is we conclude that not only the technology, the use activity, but the creativity of the program, I think also important to increase the physical activity. The other side is about the smartphone application or fitness apps or website. There is a positive effect of the technology related to the COVID pandemic. People is exercise at home because of lockdown of the COVID pandemic, and there is I think some journal or some literature said that the new word of the fitness, the word of fitness is digital fitness, because it's more flexible, anytime, anywhere, and from exercise from home, from the application or from the fitness website, we can grab more people into fitness, including who can follow the rigid schedule. And now people are integrating their life with the technology. This is also the reason why the digital fitness why growing, because it will be long time before many people are comfortable going to the big fitness center. They maybe more convenience exercise at home. That's why digital fitness is very increased. Okay, about the Swift, I think everybody know about the Swift, the application using the cycling. We can use the application, and there is a increasing of subscriber in the COVID pandemic. And also the superstar Beyonce and Jay-Z investing in the Peloton and also CLMBR. If you don't know about the Peloton is like software. Everybody said that the Peloton is the next Netflix in the fitness world. So they have many options in the Netflix. We can choose the many movie, but the Peloton we can choose many exercises. And the Peloton also sell the treadmill and also cycling, but they not only sell the cycling and treadmill, but the digital in front of the cycling and the treadmill. Then this is the CLMBR. This is like stair climbing, but not only stair climbing, but the digital in front of the equipment. This is the mirror like this. It's about artificial intelligence. People can use exercise at home, and mirror by acquisition by Lululemon. And this is the tonal, simple equipment people can exercise at home. Okay, this is about the applying artificial intelligence in physical education. This journal research said that the artificial intelligence can improve physical education and also physical activity in students, also in the young people. And last week,
it is time for us to adopt a new company brand to encompass everything that we do. To reflect who we are and what we hope to build, I am proud to announce that starting today, our company is now Meta.
Okay, we know that Meta, Mark Zuckerberg is the founder of the Instagram, Instagram, WhatsApp, and we know that Instagram and WhatsApp, because of the Instagram and WhatsApp, we can sitting many hours, But with the Meta,
Angar, fence. Don't be scared, there's hat. You seem like a natural.
Whoa, all right, that's a little too realistic. See you later, Lee. That was fun.
Good job, Mark.
Okay, this is about the boxing.
Let's make this a clean fight. One, two,
okay. VR, I think, is one of the future of the physical activity, to increasing the physical activity. Okay, from the other research, we can found that the high-tech tool for the exercise motivation, not only for the young or young adult, but also for the elderly. And then for the people with disease, from this result, the technology also associated with positive impact for the diabetes patient. For the elderly, using mHealth and eHealth technology also effective to increasing physical activity and decreasing sedentary time. So for the summary, as we know, physical activity is fast-growing public health problem, contribute to variety of chronic disease, health complication, including obesity and cancer. But in the COVID pandemic, have a negative effect in the decreasing physical activity related to the lockdown and work from home. But technology have a negative and positive impact of the physical inactivity, but there are a lot of evidence that technology associated with increasing physical activity and health outcome. Thank you very much, and thanks back to Dr. Nani Cahyani.
Thank you, Dr. Andi. Wow, this is quite a different point of view from you, and I think this can complement what Professor Lena already told us in integrating many things. And thank you for curating that for us, Dr. Andi. We are going to move to the last speaker, last but not least, Dr. Julkurnia Robi, or we usually call him Dr. Bobby. He is also a sports medicine physician practicing in Sport National Hospital and also in our Center for Sport and Exercise Studies in IMERI FKUI. So without further ado, I think we have the pre-recorded presentation of Dr. Bobby. Please, committee, show us the video.
Good afternoon, dear participants of the 6th IMERI Eyes on IMERI webinar. Assalamualaikum warahmatullahi wabarakatuh.
Excuse me, we cannot hear the voice.
First of all, I would like to thank the organizing committee for having me here. And I have agreed to share with you a title called Risk Stratification Assessment. Next slide, please. Risk stratification assessment is the first steps that we have to take before we engage ourselves or our patient in exercise program. So we have to consider this is a very, very important process, because in this process, we are trying to gather as much information as possible to give us the view about the risk that anyone can face during exercise activities. And in this pandemic situation, of course, the first thing that we have to consider is the risk for SARS-CoV-2 transmission or COVID infection. This is the situation that has been going on for almost 2 years, and it happens in all over the place around the world. And this is also a serious thing to consider before we start to exercise or we start exercise program for our patient. And the next thing that also important that I believe you all have understand that if we are doing exercise, we are also facing the risk of having an injury, musculoskeletal injury. And for example, maybe almost all of us have experienced ankle sprain during exercise. That's one of the most common injuries happen in exercise and sport as well. And the next thing that is also important to consider is about the cardiac event. Cardiac event is a serious problem, and it could happen unidentifiable to somebody who's doing exercise. That's why sometimes we see the news or in papers, maybe we can see that somebody died during exercise. That's what we consider as cardiac event. The other thing that also we have to consider is also the environmental related problem. You're exercising outdoor, that means you have the temperature, you have the humidity, you have the wind, and everything that might alter or that might affect your body while you're exercising, and that could lead to problems also. And the other important and serious thing is internal traumatic injuries. Maybe if somebody ride a bicycle and then involved in traffic accident, and then one part of the bicycle hit body parts, that might lead to internal injuries. And also we can face any problems during exercise. That's why we have to try to gather as much information about the potential of the risk that might occur during exercise. Next slide, please. Well, we can easily identify the sources of risk during exercise, and maybe we can look at this diagram. Let's say we have a SARS-CoV-2 as the first and foremost thing that we have to consider these days. And then we also have facilities that you might use or your patient might use during exercising. And then there is also equipment that you use or you wear. And then, of course, we have the activity itself. I mean, if you're engaged in running, it will give you different risks compared to if you have playing soccer as your activity. That will give you different risks. Also, the use of proper equipment, it will protect you to certain points, and you'll get safer by using the proper equipment. And the other thing is the individual who perform the exercise, because if you already know that you have certain disease or risk factors, then you are more likely to have a higher risk during the exercise. And with all of those things considered and put together, we can easily recognize the exercise, the risk exercise for each and every one of us. Next slide, please. So the risk stratification process is an effort to identify exercise risk in individuals. It means maybe your risk if you're doing your exercise, or maybe also the risk of your patient if you're suggesting your patient to do the exercise. So it goes for you and both also for your patient. And ideally, you can have this idea about how risky an exercise can be if you have performed the periodic medical checkup. So if you have a periodic medical checkup of your patient or maybe yourself, you can have a better idea about what risk that you are going to face if you're exercising. But periodic medical checkup is a process that considered as a costly process, and also time consuming. So maybe if you have a patient coming to you and asking for your permission or maybe your medical advice, if he or she is going to exercise, it will take some time before you can answer or give your advice. Because it involves the standard medical process like history taking, physical examination, and then you do supporting examination like lab examination and x-ray and everything. That's the standard process if we are going to use the medical checkup. And then if you gather all the information for that medical checkup, you should be able to categorize your patient or maybe yourself in the low risk, medium risk, or high risk based on the result of that medical checkup. Again, I would say that this process is an ideal process, but this is also costly and time-consuming process. So we have a simpler alternative available. It is not completely replacing the medical checkup, but it is a simpler version to help us to do this thing, this risk stratification thing, easier. Next slide, please. Well, I'm gonna give you one example of those alternatives. And in this alternative, we have Get Active questionnaire. It is questionnaire that endorsed by CSEP, or Canadian Society for Exercise Physiology. This is a really simple questionnaire. And this is only one example of those alternatives. We have other questionnaire as well. One of the most popular is called PARQ, Physical Activity Readiness Questionnaire. But this time I'm gonna show you this questionnaire, Get Active questionnaire. And it consists of 4 questions. And we also have a sub-question in the first question, asked. And as you can see, it is the information that they're trying to gather from you about certain condition like written in this questionnaire. If you have completed all these questions and the answer is no to each one of all questions, and then you can go to the next page that we can see in the next slide. Next slide, please. This is the second page of the questionnaire that you can fill if you completed the first page of the questionnaire and all your answer is no to all the questions. In this page, they're trying to gather the information about the kind of physical activity that you or your patient previously engaged to. And then they also give the general advice how to become more active, safely, of course. And then before we finish this questionnaire, we have to declare that we have given the right information, and then we have to sign the questionnaire as well. Okay, this is a simpler alternative compared to medical checkup. However, it is not replacing medical checkup. So after you or your patient have completed this 2-page questionnaire, you have to do certain follow-up to verify the information, especially if you have yes as an answer in the first page of the questionnaire. You have to dig deep to gather more information about the problem that your patient might be experienced in the past related to the questions in the first page. Okay, next question, please. Next slide, I mean. So after we perform the risk stratification process, whether by doing the ideal medical checkup or by doing a simpler alternative, we have at least 3 categories of health condition of our patient or maybe ourselves, and it has the implication as well. If you are considered as a low risk, it is free for you to choose the activity. That means you can choose a lot more option compared to somebody who has medium or high risk. In medium or high risk person, before they can choose, it is better for them to get a medical clearance, or sometimes we need also referral. We have to refer the patient to certain specialists to confirm the condition if they are about to engage in exercise. And especially for COVID-19 survivor these days that we have like 4 million in Indonesia of COVID survivor. Before the exercise, we need to make sure that the patient has a negative PCR test. And then if they have symptoms, whether immediately after they recover or they get tested negative, they should be consulted to get the clearance from the relevant medical specialist. I mean, like maybe internal medicine, pediatry, or pulmonology specialist. If you are lucky after the COVID infection and you only get a mild or asymptomatic, the condition that we have to make sure is that you can move yourself independently and you can maintain your balance during your movement. That's the criteria that we have to seek and we have to meet before we can let somebody to go into exercise after they survive from COVID-19 infection. Next slide, please. Other implication is if we have the disease like hypertension, lipid metabolism disorders, or maybe overweight, obesity, diabetes, coronary heart disease, and everything. Of course, it is strongly suggested to get a clearance from the medical specialist. And if needed, we can also refer the patient for further treatment before they can participate actively in exercise program. And also if you have injury at this moment, or your patient has injury or other musculoskeletal problems like say osteoarthritis, or maybe other injury to the knee, let's say, it is better for you to seek for medical clearance. And if needed, you can refer the patient for further treatment. Okay, next slide. I believe this is near the end of my presentation. In primary care setting, risk stratification is an essential and mandatory part of developing or implementing individual or group exercise program. I would like to emphasize this strongly. This is essential and mandatory. However, this process is often overlooked. Again, often overlooked. We tend to forget to do these things for our patients, even to ourselves, before we start exercise program. However, this process is actually not a complicated process, and this process is within the primary care doctor's authority and competence as well. So there should be no reason for doctors working in primary care setting to have confusion or have doubt to do the process of risk stratification. So I strongly advise you and suggest you, let's do this. Let's do the risk stratification for your patient, maybe even yourself, your family, before we start the exercise program. Okay, next slide. So I've come to the last slides of my presentation, and the person in this picture is considered as the modern father of medicine. This is Hippocrates, and one of the quotes that has been introduced by Hippocrates and his students is this quote, which is one death in exercise or sport activity is one death too many. And especially in these pandemic times when Indonesia has already lost like 4 million of its people due to COVID infection. I believe this is the end of my presentation. I would like to thank you for listening, and I hope I can answer your questions in the question and answer session. Assalamualaikum warahmatullahi wabarakatuh. Thank you.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Dr. Budi. So there was our 3 speakers, and I come to the conclusion that using technology can be very expensive, but then it has some opportunities. And looking at what Professor Lina Sanji developed, it's also complicated and comprehensive because we need to include so many experts. But then I got some insights that in the future, maybe we can have a special application for young people to educate about physical activity and its risk and its benefit, and also that application might can give periodic checkup. I think that's what we should go further. Since we still have not get any questions from the floor, I have the question for Professor Lina Sanji. So from your experience, how would you move forward with the youth to do more exercise for health using your experience in developing technology-enhanced services?
Yes, that's a really good question, and I haven't looked in depth around the exercise motivation in the way that Dr. Kuna has. But I think actually it's important for young people, and what we've seen in this lockdown, to maintain social connection. And we've seen a big rise in mental health issues and drop in motivation since the homeschooling has been there. And I think actually, and one question I was going to ask Dr. Andi was, rather than be at home with your technology doing exercise, I think we need to promote being together with your friends doing exercise and achieving goals together, and not in some virtual environment. So I think if we can work on motivation to kind of set goals and achieve those, but do that based on what the young people feel is important to them and in the context of a group setting, that could be one way to go. But definitely, you do get issues with young people who don't feel they're good enough at sport who don't participate. And then it's about finding any other activity that they might like to do that is, it needn't be a sport, but just moving around, finding some ways to do that. And that might be a conversation you start having with them around what they like, enjoy, what they like doing and those sorts of things. But yeah, I'd be wanting to encourage that more group-based activity.
Thank you. Thank you for the insight. So for young people, it's also about connection, and their devices can connect them, and enhancing movement through that is one opportunity, right? Okay, what do you think, Dr. Andi?
I agree, Doc, because in preparing in this webinar, I have a lot of ideas, to improving physical activity with the technology, and also I think for the future, because if we're looking for, I'm very amazing when I see the Peloton, like the Netflix, but the Netflix of the fitness. I think we have to have like channel like in the YouTube or in the video.com or in the like Disney, but there is a lot of exercise, physical activity for all age and all level participant. There is a physical activity or exercise for kids. There is a dance kit, hip hop kit, hip hop dance or for kids, and then there is like a exercise for osteoporosis. There is a Zumba Gold for elderly, and there is a exercise for of course there is a most famous workout, like Zumba, Strong Nation, or Pound Fit, or there's of course there's a lot of exercise, and especially for kids, I think we have to give creative intervention for kids to increase the physical activity and more fun.
Thank you, Dr. Andi. We got one question from the audience. To Dr. Andi, how would you educate young people with history of knee injury regarding the best exercise for them? Please respond.
I think related with Dr. Bobby's presentation, because related with the risk stratification, we have to know the history of the musculoskeletal injuries, and we have to modify the physical activity. Of course, they have to do the rehabilitation first, or to recovery first of the knee injury, or after already recover, maybe we have to give the step-by-step exercise intervention from the low impact, medium impact, and high impact, because about impact, not intensity. Impact is the joint impact, because if we're talking for the young people, they need high impact exercise to increase the bone mass, also the bone, also the muscle mass. So if young people have a history of knee, I think the important thing is to make sure the recovery, the rehabilitation, and after that, the exercise program will increasing step by step.
Thank you, Dr. Andi. I invite Dr. Bobby to give some suggestion regarding this question.
Yeah, you should seek advice from professionals to confirm your condition, and then you go with step-by-step approach, what you can do one thing at a time. Can I add something to Prof. Sanchi, please?
Yes, please. I believe he will be very glad.
Professor.
Yes, sure.
How do you manage to get the support from law and regulation in relation to technological enhancements that you and your colleagues do in University of Melbourne?
Yeah, that's a good question. We actually have a group within the law faculty. They work across law and engineering, and they're called the Centre for Digital Ethics and Artificial Intelligence. So they actually have formed a centre, and they've come together with expertise considering all the issues to do with digital health and digital technologies in particular. So they're particularly concerned around privacy and preservation of rights, but also effective and safe healthcare. So we work alongside them in development of our interventions, and they have the regulatory information as well as the privacy sort of ethical lens as well. So it happens that there's a cohort of them at the university that have expertise.
Thank you very much.
You're welcome.
Okay, so that explains, Dr. Bobby, how would a certain many databases can come together, and that was always the problem. We also have that kind of talk in the morning regarding the way forward for our government to enhance the telehealth, because we strongly need that, and we have primary care facilities that can be supported if we can use that wisely. But then there are many issues that still need to be overcome. And yes, I believe so. And also, I think I still have no question from the floor. I think one last question. We have still 1 minute. So if this is a self-monitoring patient, Dr. Bobby, what do you think the most important thing in using digital technology? You can see that Dr. Andi presented many interesting and might be expensive things. How can we use it wisely?
Yeah, the first and foremost is the thing that I've shared with all of you is about the risk stratification process. That's the mandatory process, and we have to do that, whether using technology or directly. We can use certain technology to do that, and then we have those information, and then we plan what we have to do next after the risk stratification. If the patient is in a good condition, he's healthy, he's willing to do, and then we can use the technology to help monitor the activity, not all the time, but in certain times, and maybe during the risky activities of the patient. I believe that would be beneficial for us, also for the patient. Thank you,
Dr. Bobby. Well, we have one more question for Professor Sanji. I hope you still would like to answer this. To Professor Sanji, telemedicine become more and more popular during the pandemic era. Do you think telemedicine should be maintained and promoted after the pandemic in primary health care?
Yes, I think it definitely should, because it works very well for some patients and for some clinicians. It's a financial decision and sometimes a bit of a political decision. So in Australia at the moment, they are going to continue it for certain groups for mental health issues and sexual and reproductive health. But for other complaints in primary care, they will only entertain the thought of telehealth if you've had a face-to-face consultation with the doctor in the previous 12 months. There's still a belief that face-to-face is much better, and for certain things it is, but the evidence would tell us that for other things, it's perfectly fine to have telehealth. But we have had some sort of people coming up and sort of scamming the system a bit, if you like. There's been an overuse of some telehealth in some areas, so they have to put some regulation around it. But for our rural communities and remote communities, for elderly people and others that find it difficult to leave work or leave home, I think it's really an important part of access to healthcare, and at least can triage people as to whether they need to come face-to-face or not.
Okay, thank you so much, Professor Lena Sanji. So we are already convinced that this is an important issue that we have to work hard to achieve that. And in the morning, they said that we have to work hard so telehealth can be as easy as mobile banking. They also come across many issues, and they can survive. So why not the health? So concluding this session, I would like to again thank the three speakers, Professor Rena Senchi from the University of Melbourne, Dr. Andi Kurniawan and Dr. Bobby as our sports medicine specialist and from IMERI FKUI. Thank you so much, and I give back the session to the Master of Ceremony.